Good morning, everyone, and welcome back to Bahrain Palliative Care and Oncology Conference. So we'll start the first session for today, which is mainly hematology. Our first speaker will be Dr. Mahsen Al-Dahrani, who is a consultant of hematology and stem cell transplant at King Abdulaziz Medical City in Riyadh. He finished his internal medicine Saudi board in 2005, followed by hematology residency in 2009 in Dalhousie University in Canada, followed by 2 years fellowship of hematopoietic stem cell transplant and lymphoma. He's currently the head of division of stem cell transplant and cellular therapy at King Abdulaziz Medical City, Riyadh. Welcome, Dr. Dahrani.
Assalamu alaikum. Sabah al khair. Good morning. Do you hear me? Hello?
Doctor, we can hear you.
Okay. So I will share the presentation.
Yeah, we can see the slide now.
Okay. Just let me make it. Thank you, Dr. Fatima, for the introduction, and thank you for inviting me to present in this elegant conference, palliative care and oncology, hematology. It's my pleasure to present today, and my apologies, I was not able to attend in person. But hopefully in the future I'll be delighted to visit Bahrain and collaborate or give another presentation. I'd like also to apologize, I don't have a camera in my computer in the office here, so I apologize for this. So I was given the task to present about stem cell transplant for sickle cell disease, which is a very interesting subject for us here. We started the program for adult transplant in 2014. Our colleagues in pediatric in our hospital here in Riyadh, National Guard Hospital, started before us. So far, we reach more than 350 cases, both adult and pediatric, with excellent outcome. So I will share with you some of our results and some suggestions for the transplant. So sickle cell disease is the commonest monogenic disease worldwide. It's very common in Africa, Asia, and America, and now with the migration of people, you see it everywhere. I'm sure in Bahrain you have a lot of patients also. The mortality of sickle cell disease improved over the last 2 or 3 decades because of introduction of many therapeutic options, basically like vaccinations, antibiotic, hydroxyurea, and the novel agents are coming, and the transplantation. But still, you see the survival care of sickle cell disease is less than other healthy population with the same age and gender. And for this, we have to look for other therapeutic or curative options to improve the outcome of sickle cell disease, like stem cell transplant or gene therapy. It is a common disease in Saudi Arabia, more than 80,000 patients distributed all over our country, but with the main focus, large population in the eastern province and in the southern province. This study by our colleagues, Dr. Abdurrahman Sultan from King Saud University here, they try to estimate how many patients from those 80,000 patients they need a stem cell transplant. And they take in consideration 3 indications: stroke, acute chest syndrome, recurrent VOCs. They estimated around 10,000 patients will need a transplant with these 3 indications only, and this is a huge number, and current transplant centers cannot cover this need, so the demand is very high. The story of stem cell transplant for sickle cell disease started a long time ago in 1983, where a patient in USA was diagnosed, a sickle cell patient was diagnosed with AML, and the patient underwent a transplant for AML from match sibling donor who was carrier. And fortunately, the patient was cured from both AML and sickle cell disease. This opened the door for transplant in sickle cell disease and hemoglobinopathies. And as you see here in the bar charts, there is an increasing transplant activity of sickle cell disease over years, but more over the last since 2010 and coming forward. And we expect to have more number of transplanted patients over years, and because there is disseminated knowledge to healthcare practitioner and also patients and their families about this curative option. Outcome in children, this is one of the earliest studies by Dr. Mark Quarter, multi-center study, phase 2 study. So they do transplant for pediatric patients less than 16 using myeloablative conditioning, which is a common conditioning regimen used in pediatric busulfan cyclophosphamide ATG, and they estimated they have survival 91% and event-free survival 73%. Which is at that time is maybe a good outcome, but currently we have much better outcome in pediatric patients. Most of the studies reported overall survival more than 95%, event-free survival or disease-free survival more than 91% in pediatric population, mainly using myeloablative conditioning. In our hospital, our pediatric division, transplant division, also they are very active in transplant for sickle cell disease, and they use myeloablative conditioning, thiotepa, bisulfan, fludarabine, and they have overall survival 100%, which is excellent, amazingly excellent. They did in this cohort 41 patients. They tried to do reduced intensity conditioning because they want to avoid the long-term complication of myeloablative conditioning. However, as you see, the curve of reduced intensity conditioning with event-free survival is much lower than the myeloablative conditioning. So in pediatric patients, myeloablative conditioning is a standard of care. It's associated with a high rate of overall survival, event-free survival, low transplant-related mortality, low rate of GVHD. The drawbacks is the long-term adverse effects, mainly infertility or other long-term side effects. And this, once the child grows up, especially when he come to adult, and we are following some of the pediatric patients transplanted with myeloablative conditioning, we see some of these adverse events. Can we avoid this adverse event by using reduced intensity conditioning or non-myeloablative conditioning? But as you saw the previous slide, when you reduce the intensity of conditioning, you will have more graft failure. However, the outcome of pediatric is much better than adult. This is a large retrospective registry-based study, 1,000 patients from ABMT, CIBMTR, and cold blood registry. The 5-year overall survival in this 1,000 patients, mainly pediatric patient, was 92.9%, and the overall survival children was 95%. In adult, it was 81%. So there is big difference in the outcome between adult and pediatric. And you see in this population, 20% mortality in adult is high. Why the outcome in adult is worse than pediatric? For many reasons. One of the reasons is the adult patients with sickle cell disease, they tend to develop multi-organ dysfunction with time, and this organ dysfunction will impair the tolerance to conditioning therapy and to the transplant. There is a risk of seeing this vasculopathy with complication related to that, risk of multiple transfusions, increasing risk of graft failure, impaired immunity, increasing risk of infection, and graft rejection. So how to mitigate this? Many studies, they try to use myeloablative, but they end up with poor outcomes. So most of the adult centers, they try to use reduced intensity or non-myeloablative conditioning. This is one of these conditioning. It is invented by NIH group. It is chemotherapy-free regimen. Basically, it is alemtuzumab, which is CD52 monoclonal antibody, target T lymphocyte and B lymphocyte, given over 5 days, 1 milligram per kg. This is a common drug that's used in the past for treatment of CLL, but more recently it's used in treatment of in preparation for GVHT prophylaxis pre-allogenic transplant, and recently it's used in treatment of multiple sclerosis also. So the other treatment here is TBI, total body irradiation, 300 centigrade, and the sirolimus is used as GVHT prophylaxis from day -2 or day -1 up to 1 year. And the source of the stem cell is peripheral blood stem cells. So the NIH group, they published their result on multiple occasions, and this is from 2014 JAMA study. Overall survival 94% and disease-free survival 88.5%. Many centers adopted this protocol, including Chicago, Canadian Center, our center. So as you see in the last line is our cohort 110 patients. We presented this in ASH 2020 as oral abstract, and we have similar outcome to what was reported for other centers, with overall survival 97% and event-free survival 87%. So this is our patient population that we did so far, and this was collected around 2 months ago, 229 patients. Median age 25, and the donor type, a match-related donor, 219 patients, mismatch-related donor, 2 patients, and haplo donor, 8 patients. So we use this protocol mainly for match-related donor. The most common indications is the recurrent VOCs, then followed by CNS events, followed by recurrent acute syndrome, but we did patients with AVN, hepatopathy, recurrent priapism, and nephropathy. Many patients, they have multiple, majority of patients, they have multiple indications for transplantation. And this is our event-free survival, 87.3%. So we have 13% either graft failure or a death, and overall survival 97%. We try to compare our result with our colleagues in pediatric division. So we show their outcome is 100% event-free survival and overall survival using myeloablative conditioning. And our protocol is non-myeloablative conditioning. So we have lower event-free survival, and this was statistically significant in favor of the pediatric regimen, but the overall survival was not different. If you compare this to the large registry-based study that I showed before, the pediatric overall survival was 95% and the adult was 81%. Here, we are almost approaching the pediatric result. So using non-myeloablative conditioning is the way to go for adult patients, or reduced intensity conditioning. Now, a graft failure is, as I mentioned, it's around 13% in this protocol and in many other protocols. And there are many reasons for graft failure and transplantation for hemoglobinopathies. So we try to look for these reasons, and we found like by univariate analysis, multivariate analysis, multiple reasons, but aluminization and having antibodies against RBC antigen on the donor cells is one factor that we find it is significant. And we try to correlate the overall survival with the presence or absence of graft failure. So if you have no graft failure, the overall survival is 98%. And if there is graft failure, the overall survival dropped to 74%. So we try to modify more the protocol to reduce the risk of graft failure and hopefully improve the overall survival. So we did different steps. The first thing, we know that the aluminization and RBC antibodies is a major factor. So we try to select a donor with full HLA match, ABO compatible, a donor that match even with the RH, and a donor that the patient doesn't have antibody against his RBC antigens. If there is if there is ABO incompatibility, we prefer major ABO over minor ABO incompatibility, and other factors to consider: pre-transplant hydroxyurea to maximum tolerated dose for 2 months, try to use, in this protocol, they use mega dose of CD34, more than 10 million. So this is only for this protocol. There are other reduced intensity protocol where they don't exceed this number. So you will not get a lot of GVHD, and optimize the sirolimus level post-transplant. Now, not every patient will have a donor, match-related donor. If you look to North American and European studies, the chance of finding match sibling donor is only 18%, and match unrelated donor is less than 18%. In our center, for all indications, malignant and non-malignant indications for transplant, the chance of finding match sibling donor within the family is 60%. And specifically for sickle cell disease, for the cases referred to us, 57% of the patient, we find a match sibling donor within the family. So you have here maybe, like at least in our situation, 40% of the patient, they don't have match-related donor. And in Western countries, around 80%, they don't have match-related donors. So the next option will be match unrelated donor, and we can get match unrelated donor through local registries or through international registries. There are around 40 million registered donors in all registries around the world. In our country, we have two large registries, one in National Guard, 80,000 donor, and one in King Faisal Specialist Hospital, close to that 80,000 donor. So there is a high chance to find unrelated donor. However, the result of unrelated donation in sickle cell disease is not very good. At least in this study, prospective study from USA, using for pediatric patients using fludarabine, melphalan, alemtuzumab, the transplant-related mortality was high, 28%, and the chronic GVHD was 62%, 38% extensive GVHD. So based on this study and other studies, it's a finding of favor this option, match unrelated donor, except to be done in a clinical trial. The next option is haploidentical donor. Every patient will have a haploidentical donor within his family. You know, haploidentical stem cell transplantation is associated with very high risk of graft versus host disease and graft failure. So how to mitigate this risk? You have to deplete the graft from the T lymphocyte. And there are two strategies. The first strategy is to give post-transplant cyclophosphamide on day 3 and day 4, which will deplete the allo-reactive T lymphocyte. And the second strategy is to deplete the T lymphocyte before infusion to the patient by selecting CD34 or depleting T cells and B cells. But you should have this machine called CliniMax and the kits, which is not available in most of the centers. So most of the centers, they use the first strategy, which is T-replete post-transplant cyclophosphamide, including our center. So this post-transplant cyclophosphamide was invented by Johns Hopkins group. Basically, they give fludarabine cyclophosphamide TBI, reduced intensity conditioning before transplant. Then they do post-transplant cyclophosphamide 50 milligram on day 3 and 4, plus MMF and tacrolimus. They did for sickle cell patient transplant using this protocol, and they did transplant for match sibling donor. The graft failure was 0%. For haplo donor, it was 43% graft failure. So they try to modify the protocol to optimize reduce the graft failure rate. So what they did, they increased the TB in the Hopkins. On the right side, you see they increased the TBI from 200 to 400 centigrade. They doubled the dose of the TBI. And another approach, European and Vanderbilt, they added Thiotiba and ATG to this protocol. So this is the Vanderbilt and European protocol. It is a multi-center consortium, 12 centers from 6 countries. In our kingdom, there are 2 centers, our center, National Guard, and King Faisal Specialist Hospital. So it is the platform for Johns Hopkins fludarabine cyclophosphamide TBI 200 plus post-transplant cyclophosphamide, and we add here ATG 4.5 milligram per kg and 10 milligram per kg. The first publication came in 2019 by Dr. De La Fonte, where less number of patients, 15 patients, event-free survival 93%, overall survival 100%. When more patients and more centers were joined this study, you see there is drop in overall survival and event-free survival. However, still this is maybe acceptable outcome, and there are some effort to improve on this outcome. There will be a presentation about this in the upcoming ASH in December. There are many studies used post-cyclophosphamide haploidentical donor, but the general theme here, you have excellent overall survival, very low rate of GVHD. And pediatric population, they said there is increased risk of graft rejection. So there are some modification by giving high-dose hydroxyurea and hypertransfusion before transplantation to reduce risk of graft rejection. The other study is the haploidentical transplant using T-cell depleted product by depleting the T-cells before infusion by the Clinimax machine. Also, excellent outcome, but the main problem here is the availability of the machine and also the risk of viral infections post-transplant because you deplete all the T and B lymphocyte. So what are the indications for allogeneic transplant, at least in our center? Any patient with CNS events like stroke, TIA, silent infarct, CNS vasculopathy, impaired neurophysiological function, abnormal brain MRI, we take them as a strong indication for transplant. Any patient with end organ damage, sickle nephropathy, hepatopathy, sickle lung disease. Now, this is a very difficult situation. You cannot do transplant for patient with this condition, except by using non-myeloablative conditioning like this protocol that we are using, alemtuzumab and TBI, because if many of these patients will not tolerate more than that conditioning regimen. And we did a few patients with these three indications with good outcome. Recurrent acute chest syndrome defined by 2 or more acute chest syndrome in the last 2 years, despite on best available therapy, which is hydroxyurea, maximum tolerated dose. Recurrent VOCs 2 or more per year, despite on best available therapy, which is hydroxyurea, or one of the novel agent. Multiple joint AVN, recurrent priapism, regular RBC transfusion therapy to reduce complication or symptoms, red-cell alloimmunization. Now, this is one of the most difficult indication for transplant because it's associated with the risk of graft failure, poor quality of life. This is a table for indication from one of the clinical trial. So it's almost going with our standard indication for transplantation. Now, one question will come, should we wait for a child to develop complications and take him for transplant? Why not to do transplant before the child develop any of the complications? So there's pros and cons for this discussion. So going for that is low risk of dying, better transplant outcome when it's done at a young age before having organ damage and alloimmunization. Every 1 year increase in the age at transplant, 9% increase in treatment failure, death or graft failure. Against that, very low risk of dying with the current supportive care. There are novel drugs coming, further improvement in sickle cell disease. Newer medication may make curative therapy less important.
Dr. Mahsen, 2 minutes remaining.
Okay, so maybe so this is graph for indication for transplant. Yellow boxes is the standard of care. Green boxes is those possible indication patient who have recurrent splenic sequestration, baseline hemoglobin less than 7, rare erythroid group. So in conclusion, with limited number of transplant centers, priority to patient with the approved indication. Transplant at young age with matched sibling donor and myeloablative conditioning provide the best result. Acceptable outcome in adult patient using RIC or non-myeloablative regimen in adult. Haploidentical donor transplant is the next donor choice based on the current evidence. Thank you very much.
Thank you, Dr. Mahsen, for this informative lecture, and hope to see you in person soon, upcoming event. Now for the next speaker.
For the next speaker, Dr. Iman Farid, Professor Emeritus, Faculty of Medicine, Bana University, Egypt, Senior Consultant, Head Laboratory, Al Salam Specialist Hospital, Associate Professor of College of Medicine, Department of Microbiology, Immunology, AGU, previous Head of Immunology Section, Pathology, Department of Salmonella Medical Complex, constructed and hid HLA typing flow cytometry service in Salmania Medical Complex. Please, Dr. Iman.
Assalamu alaikum. Good morning, everybody. Thank you for inviting me, such a prestigious conference. And as you know, the title of my talk is about flow cytometry in hematological malignancies. So the outlines of my talk are summarized in this slide. Actually, I will go first on the principles of flow cytometry. Then I will share with you some and present for you some cases, immunophenotyping diagnosed by flow. And then lastly, I will share with you some selected 2022 articles for this topic. So to start with, if we talk about flow cytometry, the flow cytometer is a strong instrument that is present in some labs now, but really it is useful for diagnosing malignancies. It's a powerful tool for multiple parameters, and it works on individual cells. As you see the word flow cytometry, flow means the cells are flowing, cytocells, and metry that we are measuring these cells. Cell populations are measured by different antigens, and there are a lot of panels or monoclonals that are used and coupled with the fluorochromes. You can look at this instrument as a tidy, as you can see here, a tidy instrument on the left side, but actually inside there is a lot of technology that is working on. In Salmania Medical Complex, we started this service in 1995, and we were serving all Bahrain. It was the only flow cytometer present in Bahrain. Of course, by the years, we had progress in the machine, and the advanced one is available now. So historically, if we talk about the idea of the machine, it started by years back by counting blood cells, cell sorting, and then after that, there is the photoelectric techniques. And in 1949, there was the Coulter counter. And then came in 1965, the first flow cytometer instrument capable of sorting cells. After that, in 1968, there was the fluorescent-based flow cytometer. And then there was the achievement of having cancer cells from normal cells. And lastly, the Becton-Dickinson had the fax machine, which was the first one, and this was in 1970. And currently, there are machines, flow cytometers, with 5 lasers and 18 fluorochromes. What is important in this machine is to use the sample, a proper sample. So the sample must be a single cell suspension. Always RBCs are lysed, so we have to get rid of the RBCs. And as I told you, if you have a single cell and a good sample, you will have a good data. Always there are the panels of monoclonal antibodies that are used. These fluorochromes have different fluorescence, and that's why we say this is 5 color, 8 color, and we mean by color the fluorochromes. 3 major components, the fluidics, the optics, and the electronics. So you hear always about laser. You can ask anyone, which your machine flow, how many lasers? So the laser is something important in this machine. There are the optics and the electronics. You can see in this slide how the cells go down one after the other in a fluid sheath, and perpendicular to them is the laser beam where we find scattering of light occurring. So this slide shows you the journey of what? Of the sample, starting from sample preparation and taking the sample from the patient, then preparing the sample for the machine. And here you have the cells going down, as I told you. And then we have the analysis. And analysis is very important because you have the report according to the analysis and the finding. And please take care here that what you see on the microscopes as cells are nothing but here dots, as you can see in this slide. So they are population of cells and dots that we see on the histograms. You can see here the lymphocytes, monocytes, granulocytes, how they are gathering together in population of cells. Laser stands for the light amplification, stimulation, emission, radiation, and the different colors or fluorochromes are important. So this slide just shows you in brief what happens. Cells go down on the flow, perpendicular to them is the lasers and a lot of filters and detectors. And data analysis is something important because the machine has a list-mode data file with values of every parameter of cells there. So you can imagine how millions of cells are there and informations about them. So a powerful computer is actually needed and necessary to analyze these data. Even now, some flow cytometers have the sorting option. So you can see in this slide how, for example, stem cells can be just taken away from the sample. Now I move to the applications. Applications of flow cytometry is in both research and diagnosis. They can be put in major titles or fields of science, whether immunology, transplantation, and hematology, and among the hematology, hematological malignancies. So leukemias and lymphomas are something important that we work on in a diagnostic lab by the test called immunophenotyping. Always there is the list of markers that are used. Under the microscope, the hematopathologist easily says this is a leukemia, there are blasts, but to answer in which lineage this is it an ALL or AML, is it B or T, and which type of AML? All this is done by the flow cytometry quickly. In less than 2 hours, you can get the reply. Another application which is coming now in many guidelines is the MRD, the minimum residual disease. Residual tumors, if they are in the sample or the patient has. So flow cytometry can show something like that, the MRD, if it's positive or not, before these cells are showing up as relapse. So as I told you, what is seen under the microscope with different types of WBCs is nothing but population of cells and dots in the flow. So if you have a case where you have lymphadenopathy, a condition that is very common in many specialties, by taking a fine needle aspiration of a lymph node or even a biopsy, you can answer, is it a lymphoma, reactive, leukemia, metastasis? So it's really a useful and powerful tool. Another application is the CSF. Flow cytometry immunophenotyping of CSF is very useful, not only for the staging of cases, new cases, but actually also when a case is already diagnosed and then there is any changes clinically and CSF is taken. So if there are cells in this CSF, we can, by the flow, say if they are blasts or reactive cells, is it a viral infection only, or it's something related to the disease. Same applies for pleural fluid. Many cases that are having pleural fluid, presence of the cells there, you can answer the question, is it lymphoma or reactive? Same applies for the acidic fluid. So what is the sample? What is the sample that is sample of flow cytometry? Definitely it's a Bemwara aspirate, but also peripheral blood, acidic fluid, CSF, pleural fluid, fine needle aspiration, even tissues. Tissues or biopsies can be crushed down into cells and used. I mentioned the CDs and the monoclonal antibodies, the panel of test markers that we use. These markers are already present on normal cells. So how to use them in order to diagnose? Either it is aberrant expression or the addition of these markers together in cells that are not expected to have them. All these have improved. You cannot work with the flow alone, but you need always the morphology and the cytochemical staining in order to have the best diagnosis. Now I am moved to the cases that I'm going to present for you. In leukemias, I chose pre-B, ALL, TAL, AML, CLL, and in lymphomas, the B-cell lymphoma and the T-cell lymphoma. So let's start by the acute myeloid leukemia. I need to remind you first about the myeloid lineage, where we have the different stages, and according to that, we have the cluster, the CDs that are expressed in these different stages. So let's go to the first case. The first case is a history of a 65-year-old man with pancytopenia and numerous circulating blasts. So you can see that this history is going to be shared by many of the cases. And then let us see what is the immunophenotyping. The immunophenotyping diagnosis of this case is acute myeloid leukemia. And you can see that the blasts, and here on the left, I would like to show you that the cells are in the form of populations, and this is the blasts. And then you have seen the different markers that are used, the CDs. Now, for example, here, it is positive for the 34 and the 13, and it is negative, for example, to the 11B here, but positive to the 34, and so on. So the case here, the blasts are expressing the CD30, the myeloid markers, 34, 117, the 13, the 33, and the HLA-DR, and negative to the other tested markers. The second case is a history of a 7-month-old infant with skin lesion and numerous large circulating blasts. And the diagnosis is acute myeloid leukemia with monocytic differentiation. The blasts are expressing the myeloid markers 34, DR, 33, and 13, and 11B, together with a monocytic markers 64 and 14 and CD4. And that's why it is with a monocytic differentiation. As you can see here, the different, here you have the 15 with the 34, and you have the 14, which is a monocytic markers with a 64, brightly positive. The third case is a history of a 27-year-old man with pancytopenia and circulating bilobed blasts with occasional ore rods. The blasts are expressing brightly the myeloid markers 33 and 30, but partially 117, 11B, 15, and 38, and negative for the DR and the 34. The diagnosis is acute promyelocytic leukemia. Now I move to the B-cell neoplasms. So first, we have to memorize the B-cell maturation, 4 phases, the precursor B-cell, and then we have in the bone marrow, then we have the interfollicular phase, the follicular phase, and the perifollicular phase, with different markers, CDs, according to these different phases. So the first case is a history of 5-year-old boy with anemia, thrombocytopenia, and leukocytosis, a very, very common presentation in childhood leukemias, and this is a precursor BALL with our abnormal B-cell precursor, positive for the 19, the B-cell, CD10 and 34, which goes with the precursor, and partial CD20 and CD9, negative for the rest. The second case is a history of 70-year-old man with lymphocytosis and lymphadenopathy, and the diagnosis is CLL. And here, what is the key immunophenotypic expression is the co-expression of the 19, 5, and 23. So 19, 5, and 23, if we find them together, it's a key immunophenotypic markers for the CLL. 19 is a B-cell marker and CD5 is a T-cell marker, but having them together and the 23 gives us the diagnosis of the CLL. The third case is a history of a 50-year-old male with lymphadenopathy and atypical lymphocytosis, and the case is diagnosed as mantle cell lymphoma. There is a monoclonal lambda restricted B-cell population, and always, of course, when we say lymphoma, then we look to the light chain expression kappa lambda, which is normally 2 to 1. So if there is a light chain restriction, monoclonality to either kappa or lambda, this diagnoses the lymphoma, and then we go to the subtyping. So in this case, we have the 19 and 20 bright and 5 and FMC7. And as I told you, this is a case of mantle cell lymphoma.
Dr. Iman, first 3 minutes.
Inshallah. Then we have the history of a 30-year-old man with lymphadenopathy, a follicular lymphoma, And then we have here a CSF sample of a case that is diffuse large B-cell lymphoma already. And this is diagnosing that it is already involving the diffuse large B-cell lymphoma. Burkitt's lymphoma is diagnosed by having the lambda chain restriction, and we have the CD10 and 19 together with the CD20. Hairy cell leukemia has the 103 expression, which is a marker for hairy cell. And in plasma cell neoplasm, of course, we have the 33, 38, and 138 that are there. The T cell neoplasms have the T cell markers, and T lymphoblastic leukemia lymphoma, and another one of T lymphoblastic leukemia lymphoma, and this is a T cell leukemia. And what is recent about the flow cytometry is the presence of the multicolor. And in Euroflow now it reached to 10 colors where we have them in a certain strategy using single tubes. About the interesting cases, this is a case of in Cancer 2022 published, talking about the sample preparation and its importance. Another one talking about quality assessment, which is also something important in flow cytometry. And this is a case about AML, talking about the new knowledge about the molecular pathogenesis and how it is important now in the new therapies. And here we are talking about the era of precision medicine, where, as you know, precision medicine is something important. What is useful for one patient will not be useful for another one. And here is talking about the review of lineage from B to myeloid during treatment. It is not known how the lineage is changed, but they are thinking that using B-cell specific markers, CD19, can have a role in that. This is talking about the MRD in multiple myeloma. And this is my last slide showing you the flow cytometry user's guide, which I chose to you in case that anybody is interested of that. And here is a picture of the laboratory staff that are working in Salmanea Medical Complex in serology immunology, where the flow cytometry service is given. And this photo is taken on 14th June 2022, my last working day in Salmanea Medical Complex. Thank you so much.
Thank you, Dr. Iman, for this nice presentation. Now we have this next speaker, Prof. Tharwat Wajdi. He's currently Prof of Hematology in AGU since 2019, Consultant of Hematology and Hereditary Blood Disorder Center and Hematology Department since 2019. He will present a presentation about sickle cell disease and pain management.
Good morning, everyone. Sorry for time factor. I'll try to summarize the talk so much we can finish on time. Today we will discuss management of pain and sickle cell disease. Okay. As in the definition of pain, type of pain, pathobiology of pain, sickle cell disease, pain management medications, guideline of acute pain management, and targeting novel mechanism of pain and sickle cell disease. At first, pain is defined by International Association of Study of Pain as unpleasant sensory emotional experience associated with actual potential tissue damage. The first definition of neuropathic pain in 1994 is pain initiated by and caused by primary lesion or dysfunction in the nervous system. This definition changed, new one in 2005. Currently, there is nociceptive pain and neuropathic pain. Nociceptive pain due to stimulation of primary nociceptor nerve endings, non-nociceptors, that excited or sensitized with the signal potential tissue damage, and neuropathic pain defined as pain due to lesion or dysfunction of nervous system. Type of pain, the main three types: neuropathic pain, nociceptive pain, and lastly, other pain now defined by nociplastic or algoplastic pain. Nociplastic pain defined as pain that arises from altered nociception despite no clear evidence of acute or threatened damage causing the activation of peripheral nociceptors or evidence or disease lesion. or lesion of the somatosensory system causing the pain. Nociceptive pain, the example is tissue, I think, is it is arise from various kind of trouble in tissues reporting to the brain by nervous system as pain, strain, injury, nausea, tumor, inflammatory arthritis. Neuropathic pain is a type of pain associated from damage to the nervous system itself, often associated with sciatica, neck pain, radiculopathy, trigeminal neuralgia, and diabetic neuropathy. Other classification can be divided either somatic from the skin, muscle, bone, and joint, or visceral. This other type, this psychogenic pain, now is another term that sometimes used to describe pain. There is not an official diagnostic term for pain, but sometimes used to describe pain that associated with some degree of psychological disturbance as emotional pain, embarrassment, anger, depression, and anxiety, and post-traumatic stress disorder. Other classification can be divided into acute pains that normal and temporary response to alert body to injury, or chronic pain that lasts for more than 2 weeks or more, or breakthrough pain, referred to episode of acute pain that occur during analgesic medication of chronic pain. For pathology of pain, just to know that sickle cell disease inherited disorder appeared in the Western literature 1910 by Dr. James Herrick. He would describe the case of severe malaise and anemia in 20-year-old dental student. He summarized that the cause of the disease may be some unrecognized change in the red cell corpuscles, which is sickle cell. Now we know that sickle cell disease mainly started in the sub-Saharan Africa, in endemic area of malaria endemic area, then distributed over the world. Is the main more than 5 million in sub-Saharan and 1 million in India, and other distributed all over the world. Currently estimated 300,000 affected babies are born each year. More than 80 of them are in Africa. The number of sickle cell disease patients expected to be more than 14 million by 2050. And now the number is about 6 million only, and the sickle cell rate is 300 million. And 300,000 children born each year with sickle cell disease. The pain may not specific to area, but can be in the arm, thigh, shin, low back pain, knees, everywhere. And the pain may be nociceptive, neuropathic, or mixed. The pathophysiology, we will enter here. Here's the whole, change of red cells from normal red cell corpuscles to sickle cell under in a special situation as infection, acidosis, hypoxia, and others. Changes of sickle cell. Sickle cell because there is decreased the deformability of these cells with macrovascular obstruction, especially arterial. These lead to endothelial adhesions and further obstruction with endothelial damage and hemolysis. This hemolysis lead to free heme and decreased nitric oxide, causes both acute manifestation act as vaso-occlusive crisis, acute chest syndrome, liver splenic sequestration infection, or chronic complications as progressive organ damage, brain, lungs, spleen, kidney, and the heart. This is the main pathophysiology. Pain is a hallmark feature of sickle cell disease, which can start in infancy, leading to hospitalization, reduced survival, and poor quality of life. The pain in sickle cell disease is unique because it is unpredictable and recurrent episodes of acute pain due to VOC, in addition to chronic pain experienced by majority of adult patients on daily basis. This episode of pain is the most common acute morbidity and leading to acute causes of hospitalization and emergency visits. The molecular pathophysiology here, this is summary of the previous. is hemolysis with the release of free heme and decreased nitric oxides. This leads to what's called sterile inflammation that causes the tissue damage in sickle cell disease. The pain crisis, hypoxic ischemic reperfusion, inflammation, and hemolysis, all these cause mast cell activation with the release of neuropeptides substance P and the other cytokine release. This through the peripheral nerves to the dorsal root ganglia and spinal cord send pain signals to the brain. On the brain, there is sending brain, there is pain modulating system originating from the higher center of the brain, play a critical role in the perception of pain by inhibiting or amplifying nociceptive input through neurotransmitter, serotonin, dopamine, endogenous opioid, gamma aminobutyric acid, and others. These modulated signals are processed in the brain, responsible for sensory perception and for eliciting affect, emotion, and memory. This is important because recently attention has been focused on perception-based component of pain, their ability to reduce pain via non-pharmacological behavioral techniques such as guided imagery, mindfulness, and relaxation training, hypnotic, and cognitive behavior therapy. As we know, pain management medication divided into opioid and non-opioid analgesic. Non-opioid including acetaminophen, pervalgan, non-steroidal including non-steroidal anti-inflammatory, and other which has also antiplatelet effect. Antidepressant medication, a selective serotonin and norepinephrine reuptake inhibitor, particularly duloxetine, and tricyclic antidepressant, especially amitriptyline, all demonstrated efficacy in a variety of neuropathic pain condition. They are indicated for also for other psychological conditions as a depressive state. Anti-epileptic medication are also known for their analgesic properties through their mechanism of action of lowering neurotransmitter release of neuronal finding. The most common are pregabalin and gabapentin. Gabapentin used mainly in post-herpetic neuralgia and neuropathic pain, while pregabalin used in neuropathic pain associated with diabetic peripheral neuropathy or spinal cord injury. Oxacarbazepine and the carbamazepine used in trigeminal or esophageal glossopharyngeal neuralgia. Now, local anesthetic lidocaine is FDA approved for a treatment of post-herpetic neuralgia and recommended also for peripheral neuropathic pain. Opioid are broad class of medication. They have among the most controversial analgesics. This is important because there is controversy about this opioid analgesic, particularly because their potential for addiction, tolerance, and side effect. So, although this indicated for acute and chronic pain treatment, CDC is the Center for Disease Control and Prevention, recommend that only if expected benefit for the both pain and function outweigh the risk, clinician should prescribe opioid at the lowest effective dose and for the shortest expected duration to treat the pain severe enough to require opioid. For that reason, there is different guidelines for pain management. There is represented from CDC, NCCN, ASCO, ASH, and FDA are made together trying to put guidelines for pain management. They concluded that the meeting reveals that although each guidelines varies in the intended patient population, target audience, and methodology, there is no disagreement about among recommendation when applied to the appropriate patient clinical situation. This means that each institution or each country, and according to the type of patient, can invent special guidelines for pain management, and this can be agreed by the committee. This is common theme that use of they pointed to use of non-pharmacological therapy and non-opioid therapy, assessment of individual likely benefit risk prior to initiating opioid, development and implementation of strategy to maintain patient safety and minimize risk of opioid misuse, continue monitoring and regular evaluation of the effectiveness and necessity of opioid therapy, patient education on the goal of treatment and use of opioid analgesic, optimizing adjuvant analgesic psychological support and interventional therapy, graduate opioid dose reduction when indicated to prevent withdrawal symptom. The National Heart, Lung, and Blood Institute of U.S. Department published guidelines in the evidence-based management of sickle cell disease in 2014. This is considered as a core for different guidelines, which might be modulated or changed by different institutes, but this is a core. It depends only on the WHO analgesic ladder, which start with non-opioid analgesic, weak opioid, then strong opioid, and lastly, BCA or nerve block, or epidural and others. This is the recommendation I will not discuss, but 17 items for recommendation. The summary to divide the pain to mild, moderate, and severe. We start with supportive treatment and paracetamol and low non-steroidal anti-inflammatory for mild and moderate pain. And for severe pain, we can start opioid therapy immediately. Opioid remains a common treatment for acute and chronic pain because they are required comparatively larger dose for longer duration compared with this use analgesic pain. In other conditions, optimizing benefit and to minimize adverse effect are clinical. Opioid adversely alter red cell deformability, dehydration, rheology, and membrane structure. This is the drawback of opioid. It also chronic morphine treatment led to exaggeration of renal pathology, impairment renal function in sickle cell mice, and this is documented. The mechanism of action of opioid through mu-opioid receptors, mediator mechanism, function of opioid-relevant sickle cell disease, binding these opioid to mu receptors activate multiple signaling pathway that may exaggerate several complications, including increased vascular permeability, endothelial specific activity, stroke, vasodilation, opioid tolerance, retinopathy, renal pathology, and hyperalgesia.
Dr. Tharwat, 5 minutes remaining.
I'm sorry. If I'm typing. We'll about this. Targeting novel mechanism of pain in sickle cell disease. VOC is important as a cause of recurrent admission and emergency. And a patient with VOC more than 4 times per year can increase mortality. What's important, mechanism of target therapy. We can use 2 approaches to taking disease-modifying therapy and analgesic that target CNS. Targeting pathophysiology, targeting genotype with bone marrow transplantation or gene therapy, or targeting different steps of polymerization or vaso-occlusion and inflammation. The most common drugs, voxelotor, approved drugs now, FDA, bind to H hemoglobin S to stabilize the oxygen and prevent hemolysis, and crizanlizumab with B-selectin inhibitors that inhibit adhesions and decrease thromboembolic events, and L-glutamine, which decreases oxidative stress of the cell. Also, hydroxyurea, we know increases hemoglobin F, but it also improves red cell dehydration, neutrophil, reduce red cell count, and reduce leukocytic adhesion and pro-inflammatory condition. Recently, omega-3 is a promising therapeutic agent to prevent vaso-occlusive crisis. The targeting analgesic mechanism included cannabinoid-based mechanism to improve analgesia. L-arginine also used to reduce the pain intensity and has opioid-sparing effect. Non-pharmacological intervention, complementary and integrative acupuncture, dietary supplements, and the mind-body system are being increasingly used for treating chronic pain, partially to reduce complication of long-term opioid. notably suboptimal dose of morphine co-administered with electropuncture, acupuncture to moderate response responder achieve analgesic equivalent to high dose. This is the last slide. Thank you.
Thank you, Dr. Tharwat, for this nice presentation about the common disease that we face every day. Now for the next presentation, we have Prof. John Apostolidis. He is currently a consultant at hematologist and a stem cell transplant in King Fahd Specialist Hospital. He has in-depth knowledge of malignant hematology, coupled with many years of clinical experience in the largest stem cell transplant unit in Greece. Welcome, Dr. John.
Thank you, Dr. Fatima, for your kind words. Good morning, everyone, and thank you to the for the invitation to participate in this meeting. I will be discussing treatment options in Hodgkin's lymphoma. And the advances we've seen over the last 20 years. So the cure of Hodgkin's lymphoma is one of the big success stories of cancer treatment from the last century, from 20th century. As you can see in this slide that depicts the rates of death in the US starting from 1935 to 2000, you can see that the deaths started to plateau with the introduction of radiotherapy, suggesting that a proportion of patients with early stage Hodgkin's disease could be cured with radiotherapy in the 50s. And you can see after that a dramatic drop, a steep drop in the curve with introduction of combined chemotherapy in the early 60s with the combination of MOP. What's impressive is that with the introduction of a less toxic and more efficacious combination called ABVD in the mid-70s, you can see a dramatic drop in the deaths of Hodgkin's lymphoma. And ABVD until today remains the standard of care, remains the cornerstone of treatment in Hodgkin's lymphoma. So what improvement, what advances have we seen since 2000? First, we have PET imaging, and we have novel new drugs such as rituximab vedotin and the PD-1 blockade therapy such as nivolumab and pembrolizumab, which I will elucidate further down. So regarding the staging of treatment of Hodgkin's lymphoma, PET has been introduced over the past 15 years, and it has improved the staging and the ability to predict response in patients with Hodgkin's lymphoma. And what has been achieved is that we have a scoring system called the DeVille score, which ranges from 1 to 5. And based on this, we can determine the response of the patients to treatment. What you have to take into account is that there's normal FDG uptake in the mediastinal blood pool, and there's also normal uptake in the liver. Based on these, the uptake in the mediastinal pool and the liver, patients can be scored as 1, 2, 3, or 4. And what you should keep in mind is that patients who have a DeVille score of 1, 2, or 3 are what we call metabolic CR patients. And this is irrespective of what residual mass is noticed in the scan. So what's important is that the end of treatment PET scan is a very powerful predictor of outcome. As you can see here, it has a high negative predictive value with a very small proportion of false negative cases. With regard to the PET positive end of treatment PET scan, we can see that not all patients progress, and there's a false positive rate of around 40%. So we should keep that in mind, that whatever shines doesn't necessarily mean it's gold. Also, the concept of interim PET scan has been introduced, and its prognostic failure. And as you can see here, patients who, after 2 cycles of chemotherapy, have achieved a metabolic CR do much better than those who persist to be PET positive, as you can see from a variety of studies. So the concept of PET-adapted treatment has been introduced in clinical trials, and we will see some of these results. First of all, in early stage Hodgkin's disease, patients who are PET negative after 3 cycles of ABVD can actually do not need involved field radiotherapy based on this randomized phase 3 trial. You can see the 3-year progression-free survival only differed around 5%. So in other words, you would have to treat 13 patients with combined modality, that is ABVD plus radiotherapy, to see a benefit of radiotherapy in just 1 out of these 13 patients. So it really isn't worth it. Even in patients with unfavorable disease, again, the difference comparing 6 cycles of ABVD to 4 cycles of ABVD plus involved field radiotherapy, the difference is pretty small. So probably we should omit radiotherapy in patients with early stage Hodgkin's lymphoma. So the standard of care, as I mentioned earlier, is ABVD, and this is based on a balance of efficacy and toxicity in patients. Still, as you can see here, the 5-year progression-free survival rate is around 70%. So we need to improve the outcome of around 30% of patients who fail ABVD. So there's no doubt that more intensive chemotherapy, such as Pcoc or escalated Pcoc, is better than ABVD. And if you look at randomized phase 3 trials, you can see that the difference in progression-free survival favors the Pcoc escalated combination. But there is no difference in overall survival. So why is there no difference? First, because you can salvage patients who fail ABVD. The second thing is there is no difference in overall survival, as I mentioned earlier, as you can see here. But the most important thing is, with longer follow-up, you can see that with ABVD, the secondary malignancies plateau, although, as you can see, with the Pcoc escalated, accumulating over time, 10 to 15% of patients develop over long-term secondary malignancies. The other thing is, with Pcoc escalated, there's a high risk of fertility issues. So you don't want to expose early on patients, in particular young individuals, to risk of infertility. So sorry, but I cannot change the slide. So in the advanced stage Hodgkin's lymphoma, there have been, okay, thank you. So those who are interim PET negative, there's an important study, the UK RATHL trial, which showed that after 2 cycles of ABVD, if you've achieved a PET negative PET scan, you can eliminate the bleomycin from the combination, reducing the lung toxicity and overall without affecting the long-term efficacy. Another strategy is to start with patients with escalated Pcoc, and if they achieve a metabolic CR, to de-escalate to 4 cycles of ABVD. And there's another study looking at the addition of brentuximab vedotin to AVD and substituting the bleomycin with brentuximab vedotin compared to ABVD 6 cycles. There was a 5 to 6% difference in progression-free survival in this study. I will get back to this later on. This is looking at interim PET positive patients. So what you can do is you can escalate to Pcoc escalated, or if patients are still PET positive after ABVD, you can actually direct these patients towards salvage chemotherapy and autologous stem cell transplantation. Now, this is the Echelon-1 study, which looked at, it's a randomized phase 3 trial in patients with advanced stage Hodgkin's lymphoma, and it compared ABVD, which is the standard of care, to AAVD, that is the addition of brentuximab vedotin and eliminating bleomycin from the combination. This study was updated just recently in the New England Journal of Medicine, and as you can see here, there is the difference in progression-free survival in favor of the brentuximab vedotin arm is still maintained at 6 years, as you can see here, 82 versus 74.5%. But the important thing about this study was that for the first time, we can see an improvement in the overall survival in favor of the experimental arm, something that hasn't been shown before in other studies. One could argue that the difference is not associated mostly towards patients who had Hodgkin's, progression of Hodgkin's disease, rather than a odd, as I would say, higher rate of secondary cancers in the ABVD arm, which cannot be explained because patients practically receive the same chemotherapy. But anyway, it's something we have to comment on. It showed a small but significant difference in overall survival. Now, a very important study that was just published online in the JCO is a study looking at the value of PET scan in patients who have bulky disease. So this is a study that looked exclusively at patients who had bulky disease. The eligibility for bulk here, as you can see, is a bulky mass at least 10 centimeters or exceeding 1/3 of the maximum thoracic diameter. So these patients, as you can see, the majority of these patients were stage 2 advanced with B symptoms or external disease. Now, all these patients received ABVD 2 cycles. Those who were PET negative, that is DeVille 1, 2, or 3, received 4 more cycles of ABVD, while those who were DeVille 4 or 5 PET positive, which were 22% of patients, were shifted to escalated Pcoc and then received involved field radiotherapy. The primary endpoint of the study was progression-free survival. And as you can see here, there was no difference in the outcome between patients who were PET positive and PET negative, suggesting that we can safely eliminate radiotherapy from patients who achieved DeVille 1, 2, or 3 PET scan after completing therapy. And if you look at the DeVille score 2 or 3 in those who achieved a PET negative status, even DeVille 3 patients compared to DeVille 2 had no difference in outcome, very excellent results. So in bulky disease, if you achieve a negative PET scan, interim and end of treatment, there's no need to irradiate. What about elderly patients? Well, elderly patients did not tolerate ABVD. There are various options for these patients. In one study, they gave two doses of brentuximab vedotin, followed by AVD 6 cycles, and then 4 more doses of brentuximab vedotin. Again, very good results, but the 2-year progression-free survival was 84%, which is very good. But 35% of patients withdrew due to toxicity or adverse events. A novel non-chemotherapy combination is the BV-Nivo, which combines brentuximab vedotin with the immune checkpoint inhibitor nivolumab. Here again, response rates are pretty good with a median progression-free survival of 18 months. Dacarbazine combined with brentuximab vedotin is one combination we use at our center. Is very well tolerated, although it has a median progression-free survival of 18 months. And the combination of BV, brentuximab vedotin, bendamustine, which again has high response rates, but this study was terminated because they had significant toxicity, at 65% adverse events and 2 toxic deaths. But this is an important randomized phase 3 trial, which is currently has completed recruitment and waiting the results. This is looking head-to-head the combination of brentuximab vedotin plus AVD versus nivolumab AVD in Hodgkin's lymphoma. Hopefully in the next couple of years, we will have results of this very important study. Now, for patients who have primary refractory disease or who progress, we have salvage chemotherapy. These are the usual salvage regimens we give in patients with refractory disease or relapsed at some point. And these patients usually proceed to autologous stem cell transplantation. We have also a variety of other regimens which have incorporated the novel brentuximab vedotin, and we also have conventional salvage regimens which have been combined with immune checkpoint inhibitors such as pembrolizumab and nivolumab. These look slightly more efficacious, but there's no randomized phase 3 study yet to document this. This is the data from our center. This is in many patients who achieve metabolic CR with first-line salvage chemotherapy, we proceed with autologous stem cell transplantation using single agent high-dose melphalan, and we give this as in the outpatient setting. So patients go on to autologous and are followed up as outpatients. They come daily to the day ward, and they don't need admission. And here you can see the results. The 6-year progression-free survival is 62%, and the overall survival is 95% at 6 years for these patients. What about maintenance therapy in patients who have received autologous stem cell transplantation? There is a randomized phase 3 trial, the Athera trial, that looked at the value of giving maintenance brentuximab vedotin in these patients. As you can see in this randomized study, the 5-year progression-free survival was superior, as you can see, in the patients who received brentuximab vedotin. The benefit, although is not that evident in patients who have relapsed beyond 12 months, and also patients who achieve a negative PET scan before autologous stem cell transplantation. So in the 2 categories of patients, it's probably not worth giving this the maintenance therapy. Now, nivolumab and pembrolizumab are immune checkpoint inhibitors. They've shown very, very good results in patients with Hodgkin's lymphoma. Here you can see the 5-year progression-free survival and 5-year overall survival, which exceeds 71%. This is in patients who have relapsed refractory disease and who have failed autologous stem cell transplantation. What is impressive is that the survival rates are quite similar to those who achieve CR, PR, or stable disease. Similar results have also been shown with pembrolizumab, as you can see here, with long-term survivors, which actually can compete with allo stem cell transplantation since the results are so good. And a small proportion of patients who have been exposed to the immune checkpoint inhibitors can achieve complete remission. And at 5 years, you can see that still 44% of these patients are still disease-free at 5 years. And the overall survival at 5 years is 82% in these patients. So immune checkpoint inhibitors are very effective in Hodgkin's lymphoma. I'll just skip this, it's not very important. So the take-home message is that abbreviated ABVD without radiotherapy provides adequate disease control in patients with an interim negative PET scan. ABVD and AAVD are standard of care for the majority of patients with advanced stage disease. Pcoc escalated improves progression-free survival compared to ABVD, but there is a cost of toxicity and fertility in these young patients. Maintenance brentuximab vedotin following autologous stem cell transplantation is indicated in a proportion of patients who fulfill criteria, and the immune checkpoint inhibitors in the relapse refractory setting have shown significant clinical activity with a small proportion of these patients achieving long-term CRs, as I showed just earlier. And there's a growing interest of combining the immune checkpoint inhibitors and brentuximab vedotin with chemotherapy in the relapse refractory setting. There are ongoing phase 2, phase 3 trials in this direction. So thank you very much.
Thank you, Dr. John, for this great talk about the recent advances in management of Hodgkin lymphoma. Now, I think we'll go for the panel discussion. Any question?
Thank you all. I think no question now because time factor. We have to close this session now for the end closing ceremony now. Thank you all.
إنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان.
بسم الله الرحمن الرحيم. معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة، سعادة الدكتور أحمد محمد الأنصاري الرئيس التنفيذي للمستشفيات الحكومية، أصحاب المعالي والسعادة، السيدات والسادة، حضورنا الكريم، السلام عليكم ورحمة الله وبركاته. يسعدنا أن نرحب بكم في مؤتمر البحرين الأول للأورام والرعاية التلطيفية، والذي استضافته مملكة البحرين على مدار يومي 5 و6 من نوفمبر الجاري، ليجسد ما تتمتع به المملكة من إمكانيات عالية في احتضان المؤتمرات الدولية العالمية بفضل الدعم الذي يحظى به القطاع الطبي من لدن حضرة صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك البلاد المعظم حفظه الله ورعاه، والاهتمام والمساندة المستمرة من صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء حفظه الله. أصحاب المعالي والسعادة، الحضور الكريم، لا شك أن مملكة البحرين تولي اهتماماً بالغاً في القطاع الطبي الذي سجل محطات رائدة طوال الفترات الماضية، ومن أبرزها الخطوات والرؤية العالمية التي اتخذتها المملكة في التصدي لفيروس كورونا كوفيد-19 حتى سطرت أروع الأمثلة لتصبح محط أنظار العالم في التدابير والخطوات التي اتخذتها لمواجهة هذه الجائحة العالمية. وإن استضافة مملكة البحرين لمؤتمر البحرين الأول للأورام والرعاية التلطيفية يسهم في تحقيق أهداف عديدة لكافة الدول، ولا شك أن رعاية معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة كانت داعم لتحقيق هذه الأهداف المرجوة. أما الآن فليتفضل معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة لإلقاء كلمته.
بسم الله الرحمن الرحيم. سعادة الدكتور أحمد محمد أنصاري، دكتورة مريم الهاجري، دكتور عبد الوهاب محمد، أصحاب المعالي والسعادة والسيدات والسادة، حضورنا الكرام، السلام عليكم ورحمة الله وبركاته. يسعدني أن أرحب بكم أجمل ترحيب في جمعنا البهيج في مؤتمر البحرين الأول للأورام والرعاية التلطيفية، الذي يعد واحد من أهم المؤتمرات على مستوى المنطقة، خصوصاً أنه يثري القطاع الطبي في مملكة البحرين الذي يشهد تطوراً ونمواً بفضل الدعم والرعاية الذي يحظى بها هذا القطاع من لدن سيدي حضرة صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك مملكة البحرين المعظم حفظه الله.
والاهتمام والمساندة الدائمة من صاحب السمو الملكي الأمير سلمان بن حمد الخليفة ولي العهد رئيس مجلس الوزراء حفظه الله ورعاه. السيدات والسادة، إن مملكة البحرين اتخذت خطوات رائدة في القطاع الصحي بتبنيها نظام الضمان الصحي، ويشمل التسيير الذاتي للمستشفيات الحكومية والصحة الأولية وتطوير نظم المعلومات لتحقيق نظام صحي يمتاز بالعدالة والجودة والاستدامة والتنافسية، يتيح للمواطن حق الاختيار جهة العلاج تحقيقاً لنظرة البحرين 2030، مما يجعلها محط الأنظار بفضل المعرفة والحرص على الاطلاع والتحقيق الاستفادة في مختلف مجالات الطب، خصوصاً في الأمراض والرعاية التلطيفية، الذي شهد نمواً متسارعاً في العلاج المميز المقدم للمواطنين والمقيمين. لا شك أن هذا المؤتمر فرصة للتباحث لمواصلة الإبحار في أحدث المستجدات الطبية العالمية في مجال الطب، في مجال الأورام والرعاية التلطيفية، خصوصاً أن المؤتمر يضم كوكبة من الخبراء والاستشاريين من مختلف الدول الذي سيسعون للوصول إلى تحقيق كامل الأهداف المرجوة من هذا المؤتمر. الحضور الأفاضل، أشعر بالسعادة أننا جميعاً عملنا يداً بيد من أجل تحقيق الأهداف التي وضعت من أجل هذا المؤتمر المهم، وتحقيق المكاسب لمواصلة ازدهار القطاع الطبي، وتمنياتي للجميع بالتوفيق والنجاح. شكراً. أشعر بالسعادة أننا جميعاً عملنا يداً بيد من أجل تحقيق الأهداف التي وضعت من أجل هذا المؤتمر المهم، وتحقيق المكاسب لمواصلة ازدهار القطاع الطبي، وتمنياتي للجميع بالتوفيق والنجاح. والسلام عليكم ورحمة الله وبركاته.
كل الشكر والتقدير لمعالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة على هذه الكلمة. والآن مع كلمة لسعادة الدكتور أحمد محمد الأنصاري الرئيس التنفيذي للمستشفيات الحكومية في مملكة البحرين، فليتفضل.
السلام عليكم ورحمة الله وبركاته. معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة الموقر، أصحاب المعالي والسعادة، السيدات والسادة، الخبراء الاستشاريين والمحاضرين، حضورنا الكرام، السلام عليكم ورحمة الله وبركاته. يشرفنا أن يكون تجمعنا اليوم تحت قبة واحدة عنوانها مواصلة الازدهار بالقطاع الطبي والحرص على تقديم أفضل الخدمات الطبية للمواطنين والمقيمين على أرض مملكتنا الغالية، وتحقيق كامل الاستفادة من مؤتمر البحرين الأول للأورام والرعاية التلطيفية، والذي يجسد رؤية وتطلعات حضرة صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك البلاد المعظم حفظه الله ورعاه، واهتمام ومساندة صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء حفظه الله ورعاه. لا شك أن هذا المؤتمر يعتبر محطة مهمة لتأكيد ما تتمتع به مملكة البحرين من قدرات وإمكانات لاستضافة الفعاليات الطبية العالمية، وما تسعى إلى تحقيقه من أهداف عديدة تعود بالنفع على القطاع الطبي، وتمتد من مملكة البحرين لتشمل جميع الدول المشاركة، في ظل حرص المشاركين من الخبراء والمحاضرين على عكس تجاربهم على القطاع الطبي في دولهم، وبالتحديد بمجال الأورام والرعاية التلطيفية. حضورنا الكرام، إن المستشفيات الحكومية تسير وفق رؤية حكيمة مدعومة من حكومة مملكة البحرين لمواصلة تطوير القطاع الطبي في المملكة، حيث اتخذت خطوات متقدمة ورائدة في التعامل مع مختلف الموضوعات الطبية وتقديم أفضل الخدمات للمواطن والمقيم على أرض مملكة البحرين. ولا شك أن الأورام والرعاية التلطيفية أحد الأركان المهمة والتي سجلت محطات مميزة في الفترة الماضية من حيث الخدمات الطبية المقدمة للمرضى. وبالتأكيد إن مشاركة نخبة من الخبراء والأكاديميين والاستشاريين من مختلف الدول والاستفادة من تجارب الآخرين يتماشى مع توصيات مجلس أمناء المستشفيات الحكومية برئاسة الشيخ هشام بن عبد العزيز آل خليفة، وذلك للارتقاء بكافة مبادرات التطوير الاستراتيجي بالمستشفيات الحكومية. كل الشكر والتقدير لمعالي الفريق طبيب محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة على تفضله برعاية هذا المؤتمر، وعلى كل الدعم المتواصل لدعم القطاع الصحي بمملكة البحرين. وفي الختام نتمنى لكم جميعا التوفيق والنجاح، وأن تكونوا قد حققتم كامل الأهداف المرجوة من هذا المؤتمر، وإننا إذ نؤكد على دوركم البارز في تطوير القطاع الطبي واستمرار نهوضه بأفضل الطرق الحديثة، متمنين لكم دوام التوفيق والنجاح. والسلام عليكم ورحمة الله وبركاته.
أوكي. كل الشكر والتقدير لسعادة الدكتور أحمد محمد الأنصاري الرئيس التنفيذي للمستشفيات الحكومية على هذه الكلمة. كما تعلمون لقد عملت اللجنة العلمية للمؤتمر بشكل دؤوب طوال الفترة الماضية من أجل وضع التصورات الكاملة للمؤتمر وأهدافه، وتوجد العديد من المحاور العلمية والعملية التي شهدها هذا المؤتمر. أما الآن فنرحب بالدكتورة عائشة زمان رئيس المؤتمر لإلقاء كلمتها، فلتتفضل.
بسم الله الرحمن الرحيم. معالي الفريق الطبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة، سعادة الدكتور أحمد محمد الأنصاري الرئيس التنفيذي للمستشفيات، المحاضرون والمشاركون في المؤتمر، السيدات والسادة، السلام عليكم ورحمة الله وبركاته. يطيب لي أن أرحب بكم أجمل ترحيب معنا اليوم في تجمعنا في مؤتمر البحرين للأورام والرعاية التلطيفية، والذي يعد أحد أهم المؤتمرات الطبية التي تستضيفها مملكة البحرين هذا العام، والتي سجلت محطات رائدة في التطور الطبي بفضل الاهتمام والرعاية التي يحظى بها القطاع من لدن صاحب الجلالة الشيخ الملك حمد بن عيسى آل خليفة ملك مملكة البحرين المعظم حفظه الله ورعاه، والمساندة الدائمة من صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد ورئيس مجلس الوزراء حفظه الله. إن مواجهة ومقاومة مرض السرطان بشكل شمولي يمثل محور أساسي من استراتيجيات قطاع الصحة بالمملكة، والذي يشمل برامج الفحص الدوري للكشف المبكر عن مرض السرطان، وخطط الوقاية وتقديم العلاج والرعاية التلطيفية لتقديم أفضل خدمة صحية للمرضى بالمملكة. وتماشياً مع الرؤية العالمية بما يتعلق بمرض السرطان، اتخذنا عنوان المؤتمر لهذا العام متماشية مع خطة منظمة الصحة العالمية. تايتل Closing the Care Gap، واللي يترجم باللغة العربية إلى سد الثغرات في الخدمات المقدمة. العنوان الذي يتمحور حوله المؤتمر ويحمل في طياته العديد من الجوانب العلمية للتباحث حول هذه الأمراض، ويؤكد حرص المملكة ضمان توفير أجود الخدمات المقدمة لهذه الفئة من المرضى تماشياً حسب المعايير الدولية. السيدات والسادة، أوراق وبحوث علمية متقدمة شهدها المؤتمر ستسهم في مواصلة ارتقاء القطاع الطبي في مملكة البحرين، ولم تقتصر الاستفادة على البحرين فقط، إنما جميع الدول المشاركة في المؤتمر، لأننا نثق ونمشي على منهج أن المؤتمرات تساهم في ارتقاء هذا القطاع وينعكس بالإيجاب على المواطنين والمقيمين في هذه الدول بحصولهم على أفضل الخدمات الطبية، وسعياً لتحقيق الاكتفاء الذاتي والتكامل وتبادل الخبرات بين دول المنطقة. حرصنا في هذا المؤتمر على تسليط الضوء على الخطة الخليجية لمكافحة السرطان 2016-2025 وسجل إحصائيات مرض السرطان في مملكة البحرين كانسر ريجستري، بالإضافة إلى أول مرة إلى إشراك المرضى لمشاركة تجاربهم وتقييم الخدمات المقدمة لهم، بالإضافة إلى دور الرعاية التلطيفية في المملكة. كما أبرزنا دور المؤسسات والجمعيات الأهلية في البحرين ممثلة بجمعية البحرين للسرطان لإبراز أهمية المشاركة المجتمعية في هذا الجانب. السيدات والسادة، إننا فخورون بما تحقق من إنجازات طبية متقدمة في مملكة البحرين طوال هذه السنوات الماضية بالخطوات المدروسة، ونؤكد بأن المستشفيات الحكومية ماضية في مواصلة العلم والمعرفة لتقديم أفضل الخدمات الطبية للجميع، سائلين الله أن ينعم على الجميع بالصحة والعافية. وفي الختام لا يسعني إلا أن أتقدم بالشكر إلى معالي الفريق الطبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة لرعايته الكريمة لهذا المؤتمر، وإلى كل من ساهم على إنجاح هذا المؤتمر. صراحة بالنيابة عني معالي الشيخ وعن القسم نشكرك جزيل الشكر لأن أحييت القسم، جزاكم الله عنا خير الجزاء، والسلام عليكم ورحمة الله وبركاته.
كل الشكر والتقدير للدكتورة عائشة زمان على كلمتها. ومن ضمن برنامج المؤتمر كان للمتعافين من هذا المرض مشاركة يتحدثون بها عن تجربتهم ومراحل علاجهم وما تبعته من تغييرات عدة في أنماط الحياة تبعث السكون والطمأنينة والفرح. كلمتنا القادمة ستكون لباعثة الأمل والفرح الإعلامية القديرة فرح علي، فلتتفضل.
بسم الله الرحمن الرحيم. مع الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة، سعادة الدكتور أحمد محمد الأنصاري الرئيس التنفيذي للمستشفيات الحكومية، المحاضرون والمشاركون في المؤتمر، السيدات والسادة، صباحكم خير. راح أنتقل شوي من الرسميات للكلام بالعامية. أرحب بجميع ضيوفنا في هذا المؤتمر. أحب أعرفكم بنفسي. فرح أو فتاة من الخليج كما سميت في المستشفى اللي كنت أتعالج فيها خارج دولة البحرين. قصتي بسيطة جدا. تخرجت من الثانوية بعد ما كان لي باع في المسرح المدرسي والمسرح الأندية والمسارح الأهلية، توجهت لدراسة المسرح من قبل وزارة الإعلام. تخرجت عندي طموحي، عندي أهدافي، عندي خطتي لحياتي لمستقبلي، وما كان السرطان ضمن هذه الخطط، أو ما كان في الحسبان أنه ممكن يصير هذا الشيء. بعد فترة من وجودي في الإعلام قررت أنه أتجه لتجارتي الخاصة البسيطة اللي هي كانت بالأساس مملوكة لأحد أفراد العائلة، وخذيت أنا أواصل فيها المسيرة، ومن ارتباط إلى إنجاب إلى آخره، إلى مستعمرة تبني نفسها ببطء شديد في جسدي. لما أبلغت أنه أنا عندي سرطان، كان أول شيء أبغي أقوله لا، مو من ضمن خطتي السرطان، مو من ضمن أهدافي، مو من ضمن الخطة المستقبلية اللي أنا حطتها لحياتي، لكن كان الواقع يقول لا، هو سرطان. فطبعا كان لازم أمشي مع البروتوكول اللي موجود في هذه الحالات. لله الحمد أنه إحنا في البحرين عندنا مراكز كثيرة ومتعددة دائما يحثوننا على الفحص المبكر والفحص الذاتي، اللي أنا اكتشفت الورم اللي عندي بالفحص الذاتي، ثم توجهت للعيادات وللمستشفى بأخذ العينة والبروسيس اللي أغلبكم يعرفونها، وتم إزالة الورم. وأيضا أخذت علاجي الكيماوي والإشعاعي كاملا في مجمع السلمانية الطبي. دكتورة عائشة شكرا لأني أنا موجودة اليوم هنا. دكتور حسين أحييك. الدكاترة اللي تحملوا، الممرضين والممرضات اللي كانوا، بالأخص الممرضات قسم الأورام في مجمع السلمانية الطبي، تحملتوا كثير مزاجيتنا، تحملوا الأطباء مزاجيتنا، تحملوا عصبيتنا، تحملوا ضحكنا، فرحنا، حزننا، في كل شيء. قصتي يمكن تكون مختلفة شوي عن باقي القصص لأنه أنا كانت من شقين. الخوف اللي كان يجيني أحيانا أنه أنا ممكن الكانسر يرجع لي، خلاني ألجأ للاستئصال الوقائي اللي صار فيه شوية تعقيدات، فرجعت مرة ثانية تحت عمليات معينة عشان أرجع تماما. لما قعدت مع نفسي في فترة ما أنا كنت أتعالج أو في فترة ترميم، وقفت مع نفسي في فترة إصابتي بالسرطان. أنا كنت مختفية تماما عن الإعلام، ولا أحد يعرف أنه أنا أصبت بالسرطان. تركت الإعلام، التلفزيون، المسرح، وابتعدت تماما. ولكن بعدين وقفت مع نفسي وقفة صغيرة، قلت فرح هناك حكمة. طبعا أترك كل ما في داخلي، مثلا ليش، شلون، متى، هذه الأسئلة اللي كانت دائما تدور في ذهني. فقلت لنفسي فرح لازم يكون لك وقفة، والوقفة هذه تعني أن أنت تعودين للإعلام بإحسان، يستفيدون المرضى من تجاربك، ومن يحتاج للسبورت النفسي، الدعم، أكون موجودة. لذلك كرست وقتي بين شغلي وبنتي وهذا المجال، أني أكون موجودة مع أي مريض يتلقى خبر الإصابة، ومن ثم أمشي معاهم مراحل العلاج، أمشي معاهم، أتواصل معاهم، أعرف شنو احتياجاتهم اللي بدوري أحيانا أوصلها للمختصين، إنه إحنا نحتاج كذا أو المريض الفلاني. إحنا اليوم عندنا في البحرين صرح جميل جدا، مستشفى الملك حمد للأورام، اللي أنا كبحرينية فخورة بوجوده. ولكن هم أقول دائما عندي حنان ولاء لقسم الأورام في مجمع السلمانية الطبي، كوني تعالجت وتعاملت هناك معهم. اليوم أنقل كل الخبرة اللي خذيتها في خلال 6 أو 7 سنوات من كانسر سبورت جروبس، أو من أطباء، أو من باحثين، أو من محاضرات حضرتها داخل البحرين أو خارج البحرين، بكل ما أملك أحطي كل قوتي في هذا المجال، أخليها في هذا المجال، أني أساعد الكانسر بيشنتس، أساعدهم. فتحولت من فرح علي الطفلة الشقية إلى صائدة الجوائز في المهرجانات اللي كانت تقام في المسرح، إلى فتاة من الخليج كما سمتني ممرضتي أونا في المستشفى اللي كنت أتعالج فيها. الحلم، هذا حلم فرح وحلم حمود، شريكي وزميلي في جميع الفعاليات، اللي اليوم هو مش موجود، بس أنا حبيت أني أخلي أيضا بطاقة باسمه. حلمي أنه هذه البطاقة تكون لنا معالي الفريق، لكل سيرفايفر، لكل مريض تحت العلاج. حلمي تكون هذه البطاقة لما أطلعها في أي مكان يقولون لي عندك priority في الإدارات، في الوزارات، في المستشفيات، في أماكن كثيرة وعديدة. ما أضطر أني أنا أقول أنا متعافية، أو يجي مريض يقول أنا تحت العلاج وهو ما عنده مناعة ويكون موجود ينتظر في إدارة أو وزارة أو أي مكان. إحنا في البحرين متقدمين في كل شيء، فأتمنى أيضا أنه هذه الفكرة تطلع من البحرين وتكون من البحرين. أنا اسمي فرح، ولذلك سميت هذه الإيفنتات اللي أحضرها بفرح، للفرح كلمة. شكراً.
نشكر الإعلامية فرح علي على كلمتها ومشاركتنا تجربتها. حضورنا الكريم، لقد شهد المؤتمر مشاركة نخبة من الخبراء والاستشاريين والعلماء من مختلف الدول الذين أبحروا فيما وصل إليه العلم في مجال الأورام والرعاية التلطيفية. وحرصاً من اللجنة المنظمة على تقدير جهود الباحثين والخبراء، يتفضل الآن الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة، سعادة الدكتور أحمد محمد الأنصاري الرئيس التنفيذي للمستشفيات الحكومية، بتقديم الدروع التذكارية للمحاضرين في المؤتمر. دكتورة عايشة زمان رئيس اللجنة العلمية للمؤتمر. دكتور أمين عبد الله من اللجنة التنظيمية. الراعي الذهبي شركة نوفارتس. الدكتور عبد الرحمن دكتورة إيمان التوحيد. الدكتور ثروت وجدي. دكتورة مها السليم. دكتورة فاطمة شمس. دكتورة فاطمة. الدكتور حسن جعفر. والآن يتفضل سعادة الدكتور أحمد محمد الأنصاري لتقديم درس التاريخ لمعالي طبيب الشيخ محمد بن عبد الله آل خليفة على الشكر والتقدير لمعالي طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة. وسعادة الدكتور أحمد محمد الأنصاري الرئيس التنفيذي للمستشفى. نهاية أهلنا الكريم
I think we might just, good afternoon, everybody. I think we might start because we're running 20 minutes behind schedule. So our next speaker is Dr. Shahina Dawood. Dr. Shahina Dawood is a consultant medical oncologist and a professor in clinical oncology in the United Arab Emirates. She trained in medical oncology at McGill University Hospital in Canada and subspecialized in breast cancer management at MD Anderson Cancer Center. During her training, she was awarded multiple scholars and training awards and ASCO Merits Award. She served as an editorial fellow at the New England Journal of Medicine and has an MP. Hello? Okay, and has an MPH from Harvard School of Public Health. She has over 100 papers to her credit, including 50 peer review original articles, 30 review articles, and 12 book chapters. She serves as a reviewer for multiple journals, including the Journal of Clinical Oncology, and also the president of UAE Cancer Congress that is held annually in Dubai. She is a co-president of the Asia Pacific Breast Cancer Summit and Asia Pacific Gastrointestinal Cancer Summit. And she also has recently launched the International BRCA Forum and MENA Immune Oncology Summit. Please welcome with me Dr. Shahina Dawood from the United Arab Emirates. Dr. Shahina Dawood, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, perfect.
So thank you for the lovely introduction and thank you for the invitation to come onto your platform today to share my experiences on personalized cancer care. I think this field has exploded in the last decade. It is truly exciting where we were and how we've come such a long way in terms of the management of our patients with advanced cancers. So these are my disclosures and these are my contact information if anyone would like to get in touch with me to network and discuss. So we know that in the field of oncology, really not only in oncology, but across the board in multiple specialities, that it's usually a hit and miss strategy when we're trying to treat our patients. We assume that all patients with the same diagnosis would get the same benefit from therapy, but it's not entirely true. We know that some patients have no benefit, but only get toxicity. Some patients have benefit plus toxicity. Some patients have benefit, but no toxicity. And then of course, you've got that small group of patients that have no benefit and no toxicity from the therapy. And the field of tumor profiling now seeks to identify genetic biomarkers that influence drug response, including both those that are inherited and those that arise within tumors, so that we can use this information to improve drug therapy. And just to give you an example of how molecular profiling has actually changed the way we think. Historically, a tumor at one site, such as lung cancer, would be all treated the same. We now know that the same location is not going to give you the same treatment. For example, within the lung, different spots, different areas may have different profiles that can determine the way that we treat our patients. We also know that a single biomarker, which is relevant in one tumor, may also be relevant in another tumor. So say an NTRK fusion may be relevant in lung, colon, as well as kidney, and you would be able to give the same treatment. So what have we learned? How is precision medicine actually driving the advancements of patients in advanced cancers? So what did we learn from targets? Well, I think the first lesson that we learned is that identifying one important somatic mutation can in fact make a difference. And you can see this in an example of a patient with metastatic melanoma. In the past, we would have given him single agent dacarbazine, which would have resulted in a response rate of about 5%. But profiling the tumor results in us allowing to be able to identify a mutation such as a BRAF V600 mutation that can actually result in a targeted therapy which allows us to get response rates of above 60 to 70%. So again, telling us that one mutation can in fact change the whole paradigm of patients. Apologies. So you can see the example of different survivals across different malignancies where we try to target these patients. You can see within the realm of lung cancer, such as if a patient has an EGFR mutation, giving gefitinib is superior to chemotherapy. In melanoma, I just showed you if there's a BRAF V600 mutation, giving an anti-BRAF therapy versus chemotherapy is better. In a patient with a germline BRCA mutation who has breast cancer, giving a PARP inhibitor is better than giving chemotherapy in these patients. So a specific mutation and a specific target can actually result in improved survival. So you can see that we also have come into an era where there's a rapid adoption of also agnostic testing, which is changing the way we think about tumors. So what are agnostic testing? Agnostic testing allows you to be able to test for a marker where wherever it comes in any tumor, you can actually give the same therapy. For example, if someone has an MMR deficient tumor, pembrolizumab has been approved. In patients with NTRK fusions, larotrectinib and entrectinib has been approved. We've recently seen the approval of tumor mutational burden as well as RET fusions, where those are agnostic biomarkers as well. So one target and one drug can be used to treat actually all tumors. And this is the example of the MMR deficient tumors that I was just talking about, where we had the seminal paper that came out in the New England Journal of Medicine by Hyman and colleagues many, many years ago, which actually showed us that if patients had MMR deficient disease, could be colorectal or non-colorectal, when you treat them with pembrolizumab, these patients actually do very well. In patients with NTRK fusions, we can see that across the board, it didn't matter, thyroid, colon, melanoma. I currently have 2 breast cancer patients with NTRK fusions. You give them a targeted therapy such as larotrectinib or entrectinib, you get very high response rates despite these patients being heavily pretreated. So again, it actually tells us that finding that one biomarker can be all important. We've recently seen the approval of tumor mutational burden as an agnostic marker. We know that tumor mutational burden actually computes the total number of somatic and acquired mutations per coding area of the tumor genome. And the number of these mutations can actually vary across different subtypes. But we have seen the results of the Keynote 158 trial that actually looked at giving patients with a high tumor mutation burden, where you use the cutoff of more than or equal to 10, across different solid tumor subtypes, when you give them pembrolizumab, they do get a decent response. And this led to the seminal approval of the FDA approving pembrolizumab for both adults and children with tumor mutational burden high solid tumors. So you can see that, in fact, the last couple of years have been truly exciting. We've seen so many tumor-agnostic genomic-based approvals, from pembrolizumab in patients with MMR-deficient tumors to larotrectinib and entrectinib for NTRK fusion-positive tumors to pembrolizumab for TMB high. I just showed you that. We've also seen some interesting data for belzutifan for renal cell carcinomas who have a VHL. We've seen dostarlimab for, again, MMR deficient tumors, dabrafenib and trametinib for BRAF V600 solid tumors across solid tumors, not just as for melanoma patients, and of course, silpercatinib, and now recently pralsetinib for patients with RET fusions. Now, we also understand that one target may not be enough. Multiple target testing is also increasingly becoming important. One target, one drug eventually leads to resistance. One target, one drug does not inform us on more potent targets. And one target, one drug does not always give you the full picture. And one prime example is patients with lung cancers, where you're trying to look at the whole picture. You want to know that they have PD-L1 positive disease, which allows you to give immunotherapy. But if they also have mutations or fusions, those mutations and fusions trump PD-L1 positivity. So again, it's important to have the whole picture. We also know in lung cancer, there's also a potential for acquired mutations over time. So again, multiple target testing is very, very important. The same goes for breast cancer. This gives an example of metastatic triple negative breast cancer, where we can see a whole plethora of different targets that are being currently explored in that first line setting, including biomarkers of defects in the DNA repair pathway, that inflamed phenotype, the androgen receptor, alterations in the PIK3CA AKT pathway, and of course, those agnostic markers such as HER2 mutations, NTRK fusions, as well as RET alterations. We know that pancreatic cancer also, we need to be able to profile these tumors. Although it's a very, very poorly associated prognostic outcome in pancreatic tumors, we know that in 2019, the NCCN guidelines clearly stated that all patients with metastatic pancreatic cancer should have their tumors profiled, because about 17 to 48% of these tumors actually harbor actionable findings. So is it worthwhile finding all this information? The simple answer is yes. You can see that patients with highly actionable alterations who receive molecularly matched therapy, in fact, live longer than patients who do not receive molecularly matched therapy. Putting aside lung, putting aside breast, you see it even in a hard to treat tumor like pancreatic cancer. Now, profiling also allows you to expand the population of cohorts that can benefit from therapy. And a prime example, again, is immunotherapy, where it's not only about PD-L1 testing. Patients that can benefit from immunotherapy include those patients with PD-L1 positive tumors, MSI tumors, tumor mutational burden high tumors, and of course, the ever-evolving interferon signatures as well, and this is pieces of information that can be derived from profiling. We know that rare tumors as well, profiling it can give you the information to be able to get targeted therapy for these patients. For example, salivary gland adenocarcinoma could have a BRAF mutation. I recently got my first patient with an NRG fusion who has a salivary gland adenocarcinoma. It is a needle in a haystack, but it's something that's going to save her life in that pretty rare to treat tumor. So as clinicians, we want the information early. We want that information accurately. We know that in metastatic setting, the progression-free survival gets shorter and shorter with subsequent lines of therapy. So we want the best therapy early by getting that NGS information information early. We would like to switch therapy early if it is not working. And we want to be able to stop that progressive decline by giving guided therapy in our patients. Now, I've said all this, but what is the best profiling strategy that we can actually use in our clinic? Well, we know that comprehensive genomic profiling allows testing of all types of alterations in broad panels. We need to stop using hotspot testing because I don't think it gives you enough information. The information that you get for all the pieces of information you will need to drive that clinical information that you need in the clinic comes in fact from comprehensive genomic profiling, which should integrate whole exome sequencing, whole transcriptome sequencing. It should integrate protein immunohistochemistry, and I'll give you examples of that. It should also integrate germline testing, because we know that germline testing has become imperative for BRCA-associated tumors, as well as the ever-evolving artificial intelligence. So where does whole exome sequencing actually help us? Well, whole exome sequencing is a next generation sequencing-based assay that analyzes the whole exome of approximately 22,000 DNA genes. And it provides enhanced detection and assessment of point mutations, insertions, deletions, copy number alterations, as well as that ever important MSI, tumor mutational burden, and loss of heterozygosity and homologous recombination deficiency. Now, again, in the realm of ovarian cancer, you can't treat your patients with ovarian cancer without knowing HRD, which is homologous recombination deficiency, the definition of which incorporates loss of heterozygosity, telomeric allelic imbalance, as well as large-scale state transitions that gives you the term genomic scarring. Now, on a clinical front, how does this help you? We know, and I won't go through all the trials for ovarian cancer, but we know that in patients who have ovarian cancer, we've always tried to hone in on the best therapy, where to insert a PARP inhibitor. We know from the Paolo 1 trial that patients with a BRCA mutation and patients with HRD BRCA wild type are the ones that are benefiting from the presence or the integration of a PARP inhibitor in their treatment paradigm. If you were to only test for BRCA mutation, you would actually be missing out on a significant cohort of patients that could benefit from a PARP inhibitor. Now, what about RNA sequencing? RNA sequencing is very, very important in my mind to be able to determine those fusions. Now, gene fusions detections using DNA, using NGS technology requires tiling of intronic regions known to likely harbor the genomic breakpoint. But this approach can be rather challenging because the introns are either too long to tile, the introns can contain repetitive elements that are unmappable, or they could have genomic breakpoints that take place in alternative introns not predicted by the panel design. And that is the reason why you need RNA sequencing as a more direct approach to fusion detection. And just to give you an example of why this is important, this was a very important study that came out of the Memorial Sloan Kettering group, where they had this large cohort of patients that only had DNA sequencing, and they had about 232 patients. All of them had RNA, all of them had fusion negative disease. When they went back and they did RNA fusion for them, they found that 36 of these patients actually had fusion positive disease that could potentially benefit from targeted therapy. And as such, the NCCN guidelines now recommend that it is feasible that testing be performed via a broad panel-based approach, most typically performed by NGS, for patients who in broad panel testing don't have an identifiable driver oncogene. You need to consider RNA-based NGS if not already performed. Why is this important? Is it better than a mutation? Well, the same group went back and they actually looked at that, and they found that when patients were matched, and it's humanly possible actually. I have a very similar case in the clinic where a patient has a PIK3CA mutation as well as an NTRK fusion, and I've had to ask myself, which is the better target? So the Memorial Sloan Kettering group actually went back and they asked that question, which is better to match, matching to a fusion or matching to other alterations? And what you essentially see is that when you match to other alterations, which is the red line, these patients actually don't do very well compared to the green line where you're matching to fusion. So fusion always trumps a mutation. And that's what I did. I actually treated her with entrectinib and she did very, very well. And this is the example that I was talking about. This is a 30-year-old woman with stage 4 de novo breast cancer, ER/PR positive, HER2 negative, extensive bone and liver metastases, first-line therapy, CDK4/6 inhibitor plus an AI. She had a progression-free survival of 6 months, and we profiled her tumor. You can see she has both an NTRK fusion and a PIK3CA mutation, making her candidates for both targets. We did go on to treat her first with entrectinib, and you can see that by September, and this was her pre-scan, her May scan, and by September, she had a complete response by giving a proper targeted therapy for this patient. Now, remember, I also told you it's not only about DNA sequencing and RNA sequencing. You need to incorporate IHC as protein immunohistochemistry as well. That information is vital, more so in lung cancer, where you need the information of PD-L1, and not only by one test, by multiple tests, so that you know which immunotherapeutic agent you're going to actually incorporate for your patients with lung cancer. Now that's all tissue-based profiling. Now, what about liquid biopsies? I think that is also a very important question to ask, because now we're incorporating that more and more in our clinic. There's been a number of different publications regarding ctDNA, and it's actually been a very exciting time because it is actually easier to do than a tissue profiling. So that takes me very nicely into what is the clinical utility of ctDNA. Well, it gives you access to tumor where tumor is insufficient. So basically, you're taking a blood draw from your patient and harvesting the cancer cells that are circulating, rather than going and fishing for that tissue, which is always not sufficient. It gives you speed of results. That means a rapid turnover. And this comes very nice data from our Japanese colleagues. It was the GI screen plus Godzilla combined analysis study, where they took a large cohort of GI patients, did both tissue profiling as well as liquid biopsies. And you can see that the turnaround time for patients for plasma in terms of getting the results was actually much shorter compared to the tissue. We know that sometimes that can take very long. And whether that impacted prognostic outcome, you can see it did not. So long as you detected the biomarker either in the tissue or in the liquid, prognosis was exactly the same. And this is just to give you an example of a patient that I recently treated, a 60-year-old lady with stage 4 non-small cell lung cancer, extensive lung and liver metastases. At the same time, because the recommendations for lung patients is to send liquid and tissue at the same time, because you can get a lot of QNS, which is quality not sufficient for tissue. And you can see this patient actually has an EGFR mutation. The turnaround time was 10 days. For the tissue, the turnaround time was 30 days, because the first sample we sent, it was QNS. We had to then send another sample. So it took a total of 30 days to get her results. When these results came back, she had already been on 2 weeks of osimertinib. So this tells you the speed with which you can get the results for a liquid biopsy. Liquid biopsy also allows for rapid dynamics in terms of response to therapy. And you can see here that the half-life of ctDNA in circulation is measured actually in minutes and hours. And this gives you an example of a patient with colorectal cancer. And you can see the ctDNA levels fall by more than 90% in 2 weeks in patients who are actually responding to therapy. So it's a way of actually monitoring patients. And we know that that's actually coming in very nicely in patients with not only metastatic, but also early stage disease. Determination of biomarkers is very important also with ctDNA, as well as assessment of resistance. And you can see across multiple solid tumors, we actually can track resistant mechanisms. In lung cancer, patients with an EGFR mutation can develop a T790 mutation. Patients with breast cancer who have been treated with endocrine therapy can actually acquire an ESR1 mutation. Now, we've had, say, in colon cancer, a lot of studies looking at the use of re-challenging with an anti-EGFR. And this comes from the Cricket trial that actually shows that patients with EGFR wild type or RAS wild type disease who've been treated with an anti-EGFR therapy, could you potentially re-challenge? And what they essentially found was that you can potentially re-challenge, but about 48% of the time, these patients actually acquire a RAS mutation and they won't benefit from an anti-EGFR. So important to retest before you give an anti-EGFR. What about those patients with a HER2 amplification and who have colorectal cancer? Can we treat them with an anti-HER2 therapy? This comes from the My Pathway trial that actually shows that if patients have RAS mutated disease and HER2, they do worse than if they have RAS wild type disease and HER2. So again, it allows you multiple targets, allows you to select which patients will benefit. So the tumor dynamics of patients receiving biomarker-selected therapy actually evolves over time. We know that there's growth of resistant clones, and if you give a holiday from the targeted therapy followed by reintroduction, you can actually change targeted therapy based on emergent biomarkers, and you could actually start introducing agents active downstream with active against downstream targets. So again, liquid biopsy gives you that opportunity for longitudinal follow-up of these markers. And then, of course, evaluation of heterogeneity. Different parts of the tumors may be expressing different biomarkers. And we do have, again, results looking at liquid biopsy in terms of looking at tumor heterogeneity. And I'll just give you one example here from gastroesophageal tumors, where you can see that if you were to do only analysis of the primary tumor and the metastases tumor, you get 37% overlapping biomarkers, but you can see 32% would be only in the primary and 31% would only be in the metastases. But if you did a liquid biopsy, you could capture all these biomarkers in toto. So again, I think it complements each other rather than being individualistic. Now, what about minimal residual disease and the role of ctDNA? Now, that is a huge thing that's come up, especially in our early stage patients. What is minimal residual disease? So basically, minimal residual disease is defined as a detection of ctDNA with no other clinical evidence of disease recurrence in patients who have completed all potentially curative therapy. And recently it's come out, and this was presented at ASCO, where patients with stage 2 colon cancer, where we're trying to figure out whether they need adjuvant chemotherapy or not, were randomized either ctDNA guided or physician choice guided therapy. And you can see that in ctDNA guided therapy, patients with ctDNA positive disease, that means detecting minimal residual disease, did worse than patients who had ctDNA negative disease, which tells you that these patients could potentially avoid chemotherapy in that stage 2 setting. So again, an evolving test in early stage colon cancer, and something that I'm very excited about. So where do we stand today? I've given you a lot of information that's probably, bombarded your memory cells right now, because it's such an exciting field and I get very hyper when I talk about it. But where do we literally stand today as oncologists? We know that comprehensive genomic profiling is a reality in today's clinical practice. We can't get away from it. You need to stop hotspot testing. You need to stop single biomarker testing. It's important not only to guide your therapy in clinical practice, it's also used if you're in a center for clinical trials, allowing patients to get on those clinical trials. This is a snapshot view of how we treat our patients with lung cancer. If you did not do comprehensive genomic profiling, you would not be able to look at all these targets, common mutations in lung cancer, and have the plethora of different medications that are available to treat your patients with these different targets. And we know that there's been a huge evolution in molecularly guided clinical trials. And these trials have gone from the Winter in 2013 to the iPredict in 2015. The most recent one has been the Pcoc, which was in 2018, and it's ever evolving. But each one of these trials have actually helped us answer important clinical questions. For example, the Winter trial combined both RNA and DNA sequencing to guide therapy. 303 patients enrolled. 22% of the patients that were had targeted therapy actually achieved more than 50% increase in the progression-free survival compared to their previous therapy. We saw results from the Target trial that looked at about 100 patients. 41 patients had actionable mutations, and 11 patients actually received those matched therapies, a significant proportion of which actually had durable responses. So what these trials are essentially telling us is that it's possible to do. It's possible to do it in your clinic. The number of patients may be small, but those patients who actually get treatment do very, very well. Now, molecularly guided clinical trials in precision medicine in general deal with small target populations. We've shown you that NTRK fusions happen in about 1% of all your patients, and only a minority of those patients will actually benefit. But if you get one of those patients, it does change therapy. So the challenge is starting to be addressed by increasing reliance on data generated from early phase non-randomized clinical trials, because there's no way that we can actually do huge clinical trials with such small targets of patients, and using real world data to capture about 95% of cancer patients who have no opportunity to in fact participate in clinical trials. And we do this all the time, right? As community oncologists, we look at the profiling report, we see something that could work. We have no data for it. In our MDTs, we say, we'll try it. Our patient does well. We put that patient into a real world database, and that's how we accumulate information. And you can see that evidence from early phase clinical trials have actually played a greater role in drug approval. So it's not all about phase 2 and phase 3. phase 1 trials have resulted in rapid approval of a number of different studies. The pembrolizumab trial for MSI solid tumors was based on a phase 2 trial. Larotrectinib, again, a phase 1, phase 2 study. Entrectinib, again, a phase 1, phase 2 study. So you don't always need phase 3 clinical trials. We also know that observational studies, registries are important pieces of information that we can use to actually look at those clinical decision making for us, to have information about policies, to have information about making policies for your own institution as to how to treat these patients. So randomized clinical trials are not the only way to do it. Randomized real world data can also be used to generate external controls. What does this mean? This means that if you have a phase 1 study or a phase 2 that's non-randomized study, where you only have one arm of the study, you could actually compare that to a control arm that you build data from a real world data set. An example comes from ALK positive non-small cell lung cancer patients receiving the newer drug alectinib, and you want to compare it to the older drug ceritinib. So you pooled your trial data for alectinib and you compare it to real world data for ceritinib versus clinical trial data for ceritinib, and you'll find that when you're putting those Kaplan-Meier curves together, very similar. This is alectinib, they're doing all well. This is ceritinib real world data and ceritinib clinical trial data. So real world data can allow you to build those cohorts that you can compare to the trial data that you have single arm. So how do we integrate all this information into our clinical decision making? We need to consider the entire picture to make the best clinical decision for the individual patient. We need to incorporate patient characteristics, imaging data, molecular information, pathological data, as well as the potential treatment options and corresponding levels of evidence that we can use to integrate. These are MDTs. Now, we want to be able to go one step further. So not only have MDTs where we're trying to brainstorm, but we also need artificial intelligence that can actually put all the information together and come up and help you with a clinical decision pathway. So you're basically putting all the information, including the data that comes out from molecular tumor board, the real world data information, drug access, the tissue agnostic labels, the novel clinical designs, the conventional diagnostics, advanced diagnostics, and that pops out a clinical decision that you could potentially discuss with your patients. And that's the future. Artificial intelligence is the future. So this is my last slide. Precision oncology as a framework for patients in 2022. Where are we at? You biopsy your patient, could be liquid biopsy or tissue biopsy. I'm a big proponent of doing both. You then send that sample for sequencing. You then discuss that information in your molecular tumor board, where you'll discuss logistics, cancer heterogeneity, as well as the magnitude of clinical benefit that you'll get from targeting a specific target. You develop that individualized therapeutic plan, and that's how you best treat your patient. So thank you very much. I hope I haven't given you too much information, but it's such an exciting field, and I'm happy to answer any questions.
Thank you, Dr. Shahina Dawood, and definitely interesting and more challenging to be an oncologist nowadays. I don't know if there is any burning questions for Dr. Shahina. Yes, Dr. Khulud, can we get the mic to her, please?
Thank you very much, Dr. Shahina, for this very exciting presentation about such a lovely, fast-growing medicine. And I really enjoy it. And I think, I don't have a question, but it's just a comment, because I believe the future will be for such target therapy. And soon maybe we are going to be away from chemo and going to target therapy. And we hope that's coming soon. And we see 100%. Our patients will survive
with minimum side effects and with better outcome. And I just have a message. I want to give a message for our youth doctors that this is really a very interesting medicine, and I really am encouraging our doctors to go and study it, because the future for that, and it's not only for oncology, it's for all other medical disorders as well. Thank you very much.
Thank you. Thank you.
Yes, thank you so much, Dr. Dawood, and hope to see you in Bahrain the next time. Thank you.
Bye.
Bye-bye. Thank you. So with that, we're going to move to our next session. So our next session is entitled Closing the Care Gap. So it's my pleasure to introduce the next speaker, Professor Ahmed Al-Shamsi. Professor Ahmed Al-Shamsi is an American and Canadian board certified in medical oncology. He completed his medical degree with honors from the University College Cork in Ireland. He completed internal medicine residency and oncology fellowship training at McMaster University in Canada. He also completed his fellowship in GI oncology and palliative care oncology at McMaster in 2013. He was appointed as assistant professor in the Department of GI oncology at MD Anderson Cancer Center in Texas from 2014 to December 2016. He is currently a consultant of oncology and the director of Burjeel Cancer Institute in Abu Dhabi, United Arab Emirates, and holds a professor position at Sharjah University. He is the president of the Emirati Oncology Society and has extensive clinical and research experience in solid malignancy and is an advocate for palliative care in the UAE. Professor Ahmed Al-Shamsi, it's an absolute pleasure, and thank you for accepting our invitation to participate with us.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you for the very kind invitation, and thank you for the scientific committee. When I was invited, I definitely said yes. I always love to work with our colleagues and friends from across the region and the Gulf area, from Saudi Arabia, from Bahrain, and definitely this is my first ever lecture in Bahrain, and inshallah it will not be the last. So I've been asked to talk about the palliative care in UAE, since actually that the name of the conference is very interesting because it's palliative care and oncology. Usually we see oncology and palliative care. So it's clearly that, you know, the scientific committee is paying a lot of attention to the palliative care. And I'm going to tell you why palliative care is very important for me as a person, as an oncologist, and also to our region. So this is my disclosure about my research and honorarium fees as well. So the UAE actually is, for those who don't know, it does have a different areas, and each section or area, they have different regulators. So we do have different systems. So it's very important to understand this when it comes to understanding the provision of palliative care, because definitely you need understanding of the entire health system and the ecosystem before you try to implement a comprehensive palliative care for any area. So cancer in the UAE actually is the third common cause for death and affects around 4,200 to 4,500 per year, around 1,200 mortality. So we have around 1 or 2 people actually dying every single day from cancer in the UAE. And breast cancer is the most common, followed by thyroid, followed by colorectal in females. In males, we have colorectal and also prostate cancer. Skin cancer shouldn't be a big issue because most of them actually are highly cured and very, very small, numbers of melanomas. Children cancers, definitely leukemias, brain and CNS, and also connective tissue diseases or cancers are actually the big ones in the pediatric population. So there is a burden of cancer in the UAE. And again, this is very similar to what we see in the GCC. And again, the cancer is the third leading cause of death in the UAE. So patients with cancer usually are being treated. Sometimes they have a recurrence, or they could present with advanced disease to start with. So once they present with advanced disease, we know these patients actually, they are palliative from day one, except a small number of these patients who can be treated with a curative intent. But the majority of these patients actually are palliative, and they need the palliative support, which is lacking in many, many countries and regions. So this is the landscape of the cancer care in UAE. And as you can see, there has been significant progress. And this from our publication in 2020, where we describe the current status of cancer care in UAE. Despite the progress and the improvement in the cancer care in UAE, the palliative care actually in UAE was not that improved, but definitely there has been significant changes and improvement, as I'm going to show you in the next few slides. During my training at McMaster University, where I finished my internal medicine, my oncology, during my last year of oncology fellowship, I realized, when we send patients from our oncology clinic to palliative, we are actually disconnected from this patient, and it also has an emotional part where we tell patient you have to go to palliative service, and most of these patients will never see them again, even though you've been seeing these patients, some of them actually for years. And certainly this actually gave me some insight about how important the palliative care. I did some research about the palliative care at that time. This was around 2009, 2010. I realized that, there is only one provider for palliative care in UAE. So if you work in another center, you will not be able actually to have any palliative care services. So I could be in a situation where I'm stuck with a patient and I don't have that skill and knowledge to be able to take care of this patient. So that's why I decided to do an extra year of palliative care. And actually, I am very glad I did. It's an extra year, but certainly it gave me some tools, some skills that I'm being able to take care of my patient until now. I don't do palliative care, as a separate specialty. I do it for my patient. I do take care of them until the end of their life as much as I can. I do seek sometimes some help from my other palliative care expert, because still, when you are doing oncology and palliative care, you need some support sometimes from your colleagues. So when I went back home in UAE 2017, I started also to analyze the current health system. And I wrote this paper with my colleague, Dr. Mona Tareen, who actually started the palliative care for the first time in Dubai. And we wrote this title, Palliative Care in UAE, a Desperate Need. And certainly there was desperate need for such service. In this paper, I should mention, Dr. Neil, who is currently the director of palliative care at Barjeel Hospital in Abu Dhabi, where I work, and I'm the director of that hospital, he reached out to me through this paper. My email is there, and he said, "Hey, I'm interested in your paper. I'm interested in your work. I would love to come and work with you to establish such service." So we got connected, and he moved to Abu Dhabi from UK, from King's College, and we started a different ride, as I'm going to describe to you in a few slides. So in this paper, we describe, the need for expansion of palliative care provider. And again, if you're trying to make a difference, you have to start first by analyzing the current situation. You have to acknowledge the challenges. You have also not to be defensive, you have to acknowledge what are the shortages you have. So we address the issue that there are some shortage of palliative care providers. There's a need for a national cancer control plan to be part, the palliative care has to be part of it, which we were able actually to achieve as well. Education, training of the healthcare providers. I'm going to show you examples, and also some regulatory barriers like home morphine pump regulations and rules. We have to work with the regulators trying to address these issues. So we also published another paper that, about the cancer care in UAE, and also we addressed the challenges with palliative care. So we kept publishing actually about the palliative care, and also we kept talking to the regulators. We kept also getting some support from our colleagues in the health system. And also we published another paper, or actually a chapter in a book called Palliative Care. And we focused more about the financial challenges when it comes to the palliative care in the UAE. There are some barriers and some challenges which was never addressed before. By the way, these publications are the first publication with the palliative care in UAE. And we're very proud of this because, again, it started the movement about how can we make a difference for cancer patients, and also other diseases requires palliative care in the UAE as well. This is a paper from my colleague, Dr. Neil, that I mentioned his name earlier, and he wrote this update about the state of the palliative care development in the UAE. And certainly this actually diagram shows the progress of the palliative care. Tawam Hospital 2007, American Hospital in Dubai 2015, 2019 Medical Clinic in Dubai. And we're very proud to have the first palliative care service in the city of Abu Dhabi, that's in Barjeel. We established the service, and I'm going to show you our result actually in a few slides. So in this paper, a description about how did we work with the regulators trying to advance. Dr. Neil also is part of the Department of Health Palliative Care Task Force, where they advise the regulators on how to improve the palliative care for our patients. Also, discussion about the formation of UAE palliative care special interest group or a society, which is also very important to advocate for this specialty. Dr. Neil actually was appointed as for the first time representative at the WHO Palliative Care Network, and he's actually going today to Cairo to represent the UAE. Again, this is a very important step for us in the UAE and how to connect with the international network as well, trying to get from their experience and how to improve the palliative care in the UAE. This is actually the latest publication we published, maybe I think in August. What we did after we started our service, which is the first service of palliative care in Abu Dhabi, we start to describe what we have done so far. So within 9 months of being operational, we did a retrospective review, and we have around 300, I think, patients. Half of these patients actually they were local patients from the UAE, and you can see the different type of cancers. Most common actually upper GIs, also colorectal and breast are the top 3 cancers that we dealt with, and also the reason for referrals were mostly pain control, other symptoms, and also end-of-life care. 360 referrals with 85% of these patients actually having diagnosis of cancer, and 90% of these patients actually they had a valid do not resuscitate or DNR order in place, which is again different than what we've seen like maybe 10, 15 years ago. DNR is a difficult situation. But from this actually, from our experience, we are still having challenges with the palliative care delivery in our region, but certainly things has been improving through research, collaboration, advocacy as well for the specialty, and certainly we are planning to actually publish our a cumulative experience. We're reaching more than 580 patients in our cohort as well. This is our upcoming paper, should be published anytime soon. And again, we're talking about the state of the cancer care in UAE. We addressed every single aspect of cancer care in UAE to the best of our knowledge. And we definitely, palliative and supportive care is something very critical that we addressed, including the DNR status as well. So moving forward with the palliative care in UAE, this can be done through different ways. And this is from our latest paper. It's about advocacy, formation of the Emirates Oncology group or society, education for the healthcare providers, for also to include the palliative care in the curriculum, the undergraduate, access to medication. Some medications are not easily accessible. I remember the first time I came from US, I prescribed hydromorphone, and they told me, what's hydromorphone? We have morphine. I said, no, there's something called hydromorphone. So it just tells you like, sometimes how difficult, because you assume things are actually ready, but it's not ready. So we actually came a long way now. We have many medications. We created a list of medication that we need, and we do have access to medication easily. If you don't think about it, if you are not comfortable using the medication, of course, you will not prescribe the medication. So certainly the experience is very critical. Advanced care planning is also another way, and funding definitely with the health insurance, it's very critical to also think about home care and also hospice, which actually a concept that's not really mature in our region. Also, the 2016 federal decree law is very important about DNR. It does require some revision, hopefully in the future, to make it easier for physician, because sometimes difficult for physician to make the call, because should you continue medical treatment, should you keep the patient on the life support if they are DNR. So there are some issues that we need to address, but certainly that we are very proud to be the first ISMO accredited in oncology and palliative care actually center in the UAE. Also, we are getting more and more, palliative care staff trying to support our patient, and we are moving a little bit now to the concept of the hospice, which is again very challenging when it comes to the reimbursement from the insurance. We are also part of the Emirates Oncology. We are the Emirates Oncology Society, collaborating with the Dubai Health Authority as well, trying to advocate for different issues related to cancer and oncology, but definitely palliative actually one of our priorities. And this is from us last month, working with the UAE Ministry of Health, and palliative care was one of the top actually issues that we addressed, plus the MDTs has to be mandated for any patient with cancer. We are actually advocating for these two big issues. So palliative care training, this is a survey from one of our colleagues, Dr. Thana. She interviewed 11 program directors in the UAE, and she assessed their knowledge and experience about the palliative care, and also their insight about the specialty. And certainly there's a huge gap. So this is the area of training and education. It's a must that we have to address. If you are not exposing your trainee to this specialty, certainly they will be lacking the skills to be able to take care of the patient. Also, they will not be able thinking about this as a subspecialties in the future. What we did also at the Emerson College Society, we did multiple series of webinars. This was last year, where we actually did an online educational activities. We covered different topics: introduction to palliative care, symptoms control, early palliative care, management of breathlessness, psychological support, goals of care, and also medical legal issues. We have done this last year, and also we've done this again this year. And actually it did, we had, hundreds, maybe even we reached thousands sometimes of attendees. So there's an interest to learn more about palliative care. Also, we're planning for the palliative care working group or society, and this is work in progress, and hopefully this will be done, inshallah, in the next few weeks. And regarding our book, which we published 6 months ago, the palliative care, actually, we dedicated a palliative care chapter. By the way, you can download this book for free. You can Google Cancer in the Arab World. You can download it completely for free. And we dedicated a complete chapter of palliative care in the Arab world, written by Dr. Hiba Uthman. And if you are in palliative care, you know this. She's a big name from Harvard University, with Dr. Rana Yammout as well. And again, they highlighted the challenges that we have in the Arab region. And I will definitely recommend this chapter for anybody who's interested in the palliative care specialty. This book has been highlighted before in the ASCO post, and this is something we're very proud of as well, and has been highlighted also in the UICC website. And we have our book, Cancer in the UAE, coming hopefully, inshallah, first quarter 2023. We do have a special chapter about palliative care, which is also something we're trying to update the status of the palliative care on a regular basis. So when we go to the regulators, we show them these are recommendations. And definitely when people, when you keep pushing for a concept or a specialty, or even trying to advocate for palliative care, you require some support, evidence and support. Definitely that, if you have data, will be even better. My next project is Palliative Care in the Arab World book. This is something is work in progress. I discussed with Dr. Maha already. We will be getting actually a chapter about each single country in the Arab region, inshallah, and certainly we'll be having some special chapters, especially about pediatric population, which is actually they tend to be forgotten in the palliative care. So this is my project that we're planning to do, inshallah. Hopefully, if things goes well by the end of next year. And to summarize advancing palliative care in the UAE, and again, this is very similar to what we see in the GCC, national health strategy and implementation, medication availability and accessibility, training and education is a must, multidisciplinary team to decide when patients should go, and sometimes maybe palliative care has to be implemented very early, as we know from the Tamil study from New England Journal of Medicine paper published in 2010. It does improve survival in patients with lung cancer, and also we've seen GI cancer, but certainly we do advocate for early palliative care and supportive care. Home care and hospices also a very important aspect, and public palliative care awareness is also the way to go. With this, I would like to thank you for your attention, and I'll be happy to take any questions.
Thank you, Professor Hamid. I think we'll leave the questions till the end at the panel discussion, if that's okay. So I'm going to move on to the next speaker. So the next speaker is Professor Samar Rahmoud. She's a consultant colorectal surgeon in King Faisal Specialist Hospital and Research Center, the Department of Rectal and Colonic Surgery in Riyadh, Saudi Arabia. She's the professor of surgery and has been awarded at the King Abdulaziz Medal of Honor at of the first class by the custodian of the two holy mosques, King Salman bin Abdulaziz Al Saud of Saudi Arabia in December 2018 for her outstanding contribution in the field of research and cancer. Please welcome with me Professor Samar Al-Mahmoud, who will be talking about colorectal screening in Saudi Arabia. Professor Samar is joining us virtually.
Yes. Can you hear me? Alex Salam. Can you hear me?
Yes, perfectly. Yeah.
Good. Yeah. First of all, thank you very much for the organizing committee and Dr. Aisha. My apologies for not being able to attend in person. I broke my foot, but I hope I'll be able to present, virtually, and next time I will be in person. Can I share my screen? Yeah. Can you see the slides? Can you see my slides?
Yes, we can.
Yeah. Bismillah ar-Rahman ar-Rahim. So today I'm going to give a quick highlight about our current situation of colorectal cancer screening in the GCC countries. I have no disclosures. I think this lecture will complement what Dr. Saleh Al-Uthman presented yesterday. As you know, colorectal cancer is one of the most commonest cancer worldwide. According to the GloboCan 2020, it accounted for 10% of overall cancer, and it is the third most common cancer worldwide, with almost 2 million cases diagnosed in 2020. Mortality-wise, it still have a high mortality, almost up to 1 million, and it is the second most. If you can see, it is the second most common cause of mortality from cancer, in spite of being a preventable disease. The world age standardized rate in 2020 for men 23.4 per 100,000, and for women 16.2. What about our GCC numbers? You can see we are getting there. It used to be the age standardized rate is much less, and now with aging population, it is 11.5 in male, and it's still the most predominant cancer in male for the last few years. It is the third in female with age standardized rate 8.6. You can see now the trend is increasing of incidence over the last 20 years for both male and female. And as I think Dr. Saleh highlighted this yesterday, you can see that in spite that the incidence is not as high as breast, and still colorectal cancer is preventable, but the mortality is high in comparison with the incidence. And if we compare this to the breast, although the breast incidence is really very high and it's not as preventable as colorectal disease, but the mortality is still less than colorectal disease. And this is expected to increase by 2040 due to longer life expectancy, especially in our region, because we are a young population. Increase in the population, we have now better detection and registration. And most importantly, I think in our region is the current change in the behavioral and lifestyle. We can see a trend in increase in unhealthy diet, increase the incidence of obesities or prevalence of obesities and smoking, and the physical inactivity. As I said, the prediction of colorectal cancer by GloboCan that it will increase by almost 60% by 2040, with almost double the number for colon as well as rectal cancer. What about the GCC? These are the predictions. You can see the other half, that the predictions for 2035 is also going to be increased for male and female. And not only that the incidence is going to increase, I think one of the audience has raised up this question yesterday, that we are still diagnosing cancer in a later stage, where the percentage of localized is less than 25%. And this is even a better number from before, where it used to be 19 and 18. So there is a lot of work also that we really need to address in this area. So what about the colorectal cancer screening in the GCC? It's have been introduced just recently in the last few years. Is not similar to the breast cancer that is very well established. Most of the program are opportunistic, but very well organized in some of the countries. They are still not a population-based for an average asymptomatic risk individuals, and the age varies starting from 45 to 75. Some of them even start at 40. So we are starting at a younger age than what the international recommendation is. And most of it is fecal immunochemical test, FIT-based, and some countries are colonoscopy based, and they are self or through self or physician referral, not through a population invitation yet. When I was preparing for this presentation, and also, we had a paper that was published, there was a lack of data, to be honest, in the literatures, as well as the official websites of in some of the countries regarding the colorectal cancer screening. Some of them are very well organized and easy accessible for the population. Others still, they are difficult to access, and the website is not up to date. And I think hopefully through this lectures, things will move forward. So this is a table that was just published in our paper last week in Lancet Oncology regarding the current situation. As I said, it was very difficult to obtain such data, but if you can see, the majorities is between the screening start from 45, they are through self or physician referral, FIT-based. I think Kuwait is colonoscopy-based. Oman has both. Frequency for FIT-based is annual or biannual, and for colonoscopy every 10 years. And they are available through all primary healthcare centers and other hospitals and Ministry of Health hospitals. So what are the current challenges for the colorectal cancer screening? I think still there is several factors, which is the fear from the difficulty of the exam from the populations, the fear of pain, embarrassment, and most important, lack of awareness and misinformation within the population. There is some socio-cultural barriers. Some of the primary healthcare and GPs said that due to the lack of time, to promote the screening for individuals, this is one of main barriers to help promoting screening. As I said, also the availability of the current situation of our screening services, the uptakes, what are the challenges, and as well as the resources available. This is a paper that was published from Qatar a few years back, was addressing the barriers within the population, and they found some of the factors is patient ignorance, fear of the possible pain, the bowel prep itself, and if in case of colonoscopy, the result of the test, the embarrassment, as well as the primary or healthcare provider ignorance or not promoting for screening, as well as an important factor is the family relationship, especially with in our region, the inter-family marriages. So the uptake is still very low rate within our region. And as I said, unfortunately, there is few data published with this regard. There is no data on the recall, for cases for screening, as well as their colonoscopy uptake, how much people went for colonoscopy after FIT positive, and timely referral of positive patients, access to healthcare after treatment, as well as the treatment of the precancerous or polyps, the available infrastructures, cost, the quality of screening itself. Still, we don't have much data on this, as well as the effect of cancer incidence and survivals are also, especially the survival, are not currently available, so we can assess such an intervention and its impact on incidence and survival. I think someone raised up these questions that we are presenting currently a lot of data and incidence and so on. I think it's very important to have such data in order to know the effect of such intervention in the future. So these are some of the few literatures that I found. For example, this is a study from United Arab Emirates that shows in Abu Dhabi an uptake of only 23% of eligible population between 2015 and 2016, with the 13% has positive fit, but only of which 30% has went for a follow-up colonoscopy. Another study in Qatar showed also better, but still below expectation of 30% uptake with 0.2% positive fit. This is a study from France. I just highlighted this study in order to help in promoting colorectal screening, as I said, through our primary healthcare system. What they did, they have 3 arms: the usual care, where they send them invitations, the generic reminder, which what they did, they send a general reminder to all GPs to, in this area to promote for screening, and then patient-specific reminder, especially, for people who did not screening before. And what they found that the participation rate was better with the specific patient reminder than the others, although they said it's a small improvement, but it was significant in patient participation. This is all, we have low uptake on all these issues, and this is all even before we had the impact of COVID. As you know, it has a major impact in all health services, including screening, where more than 155 countries have halted all their screening. And not only this, after the improvement of the pandemic, there was a difficulty of reinitiating such services in some country, leading to higher cost, as there will be diagnosis of colorectal cancer in advanced stages. And I think the result, unfortunately, will not show up soon, will not show up in the next few years. For example, this is a study, a national population-based modulation study in England, that estimated an increase of 15 to 16% in colorectal death up to year 5 after diagnosis. This is compared to the pre-pandemic data, urging policymakers to reduce the waiting list for treatment and diagnosis. Another modulated project showed that a 6-month suspension can result in an increase of more than 2,000 cases of colorectal cancer, with an excess of almost 1,000 deaths. This is a paper from Italy. The aim of showing this paper is that what they did is, during the pandemic, I think between March and May 2020, they did not stop in one center the colorectal screening, but they highly selected fewer patients that high risk for screening, and they compared their result with the year before the pandemic in 2019. And what they found, that in spite of having fewer cases, but the diagnosis of invasive cancer was much higher, as 8 versus 1% for the year before, as well as the high-risk adenoma was higher, 47 versus 25%. And this is definitely due to the higher selection of high-risk patient and prioritizing the more high-risk patients. So what are the current recommendations? I think we still have to improve our current survival data to know the effect of such intervention in the future. We need to assess our current situation and the cost-effective analysis. I'm more than happy through this meeting to collaborate with the, my colleagues from across the GCC countries to try to address such an issue. Such data is needed to scale up our current programs to a national base screening program. We need to invest in strategies to improve, as I said, at the same time, the early diagnosis, improve timely access to healthcare, raise both public awareness and healthcare education. Assess what we need, also assess the population acceptability and what are the challenges and how can we address it. Quality assurance of the current test we are doing, build a future infrastructure. I think the problem, we are still have lower incidence of colorectal cancer, but what we need to do, we need to act for the next 15, 20 years, and we have to be ready by that time. And as I said, we need to encourage publishing more data with this regard. This is one of the advantages of having COVID, is that the awareness was better due to utilization of digital platform, where community was able to be reached and address and counsel due to digital platform. As well, maybe we need to sometimes prioritize the people for risk and taking focus on high individual risk. And we need to be flexible with the method of our screening. For example, for colonoscopy based nowadays, if they can go to FIT in order to increase the uptake. This is a couple of the paper that we published, and I would encourage that to have look at it. And this is the published in the last Lancet Oncology last week, and we set up a few recommendations, of which that we needed to invest in establishing and developing cancer diagnosis and treatment infrastructures, engage with the private sectors and provide evidence-based, timely and affordable treatment, develop key indicators and metrics to monitor and evaluate both treatment and screening programs, evaluate our current screening programs, similar to what they are doing for the breast, to assess the challenges and the requirement to fully implement population-based program and ensure quality improvement, assess and improve timely access, invest in capacity building, develop a multi-level approach to assess our current service and improve our current research. So in conclusion, I think it is very essential to assess our current screening programs in order to help planning our future integrated approach and strategies for full cancer control policies that will cover prevention, early detection, treatment in order to lower our future burden of colorectal cancer. Thank you.
Thank you, Professor Al-Hamoud, for a very interesting and definitely a topic that is very important. So please welcome with me again, Professor Hamid Al-Shamsi, who is going to talk about a topic that we are all as oncologists, and I think anybody who works in the oncology field feel very strongly about in the GCC, is oncology clinical trials in the GCC. Is it possible?
Yes, the answer is yes. Let's see how can we do that. So thank you again for the chance to speak about clinical trials and research. And you will hear some things you may not like, but we need to accept the facts so we can move forward. This is my disclosure. So I'll be talking about what's research, why is it important, maybe important for the person, for the society, for the country, for the system, also the challenges in the GCC, in the UAE as well. And also I will have a quick review about the cancer research in UAE over 40 years as well. So according to the National Cancer Institute, actually, because of the research in the US, there has been decline in the mortality. And definitely, if you are doing research, if you are implementing the latest advances in the care for the patient, this will improve the mortality. As you can see, for example, this is like the very high income countries where the research is mostly done. And also you have the low medium countries. If we look at the breast cancer, for example, where there is a lot of, or I should say, a higher incidence of breast cancer. If you look at the green arrow, when you look at the mortality, it still remains lower than what you see in lower or medium income countries. And this is for so many reasons, including access to care, but also certainly research does play a role in that. So what's research? Research systematic investigation, including research development, testing, evaluation, design, to develop and contribute to the general knowledge. This is just a general definition of research. What about cancer research? Cancer research, according to the Canadian Cancer Society, it's a slow step-by-step process that involves collecting, analyzing information from the lab research and studying people with cancer. And there are different types of research, basic, translational, clinical, population. This is out of our scope, just to highlight different types of research. And where do cancer-related research stands among other specialties? In 2021, you will not be surprised to see cancer research actually is one of the most common research between different specialties. And you can see the green color at the top being non-industry sponsored, but definitely the industry sponsored is bigger. It's a huge business, brings lots of money. Certainly everybody will be interested in that part. So what's the goal? Well, the goal is to prevent, detect, diagnose, treat, and also ultimately cure cancer, and we are very successful in curing some cancer because of the research. And again, there'll be multiple studies, especially the Hodgkin lymphoma study shows you the progress that's been happening in the landscape of cancer, where a cure can happen because the progress in the clinical research. So why should we do research? And I'm talking now about an individual and also talking about an institution. Well, it does improve the cancer prevention, and also you will have an access, especially if you're doing clinical trials, you will have an access to early medication and drugs, which may not be available until multiple years or few years in advance. And as a physician, you will be able also to know how these drugs work. You will be also exposed to these toxicities, so you'll be able to have experience with these medication and the ability also to have more experience about these drugs in the future as well. It does help someone's career. There's academic and international recognition. Also, there's a personal satisfaction when you submit a manuscript, and at the end, it takes a long time for acceptance. It does feel good, actually, especially if you get acceptance without revision, which never happens to me, but hopefully one day it will happen where you can get acceptance. So it's really satisfactory that, you know, you are contributing to the science. And also, I'll give you an example where we have a paper which was rejected first time, but the rejection is fine. When you are rejected, you give these feedbacks, you use them to improve your manuscript. And this paper has been cited more than 600 times already over the last 2 years. And it's been recognized also as one of the most, cited papers by the oncologists. Also, when you have citation, this helps you to understand how important your work. If you are publishing and you're not getting citation, there's a problem. If you are publishing and you're getting citation, definitely on the right track. And this can help you also to contribute to the general knowledge that for the humanity and for patient in general. When we look actually at the return on the investment, when you see the black color is actually how much is the country is spending, and the lighter color is how much is the country is gaining back from the investment. As you can see from the US, there's a huge investment, but also there's a huge return. What you see in Japan as well, also in European countries. In our region, we don't have much data about that. What about the spending on the research in the Arab world? Can you see the Arabic countries? You can, but it's going to take you a few minutes to zoom in and look a little bit closer. Saudi Arabia is there, Qatar is there, Egypt is there, but certainly you can compare what we are spending as countries, on the research. Definitely, we are not spending much comparing with other countries, and that's why what we see actually we are getting latest innovations and drugs coming from the Western countries and Northern American countries as well. We will look at the spending based on the research development as a share of GDP. You can see what we have a lighter color, which indicates less spending. Dark colors indicates higher spending. Certainly, we're not spending much again, which is the same message. So what about the cancer research in the Arab world? Well, there are multiple studies and publications looking at the output from the Arabic region. And in conclusion, I don't want to spend too much time, but the conclusion is the Arab world specifically lags behind in the research output, despite some improvement. There's some improvement, and I'm going to show you some numbers as well. But definitely, we need to do more when it comes to that. When we look at the countries actually with the more recent, and this is general research, not only oncology, you can see Egypt, Saudi Arabia, Lebanon, and Tunisia, they have higher numbers of research that, registered at clinicaltrials.gov. In our book as well, we did have a specific chapter about the cancer research, and this was led by Dr. Randa, and again, highlighted very similar issues that we are aware of about the challenges, and also there's, and I will do encourage everyone to read this chapter if they're interested in the cancer research in the Arab region. The most common cancer research, it's around breast cancer, which is very, understandably, because this is the most common, followed by colorectal cancer. Let's talk about cancer research in UAE. Again, we try to highlight the challenges that we have with the cancer research in the UAE. And what we did actually, we did analysis over 40 years where we searched the PubMed and also other search engines to find the papers related to the cancer in UAE. And this is actually the graph. You can ignore 2021 because the study or the analysis was done last year. But you can see there is ongoing steady increase in the number of publication. But what are we publishing exactly? So before I do that, there's only 16% of research over 40 years in the UAE was with international collaboration. And what are we publishing? Lots of lab, our basic science, review articles are many, descriptive, analytical, and others. So you can see the trend publication by study type. When we look at where the publication are being published, 82% are published in impact factor less than 5. The graph actually doesn't represent very well, should be, the blue color should be much lower, 17% only in impact factor more than 5, and 0.17 not reported. When we look at the publication citation, so we have around 144 publication had no citation, 993 publication had around 200 or less citation. Only few publication had more than 400 and 600. Again, the highest citation shows you how important the work is. So we don't have much, citation happening in hundreds in this from the UAE research. Cancer research in GCC, and again, please don't be upset with this. I did analysis where I actually searched the clinicaltrial.gov for cancer-related research in the GCC. And this is actually part of our ongoing publication we're planning to publish. Saudi Arabia, mashallah, they're sky high. And again, Saudi Arabia, they do have lots of, research activities and infrastructure. And I'm going to show you now, there's the Gulf. There you go. So UAE is 25 publication registered, the clinicaltrial.gov, Bahrain, 2, Oman 9. Again, there's lots of work needs to be done when we look at the cancer research in our region. And definitely we can learn from Saudi Arabia and their experience when it comes to cancer research. So let's talk about what's the problem. And this is a paper should be published maybe tomorrow, day after tomorrow, inshallah. And in this paper, I try to analyze the challenges that we have in the UAE. But to be honest with you, this is very similar to what you're going to see in the GCC as well. So I tried to do a 360 overview. We have a problem with the physicians or healthcare providers. There's a problem with the patient. There's a problem with the system. There's a problem with the regulators and also the global oncology community. And also we have issues with the pharmaceutical industry barriers. So there are some barriers we have to address one by one. When we look at the healthcare providers, I was speaking with one of my colleagues before the lecture, and she was telling me we have too much work, we don't have time to do research, and this is a very valid reason. If you are seeing patient every single day, you have no protected time. Definitely, the rest of the time you're trying to spend with your family, trying to get the quality of life, so you will not be thinking about research. Certainly also the lack of training of physicians and healthcare provider, if they're not getting enough training in their educational or fellowship training, definitely research will not be part of their mission and vision as well. Also, if they don't have any leadership trying to support them, or mentorship, I should say, trying to support them to do research, if you have no knowledge, if you have no experience, and you have no support, definitely this is personal motivational factors would be very low. Also, financial incentive. In fact, most people they publish, they do pay out of their pockets sometimes, or most of the time, to get things published. So really, it's not very financially, rewarding unless you're doing phase 3 trials, registration trials. Definitely, there is some financial incentive for that part. Institutional barriers. You're fresh, you're excited, you're coming from somewhere, you want to do clinical trials, but your boss has no idea about clinical trial. So what do you expect? Do you think he's going to support you? Maybe if you're lucky, but most of the time you will not be supported because you are a threat. So you shouldn't be doing any clinical research. And this is part of the problem. If you have a leader that not into the research, definitely you will not be able, or I shouldn't say definitely, but it will be harder for you to achieve your goals. Lack of research programs in your institutions or clinical trial unit. Also, many institutions, unfortunately, they focus on financial targets like getting more patients, getting more money, and they're not focusing on the research. Also, lack of promotion related to research productivity for many settings, except the academia, which is definitely linked, but many others, private providers or other health settings. If you are doing research or you don't do research, it doesn't make a difference. You'll be getting your salary and you're not getting any difference. So really, there's no need for that. Also, the competitive mode between institutions, physicians also can be a barrier and a problem. Definitely, this can affect negatively the ecosystem of the research. I'll give you a very simple example. This research, very simple. What we did actually was doing a swab for patients for COVID-19 before each chemotherapy cycle. Very simple idea, but at the time, at the beginning of the COVID-19, it was a brilliant idea. That's why we got this to JAMA. I invited two different institutions to work with me, actually, to trying to get higher number of patients within short period of time. And both of the institutions gave, okay, give us the proposals, we'll think about it, and we may get on board as well. After some time, they said, sorry, we're not gonna do this, good luck. We decided to go ahead. We had, I think in this study or this research letter, maybe 79 patients, but hey, it went fine. It was one of the most viewed articles in JAMA Oncology. Also, it was a trending article. And again, it was also highlighted in ASCO post, so it did very well. The problem is the two other institutions, they published exact same idea after we published. And actually, one of them came back to me as a reviewer from the journal. So this was actually discouraging for me to try to work with these partners again in the future, because again, you have to have, some honesty with your partners. If you're willing to work with them, if you're not, you cannot really take their ideas, or we can call it stealing. Like, this is stealing of the ideas. But again, we have to work together, even though there are some challenges. We really have to work together, and I'm going to highlight the importance of collaboration at the end as well. What about the regulation barriers? Definitely there are barriers everywhere. When we talk about the UAE, things actually has much improved over the last few years. Now we're getting approval within a week or 10 days for phase 3 trials. And this trial, actually, this is a registration trial for the thalassemia study. If the approval registration trial, we got the approval within a week. And certainly this is a significant improvement milestone from 6 months, 8 months, 1 year. We're getting this within a week or 2 weeks. And what about patient perspective? Patient, they travel to the US, they travel to the Europe, and they don't mind being part of the clinical trial. But when it comes to the patient here, دكتور يعني بتجرب علينا احنا مش في ايران تجارب, which is understandable because actually we are not talking about, we are not convincing our patient. We don't have any strong PR campaign to trying to teach our patient, especially in oncology, best treatment for cancer patient is a clinical trial. So lack of understanding, fear of experimentation and trust issues, and also definitely this will lead to the lower acceptance rates. So our patient, actually, it's hard enough for us, I'm talking about the UAE, to convince them to stay in the country for treatment. So trying to convince them to be part of clinical trial. And I see Dr. Aida, she's nodding. It's tough. Global oncology community barriers. Well, this is, in my opinion, and again, this is part of our discussion with our own group, there's some lack, I wouldn't say lack, there's some lack of trust in the research capabilities in developing countries for various reasons. Exclusion of developing countries research from the research network, which happens often. Lack of support for publication from developing countries. You submit, they reject, publish in your own journal. I don't have my own journal or region or journal from my region. Then I have to submit to lower impact factor journals, unfortunately. Pharmaceutical industry barriers. Well, they don't actually come to us because there are some issues. They're concerned about opening the trial. They're concerned about the accrual, which is actually also maybe a bigger issue in the UAE because we have a smaller country. Absence of the quality audits in local, international. Also the concern about the research capability, even though one of the largest trials about COVID-19 was done in UAE, and it was the largest actually COVID registration trial for the vaccine as well. So what are the research opportunities for oncologists in practice in the GCC? Actually, there are so many. There are some basic science, preclinical, related to our patients. We really have to think about our own patients. And we've done some work before. I didn't highlight here that we showed some differences in the gene mutations, somatic mutations in breast cancer and also colon cancer, epidemiological studies. There are lots of lacking data. For example, myself and Dr. Aida were trying to work on neuroendocrine tumor, and can you believe it? There is none. Like there is none neuroendocrine tumor data from the Gulf. Hopefully we're going to change this and we'll publish our data soon. But we have lots actually to achieve. And sometimes publishing about the incidence, some say, okay, it doesn't matter. It does matter because we need to know what's happening on the ground. So we know if our actually screening working, if our other modalities is working, if we are having a true incidence of increasing of the cancer, we do have to have epidemiological data. Clinical studies, it can be investigators initiated, data-driven studies, pharmacoeconomics and policy, guidelines and consent. And next slide, I highlighted the easy, simple things that you can do and it can make a difference. Retrospective data collection, for example, you can publish about neuroendocrine tumor in Saudi Arabia, in Bahrain, there is none. Trust me, it does help us to understand the disease. And this is just a quick example. Survey and patient-reported outcomes. We did a survey in the UAE about why patient doesn't want to go to do screening. And it was the largest screening survey. It was done within a week. Again, you can use social media, you can use different platform, but this gives you an insight how to improve the uptake for screening. For example, reviews, editorials, it can be done. You just need to do some partnership and collaborate with others who has an experience in this, and you can publish it in the good journals as well. This is just highlight from our publication. Again, I keep going back and forth to this one because really there are so many people invited to this work and they told us it will not happen. And again, if you are committed and you keep working hard trying to achieve this goal, alhamdulillah, last night reached 230,000 downloads, again for free. We're trying to increase the knowledge and experience about the cancer research in the region. So what's next? We try as a group in the Emerson College Society to talk about clinical research. We had an event, I think in September. We talked about the barriers in oncology and clinical trial, and we're trying again to discuss it, trying to bring some solutions. And we're planning actually also, again, this is our upcoming paper. We discussed the research output in the UAE, and we showed also the trend of different hospitals and what research they are doing in the UAE. And also we included some recommendation to include research as part of the National Cancer Control Plan, which also been submitted to the regulators in the country as well. And the Emerson College Society we are establishing actually the clinical trial research group, which is actually also something we're trying to advocate for, which establishes the palliative care and also the clinical trial group. We established the first cancer research group in the UAE. We're not doing any preclinical research. We're doing mostly clinical research related to the patient. And this actually was the first study, phase 3 study, which has been approved and started in our center. And again, this shows you, the effort we're trying to do to bring clinical trials, FDA approval trials, to the UAE and the region. Again, we do have a special chapter about cancer research in the UAE in our upcoming book. And also we do have our book about healthcare, where we highlight also some of the challenges about research in general, not only in oncology. And hopefully this will be published, inshallah, in the first quarter of 2023. So to summarize, definitely, the cancer research in the GCC still evolving. There are some countries are ahead of other countries. Quality of research needs much improvement. Easier data access, open data is a problem. So hopefully this will improve. More research fund is needed in cancer, especially. More collaboration is a must as well to improve the outcome of our research, and also research training program, mentorship trainee, and early cancer career physicians also required. There's a need to collaborative effort from all the stakeholders to address all these challenges. Public awareness about clinical research. Pharmaceutical companies must work closely with institutions to improve their research capabilities. Institutions, both private and public, they have to work together, trying to overcome the competitive mode, trying to improve the research. So successful research needs collaboration. Only remember this slide. Don't remember anything else. Don't worry about being the first author, second author. senior author. Just worry about how good this research is going to be and how important this research is going to be and what's the impact of the research. And one day you'll be first author, second author, you can alternate, you can be the senior author, you can be co-authors as well, first author. With this, I would like to conclude, and I would like to thank you for your attention and thank you again for the invitation.
Thank you, Professor Hamid, for an excellent talk. I think I'm sure we all have a lot of questions and we'll leave them till the end. And now it's my absolute pleasure to present Dr. Khulud Saad for the next talk. Dr. Khulud Saad has obtained her Bachelor of Medicine and Surgery from the Arabian Gulf University Medical College in Kingdom of Bahrain. And then she went on to receive certificate in Arab Board program in pediatrics. She has completed her clinical fellowship in pediatric hematology and oncology from the University of Toronto, and is working as a consultant in pediatric hematology and oncology in Salmania Medical Complex. She is the coordinator of pediatric oncology unit at SMC and the only pediatric oncology unit, which is the only pediatric oncology unit looking after children with cancer in the Kingdom of Bahrain. She was awarded from the Ministry of Health on the occasion of Bahrain Women's Day for her contribution to pediatric oncology. And she's also an advisor member for Ibtisama Group of the Future Youth Association for Psychosocial Support of Children with Cancer and their families. Dr. Khulud Saad, absolute pleasure to have you with us. Looking forward for your talk.
Thank you very much, Dr. Maha. Just correction that I was the coordinator of the pediatric oncology unit, not anymore, because I'm working now as a part-time. Dr. Amira is the coordinator currently. I would like to thank first the scientific and organizing committee for inviting me to participate in this lovely conference. And I'd like also to thank the audience who are, the audience who are still sitting and excited to continue the sessions, though it's late and I know you are feeling tired by now. Having a chance to present about pediatric oncology within a conference with a lot of talks from adults, I'd like to thank the committee for that, because having a chance that it's like collaborating with the incidence of pediatric oncology among adult cancer as well. So my presentation is about childhood. Children are not small adults. Be aware of childhood cancer. And I promised for two things. My presentation will be light and digestible, and because I know it's late time now, and it's going to correlate with the theme of this session, which is closing the care gap. I have nothing for disclosure. Children are, yes, they are not small adult because there are characters, the children having it. They have a different and unique exposures. They have a dynamic developmental physiology, and they have a longer life expectancy. And as you know, they are also politically powerless. And because of these characters, you will see how it also will affect in the coming slides about the cancer in children. Though there are differences between children and pediatric, but they do share that the World Cancer Day and the Childhood Cancer Day celebration of them coming in the same month, which is February. So the World Cancer Day was on 4th of February with the theme of Close the Care Gap, which is the same theme of our conference today. And the Childhood Cancer Day coming on 15th of February, with the theme this year was Better Survivor is Achievable Through Your Hands. And I thought to combine the two themes together, saying that through your hands, we can close the care gap and reach to a better survivor all over the world. And your hands is not only a pediatric oncology, but it's for the whole MDT members, as well as to primary, secondary, and tertiary care healthcare providers, as well as to the community, NGO, as well as to the decision makers of the governments and ministries of health. This is the outline of my coming slides. We'll go through the difference between children and adult cancers through presenting total of 15 facts about childhood cancer. The first fact saying that childhood cancer is a rare disease, and this figure can show it. If you see here that among years, the two lines here or colors, the green and yellow, is showing the percentage of children cancer below the age of 15 if you compare to the other age group of adults. And this represents 0.5 to 6% according to geographical areas and the age group including. And if you notice also that the green part, which is the cancer in children below the age of 5 years, this is the age of a preschool, which are usually seen and screened usually in the primary care, and they are getting when they are getting their vaccinations. So awareness, that's what we'll see, awareness of primary care as well important when they can discover malignancies in this age group. If we go to talk about numbers, so every year there is at least 400,000 new cases of cancer diagnosed in children below the age of 18 all over the world. And if we compare it to adults, which can reach more than 18 million per year. Going to incidence, the incidence for below the age of 14 years is 50 to 100 new cases per 1 million. And if we go to elder age, 15 to 18 years, the incidence is reaching to 15 to 200 per 1 million. Fact number 2 is saying that children cancer is a common cause of death. And actually it shared the same things with adults. If you can see that in children, cancer is coming the second cause of death after accidents and injuries. And the same thing for adults, it's coming the second line after cardiovascular disease. So again, with numbers estimated to have 90,000 deaths per year in the world due to childhood cancer. Fact number 3, these statistics we presented, they are not telling the whole story, because these numbers maybe are underestimated as there is no accurate registry coming from low-income and middle-income countries. And we can see that from this map, we're showing the countries with the green color are those who have more accurate registry of cases, reaching 80 to 100%, while those with the green, with the red colors, registry can be even less than 30% of the cases. It's not only the registry, but also the diagnosis. So children with cancer in these countries, they may die without reaching to a diagnosis. And that's what we can see also in this figure. The green is for diagnosed and the pink or orange is for the undiagnosed. And if you go down, those are for low income or developing countries. We can see sometimes maybe even 50% of cases supposed to be having die because of cancer are not diagnosed. Fact number 4, the majority of children with cancer are coming from developing countries. And that's unfortunate because 80% of these cases coming there. And if we have issues with the registry and issues with treatment and the infrastructures, we can imagine what will be also the outcome. Factor number 5 saying that children or childhood cancer is not one disease and it can grow in any organ or any cell. And it can even infant or newborn can present with cancer as well. If we concentrate on the type of cancers for children below the age of 15, we can see that the most common cancer is leukemia, coming in 31%, followed by brain tumor, which is 25%, than the lymphoma. So if we combine leukemia and lymphoma, which are the hematologic malignancy, are almost 41%. This is followed by neuroblastoma, which is rarely happening in adults, and then renal tumors, sarcoma. And if you can see here the green area, the green part here, which is 4%, including carcinoma, melanoma, which are found in adults. Factor number 6, which is saying that childhood cancer is biologically different disease from adult cancer. And that's reflecting by the type of cancers happening in this patient. So if we can see that the first color, the first part here is for the similar to what we just presented. As we say that hematological malignancy is happening in almost 40% of cases. While in the second part, we can see this is belong to adolescent, also young adults, 15 to 29 years. We can see the hematologic malignancy are coming less to only like a quarter, while carcinomas are becoming increasing. Until we reach to the adults, we can see that most of reported cases here is carcinoma like breast cancer, lung cancer, and other type of cancer, while the hematologic malignancy is coming much less. So there is really much difference in the biology between pediatric and adult. Seventh fact is this: it is still it's unclear why children get cancer in most of the cases, and that 90% of cases with cancer in children, we don't know exactly the cause. 2% may have some environmental factors, but this is definitely much different, totally different from the situation with adults, in which 30 to 50% of adult cancers are related to environmental cancers, such as smoking, lifestyle, chemical exposure, viruses. And if we go back to children, we can see that 8% probably are related to genetics. And this is just a small summary of such examples of the genetic diseases or syndromes can be found in children. And this represents only 8%. So if we want to do a screening for children with cancer, it will be very small percentage of children, those who are having this syndrome. Eighth fact is saying that early symptoms are often non-specific, and actually they can be common symptoms of other common non-malignant disorders. And that's that many cases are found accidentally, either by child's doctor or by parents. They can discover, for example, while bathing a baby, that there is a mass in the abdomen. That's what's sometimes seen with patients with Wilms tumor or neuroblastoma. Many of these symptoms, if we can gather them and describe them by using the acronym child cancer, and this is a somewhat easy way to remember these symptoms. So we have the C, continued unexplained weight loss, headache, often with early morning vomiting, I for increase or swelling or persistent pain, L for lumps or mass anywhere in the body, and D for development for excessive bruising or bleeding or rash. For cancer, we have the C for constant, frequent, persistent infection, a whitish, A for a whitish color behind the pupil, like in retinoblastoma, N for nausea with or without vomiting, C, constant tiredness and dullness, I for any eye changes in vision or the movements, and R for recurring or persisting fever. These are, we can call them the red flag signs. It can be collected in this sort of picture, which has been published by the WHO with the child oncology groups, in order to make it easy for people to remember, either for community or for primary or secondary care as well. Fact number 9, that childhood cancer is a curable disease, and that's very good news for in dealing with the best news we give it for parents when we do disclosure for them about their child. So that's with the major advances in treatment in recent decades, with the clinical trials, with the presence of multidisciplinary teams, improving in the supportive care as well. All these factors has improved the survival of patients over years and reaching in average to 80% or more than that. But this percentage of survivor is changed according to the disease type. If we go to Hodgkin lymphoma, which is the one in pink, it's even reaching to more than 90%. Sorry. Wilms's tumor survivor is going high, up to reaching to 90% as well. Acute lymphoblastic leukemia, the red color. In spite all of them are improving, but still some diagnoses like acute myeloid leukemia still is not reaching to, just reaching to 50% or just above that. Fact number 10, survival rate differs significantly between low middle income countries and high income countries. And if we review, if we saw the same slides, this one actually, it's corrected for high income countries, while for those low income, we can see that their survival is not more than 30%. And this is what we call it, pediatric cancer survivor gap. On studying the causes behind why this gap is there, there are several reasons or factors has been studied over all these countries. And among them, most common are lack of awareness and information on childhood cancer, delay or wrong diagnosis, lack of access to proper treatment and healthcare, cost of treatment in countries where they have to pay, treatment abandonment happening by several parents, and especially in very poor countries, and also the weak health infrastructures in some of these countries. In order to understand these factors, we can go through the journey, the childhood diagnosis journey. When we have a child presented with symptoms related to cancer, by the time the parents seek the first medical advice, that's what we call the patient time. And there are several factors affecting that. It's including the awareness of parents, their socioeconomic status, the tumor biology, if it is a tumor which can grow fast or slow, and also the access to the service. After the first medical seeking, and referral to pediatric oncology, this is the time measured the referral time. And there are also several factors affecting that, including awareness of the primary care physicians and pediatricians who are the first line who will see these patients. And if they are having a high index of suspicion, and also the strength and the clarity of the referral system in the country, which will help to shorten that time. And from the time of pediatric oncology receiving the patient till reaching to diagnosis, what we call it diagnosis time, or maybe that time also include all these times together. There are several factors affecting, including the approach of MDT, because treating these or diagnosing these patients is not only one person, it's MDT, including the lab, the radiology, the surgeon, the oncologist, and also the availability of diagnostic tools and the cost if the patients have to pay. And after the journey of diagnosis, there is another journey of treatment, from diagnosis to treatment to reach to the cure. This is the treatment and the treatment journey. And what factors affecting, again, it's the MDT approach and the presence of a good supportive care for these patients and the resources, and as well as the cost. Just as a break from presentation, this photo, we took it from our unit, pediatric oncology unit in Salmania. And this is more than 10 years back. And we put this information, I am strong, I am a fighter, to keep our kids, because this is the playing room there, to remind them about that. And the gentleman in the middle, this is Dr. Hussein Kharrag. He is the father of pediatric oncology who started the service. And at the back, this lovely lady is Sister Amal. She is also the first pediatric oncology nurse, and we call it her as the mother of pediatric oncology. Going back to the remaining factors, factor number 11, it's well known that its early diagnosis is equal to better survivor and quality of life. Because early diagnosis is a fundamental goal in oncology, it helps us to reach the diagnosis in early stage with low tumor burden, and consequently prognosis will be better and the cure will be attained with less intensive treatment. So even the quality of life and the side effects and the long-term effects will be much less. And the opposite is true. When we have a delayed diagnosis, we will have a heavy burden of disease. And this is that's why in countries with there is no awareness and no good service, we can see that many of the diseases which are common in pediatric here are presented with advanced or stage. Factor number 12, childhood cancer cannot be prevented because there is no non-risk factors, as we know, and in most cases, but deaths from cancer can be reduced if cancer is detected early. So awareness of parents will help for early seeking for medical advice, and awareness of doctors who are seeing these patients in first line, whether in the primary or secondary or even subspecialty, will help to refer these patients early to specialists. Fact number 13, that systematic screening for childhood cancer is not practical, though it's practical, yes, for adults like breast cancer, colon, others, but it's not practical for pediatric because, as we said, it's a rare disease. There are no high-risk groups. So there should be another way, which is the targeted programs promoting early identification. And from that, the WHO had and childhood cancer groups, European and North America, has taken this these programs and initiate several programs. So several years back, there was the Child Cancer Smart, and recently there is the SIOP CDAR project. SIOP is the European International Society, has initiated this project. CDAR, which is Childhood Early Diagnosis and Appropriate Referral, started from last 2 months, and with the help with the title that no child should die of cancer, cure for more and care for all. And this program is planning to put the light on these the common 6 diseases all over the world of pediatric cancers, which are prevalent, and they are also represent almost 50 to 60% of childhood cancer, with a good outcome if they have been diagnosed and early diagnosis and treatment. And we are going to implement this program soon, and hopefully within a few months from now, we're going to initiate this awareness in our country as well. The aim of this initiative is to improve the global survivor among patients, especially in low and middle income countries, from 20–30% to 60%, and improve also the suffering of children, and as well 1 million with this program, 1 million children with cancer can be saved in the next decade. Fact number 14 is the journey after cure doesn't end. There is a journey also for survivors. And as we know, if you remember that we said the children also, they have a life expectancy. And when a child is receiving a treatment at very early age, and they cure from the disease, there is usually some impact of treatment and disease itself on their on them and for the future. So they may have sequelae after cancer, and that depends on the age at diagnosis, on the intensity of the treatment and the stage of the disease. So they may have vital organ dysfunctions, fertility productions issues, risk of second neoplasm because they are going to live more. They are going, and these risks can develop after maybe 10 years from being survivor. Also, the growth and their growth and development from physical and emotional issues will be also affected. So childhood cancer survivors are unique and precious, and they should be followed in the long-term follow-up care clinics, and they get all the support to be an effective members in their community. Such clinics also not necessarily to be carried by oncologists. Actually, they can be carried by primary care or medical doctors who are interested through special training in such program. And there are several protocols and guidelines about follow-up of these patients. This is one of our survivors, and he's putting this that Ana Muharib, and this was part of our some celebrations we did for them. The last fact about childhood cancer is that even if a cure is not possible, the goal of treatment has to be changed to give the best quality of life to the child and his family. And this is the idea of palliative care spectrum, which is, as you know, it's still underdeveloped in our countries. And I wish this is one of the things that should be taken in consideration. We had a lot of talk about palliative care for the last 2 days, and this is the right definition of palliative care. It's the comfort should be started from day one and continue even after the death to be given for the parents as well. So the take-home messages. That children are not young, not small adults. Cancer in children is rare comparing to adults, though they share, in spite of that, they share that it is the second cause of death among children as well as adults. There is a difference in the biology of disease, reflecting by the different of types of cancer. Risk factors which are known in adults are not play much role in pediatrics. And from that, that's why 40% of adult cancers can be prevented, but this is not the case with pediatric. Screening is available for cancer in adults, but it's very difficult for pediatrics. But detection can be improved in pediatrics by more awareness, while it is also the same for adults with also screening program. Survivor is high in pediatrics, and the cost of treatment is not that is not really expensive comparing to that in adults, and that's something very important also to consider it. More concern is about the long-term side effects of treatment for pediatric, and this is something we have to consider it in selecting the treatment for children, and to think about it's not only cure, but it's a cure with the minimum side effects. And because children, as we said, they are politically powerless, also the history of medications and publication and research is less in children comparing to adults. So my last slide, that because kids, they cannot fight cancer alone, we think that through all hands of everyone will be able to improve the care and cure of children with cancer worldwide and close this care gap between among children with cancer all over the world. Thank you very much.
Thank you, Dr. Khaloud Saad, for this presentation. Definitely pediatric oncology is challenging, and thank you for all your hard work. So there's a slight change in schedule so that Dr. Hassan Jafar can catch his flight. So we might do the Novartis session now. So please welcome with me Dr. Hassan Jafar, who is a consultant medical oncologist. He has more than 25 years of professional experience. He has worked worked in Tuam Hospital, and after that he has relocated to Sheikh Khalifa Specialty Hospital in Ras Al Khaimah. With his arrival at BCI as a consultant medical oncologist, Dr. Jafar has moved up a notch in his career to be rated as one of the frontline oncologists and cancer research specialists in the UAE region. His major areas of clinical and research interest includes breast cancer and gynecological cancer, lung cancer, colorectal cancer, sarcoma, and other solid malignancies. Dr. Jafar has worked on multiple publications in esteemed journal and has a plethora of abstracts and cases presented at conferences internationally and nationally. Please welcome with me Dr. Hassan Jafar, who will be talking about optimizing survival outcome for hormone receptor positive breast cancer. We welcome you in Bahrain, Dr. Jafar.
Thank you, Dr. Amaha, for this kind introduction. Good afternoon, dear all. I would like to thank the organizing committee as well as Novartis for having me here today. So it's really a pleasure and honor. So in the next 20 to 25 minutes, I'll try to share with you the data for CDK4/6 inhibitors in advanced hormonal positive, HER2 negative metastatic breast cancer. As you all know that this is the milestone of hormonal treatment in advanced breast cancer, the first treatment targeting the hormonal therapy in advanced breast cancer by George Peterson, who was a surgeon who did the first castration for a female with metastatic breast cancer. And this was an extrapolation from a mice in the lab where if you do castration, the milk stops. And there is a crosstalk between the ovary as well as the breast. And this is why, so the first patient was operated in the 18th century where there was a transient response for those patients. But the correlation and the response was not known till like 55 years later, where they knew that the estrogen was the responsible mediators of that castration. Another 25 years to develop the tamoxifen, which was the first targeted treatment against the hormonal receptors, and another 15 years to have a commercially available test immunohistochemistry for the ER. And we know that it was also taken a long duration till we have the cut point for the hormonal treatment in order to give the treatment. So this journey, it took almost a decade in order to develop a targeted treatment for the breast cancer. Then we have the molecular era, where we can classify the breast cancer into mainly four main categories, the luminal A and luminal B, where the hormonal receptors, they behave differently to hormonal and to chemotherapy, and they have different outcome. And then we have a lot of targets to the hormonal receptors, the tamoxifen, and then we have the aromatase inhibitors, which inhibit totally the estrogen from the body, letrozole, anastrozole, and exemestane. Then we have the down regulators, fulvestrant, and we have also the oral SERD under development. Then we know that the migesterol and high-dose estrogen has been used earlier in order to manipulate these receptors. But eventually, when we use this hormonal treatment, we see a resistant, and this main resistant, when we block the estrogen receptors, are responsible for the crosstalk between different pathway with the hormonal pathway that led to that resistant. There are many suggestive pathway where you have a cross-resistant that can overcome the response to a hormonal treatment. Among these are the blocker of the cell growth, like EGFR, 2 and 3, FGFR, IGFR, and we have also the PI3 kinase mTOR pathway, as well as the CDK pathway. And because of these advances, we see that in the last 6 to 7 years, we have more than 8 agents targeting these treatments. So the progress in the hormonal therapy has been faster because of the deep depth understanding about the mechanisms of resistance for those agents. If we see the early data for the targeted treatment, the CDK4/6 inhibitors in the second line, we see the primary endpoint, which is the progression-free survival, almost doubled when we use this in combination with hormonal treatment. And we see almost similar hazard ratio of 0.5, which led to the approval of CDK4/6 inhibitor in the second line treatment. Then we have several studies across these 3 CDK inhibitors. Again, you see it, if you use it in the first line setting, you can double the progression-free survival, again with almost similar hazard ratio for these studies. And regardless whether they are having only bone metastasis, whether they are PR negative, whether they are lobular, they all benefit from CDK4/6 inhibitor. And if you see, these are for all the agents, whatever you use it, all the subgroup analysis, they benefit from adding CDK4/6 inhibitors. So we don't till today see a subgroup that they may not benefit from CDK4/6 inhibitors in the first line setting of those patients. And when we consider a treatment for advanced breast cancer, it is not only the progression-free survival, we look also for the quality of life, the safety of the drug, and the time to go for subsequent line of therapy. And all these points has been met with the CDK4/6 inhibitor. Although there are minor differences in the toxicity profile of these agents, we know that the ribociclib and the palbociclib, they have more immunosuppressive and thrombocytopenia than the abemaciclib, but we have more diarrhea, more abdominal pain and fatigue with abemaciclib. The ribociclib can cause a QT prolongation that it required an ECG assessment. So there are minor differences between these agents, but most of them, they are very tolerable and manageable. And this led to the preferable regimen for those ER positive, HER2 negative, that always to consider CDK4/6 inhibitors in combination with hormonal treatment for those patients. Now, what about overall survival? We know that overall survival for us as an oncologist is the gold standard in all type of cancer. It's not only breast cancer. Although we used the progression-free survival, but always we use it as a surrogate for overall survival. Why you use this? And if you see that in ER positive, HER2 negative for almost, if you see from 2003 till 2013, there was no improvement in overall survival for those patients with all the agents being used during this period. And there was another study included almost 15,000 in France, where you don't see any improvement in the overall survival apart from the HER2 positive disease. When you give the Cleopatra protocol for those patients, there was a significant improvement in overall survival. Apart from this, the achievement of overall survival, sometimes it's really a challenge for us, and this is why progression-free survival was taken as a surrogate. Why is that? Because most of the cases when you have a breast cancer and the survival post-progression more than 2 years, we have many agents and many chemotherapeutic agents that can be given post-progression that may dilute the benefit of the initial improvement in that survival to make it insignificant. The other factors is almost the crossing to the investigational agents. Also, this will dilute the benefit. So if you don't have a really very significant improvement in progression-free survival, this will not be translated in those patients to overall survival if they are surviving more than 2 years. And this is why most of the clinical trials took the progression-free survival as a potential surrogate for that. Till 2019, where we have the first clinical study that showed an overall survival in the MONALEESA-7, and these are premenopausal patients received the hormonal treatment plus CDK4/6 inhibitors, that for the first time, for long period of time, we see an overall survival advantage in ER positive, HER2 negative disease. And then we saw it in MONALEESA-3, which is a study that makes first as well as second line treatment. And then we have the Monarch 2 with the abemaciclib, where the study is still, it did not show the overall survival, but it is the trend with ISMO, as we will see later. And also with MONALEESA-2, we saw an overall survival advantage. So what are the updates in the last ASCO and the overall survival? And this is the first line setting in the MONALEESA-3. We see that for the first time, we are crossing the boundary of 5 years. So there was an improvement for almost more than a year for patients receive CDK4/6 inhibitors. So it is achievable, not only progression-free survival, but overall survival can be achieved with a drug that have a very significant improvement in the progression-free survival. If you take the post-treatment characteristic, we see that more patients had the treatment in the placebo arm as expected. And also we see that around 30% of those patients also crossed, sorry, it's going on the opposite side. Can we go back? I think even here, what you see that those who crossed over also to CDK inhibitors, around 30% of the population, the placebo arm. So in spite of crossing over to the investigational arm, as well as more treatment, the overall survival was shown in that study. And this is here the clinical trials which showed an overall survival. We see 3 clinical trials, ribociclib in premenopausal setting, postmenopausal setting, and in a study mixing the first line and the second line. And we see the Monarch 2 in the second line setting also showing an overall survival benefit. These are in the first line setting, as we see that the median progression-free survival are similar between each other, but in palbociclib, this was not translated into an overall survival, while in ribociclib was there. And in the Monarch 3, we know that in the last ESMO presented that there are around almost 1 year benefit in the overall survival, which will be reported soon. I think it will be also having an overall survival advantage. Now, and you see these, the median overall survival. If you look into the arm, the placebo arm is almost matching in all these clinical trials. So there is no really an explanation or clear explanation why we don't see the overall survival in the palbociclib. And if you see that, although we should not do a cross comparison between different clinical trials, but if we see the control arm is almost similar in all these clinical trials. And these are another factor where it show you that the advantage in the overall survival when you use these different agents. Now, also to see that in the ribociclib, although sometimes you see that if there is a visceral difference or liver metastasis, and these are meta-analysis of all ribociclib study, the 3, and you see that if they have visceral metastasis, liver metastasis, or more than 3 lesions, all they get benefit and improvement in overall survival for those patients. Now, and these are from the ESMO, it's just to show the benefit of that treatment and the value of that treatment. So incorporate not only the overall survival, the quality of life, and they give ranking of these. And if you see in the first line setting, we see that ribociclib in the premenopausal, they get the figure 5. In the first line setting, it's 4. And also, while the other 2 agents is you have 3 and 3 because it did not show yet the overall survival. We know that the palbociclib, the data is almost released, but the abemaciclib, I think we are waiting for that, and probably it will be soon, like 4. Now, if there is any role for CDK4/6 inhibitors if they progress on CDK4/6 inhibitors, and this study was presented in the last ESMO, and if you see that the maintain study, if the patient receives CDK4/6 inhibitors in the first line setting, they can go for a second line CDK4/6 inhibitors and switching the hormonal therapy. Those patients allowed to have only 1 line of chemotherapy or less. And if you see that initially the study was only with fulvestrant, and then it was amended to include exemestane if the patient received fulvestrant in the first line setting. The primary endpoint was a progression-free survival, and this is the baseline characteristic. 90% of those patients received palbociclib in the first arm, and around 10% they received ribociclib. If you see that de novo metastases were more in favorable of the placebo arm, 54% versus 35%, while all other endpoints were matching. And if you see that around 30% of those population, they progress within less than 12 months. If you see here, there was a significant improvement and double of the progression-free survival if you continue CDK4/6 inhibitors. Just to know that this is a phase 2 trials, so it's not a phase 3. If you see all the endpoint was get a benefit from continuing CDK4/6 inhibitors beyond progression. This is only a phase 2 study, included only around 120 patients, but we have also like 3 clinical trials, one of them phase 3, just to prove the concept of continuing CDK4/6 beyond the progression. What about the mechanisms of resistance to CDK4/6 inhibitor? We know that there are primary resistant where those patients, they progress very rapidly, especially the RB1 loss. But we have also secondary or acquired resistance, which usually happened after 6 months of treatment. And this is the frequency of this mutation. And there are many clinical trials to combine the CDK4/6 inhibitors, hormonal treatment, and also one of these mechanisms of resistance in order to prolong the response of the treatment. And one of these, alpelisib, which is the PI3 kinase inhibitors or everolimus, but this is also in addition, of course, of toxicity, and it's showing that it is a promising data. And these are many clinical trials in phase 1 and phase 2 addressing the same concept of treatment. We know that also AKT has been also presented and updated in the last ESMO. Capivasertib with fulvestrant and ribociclib also can be a potential triplet in order to overcome some of these toxicity. And you see that it is very complicated and many agents can be considered upon progression. And this is just to prolong the hormonal therapy before moving to chemotherapy. And this is the last slide where it showed that probably this is the only trial where you test head-to-head comparison between two CDK4/6 inhibitors, and this is between palbociclib and ribociclib, but in special subset of patients where there are some emerging data that ribociclib can cover those patients with molecular HER2 enriched population. So this will be addressed only this enriched population based on a molecular study to see if there is a differences between these two CDK4/6 inhibitors. I think the treatment paradigm is always to consider CDK4/6 inhibitors in the first line setting, and when the patient progress, if we don't have any biomarker to target our treatment, we have the options of adding everolimus, especially if they have a good response to the first line treatment, or we go to the chemotherapy like taxane or capecitabine. And if we have the molecular direction, we have the alpelisib for PI3 kinase, and we have the olaparib for the BRCA mutation. And we know that there are also the HER2, which we will, for the low expressor, which will be presented by Dr. Aida later on. So CDK4/6 inhibitors are the same class. Are they similar in the clinical trials? They are not similar. They are good, they are better, and they are best. And selection between these agents are very important based on the clinical evidence and data. And thank you very much for listening.
Thank you, Dr. Hassan, for a very comprehensive overview of treatment and hormone receptor positive breast cancer. So we are running a little behind schedule. I'm gonna see if there is anybody who has any burning questions for our speakers from the first session. So any questions for any of the speakers? Yes. She should be logged in.
Dr. Summer? Okay, then maybe I ask Dr. Hamid, how does it, how long does it take from doing, the screening till to have, the confirmed diagnosis, and from confirming the diagnosis to, the patient have the treatment?
Doctor, which disease site you're talking about?
Both breast and colon.
Okay, so breast, actually, we are quite fast. I'm talking about the UAE in general. To be honest with you, depends which center. Some centers are actually within a week, you can get the biopsy and the result. Other centers could be a month, and I've seen this actually over and over. And that's why we try to advocate for, faster access for patient. And even our center, we do accept patients to walk in if they have any concern about malignancy, suspicion. So it varies between centers. Colon cancer, again, the challenges regarding patient accepting the screening, even some patients with symptoms, they're actually hesitant because the cultural barriers or, concern about the colonoscopy risk. They try to avoid the colonoscopy, but once the biopsy is done, I think the time for management actually is short, but just about the timing for the screening could be challenging.
As I know, in UK, it is 2 weeks. You should treat the patients from the day of the diagnosis till, you treat them. Do we have such things in the region?
It varies based on the center. Some centers within a week, some centers up to a month.
Excellent. Thank you.
I just have a comment. It's regarding for Dr. Shamsi regarding your presentation. I just want to say it's your progress in the establishing the palliative care in UAE is very rewarding, and really I'm saying we are proud of having such progress, and we hope to see it also in our country. And I'm proud about your concern that you are also looking to see the palliative in other countries in Arab world and GCC. And I think if the people from this from the conference, though I don't see Dr. Aisha here, if there is a recommendation should come, I think the first recommendation that there should be a curriculum of palliative care in the medical school as well as in the postgraduate training, and should be as like a must for all doctors to have such training. Because still the idea about palliative care is very underdeveloped. It's not developed for adults, but imagine also for pediatric. It's much delay. And I hope really next conference will see a lot of improvement and presentations about it in all our countries. Thank you.
Thank you, Doctor. And actually, I should mention that, our colleagues and friends from Saudi Arabia, they have done a great job in establishing different centers in Saudi Arabia, and we do work with them very closely. And I think, again, it's about bringing the concept to the regulators, trying to explain the importance. Again, trust me, nobody appreciates how important the palliative care except the patient who's in severe pain, who's unable to get their medication, not able to go home. They're stuck in the hospital because of the pain or other symptoms. So definitely this is something that, unfortunately, any one of us, could be in this situation. So we have to make it better for our, nation and our country and our population.
Probably have a quick comment about the oncology clinical trials. And I think, like you mentioned, all of us who have worked abroad know how very different it is, the setup here to when you come and you were enthusiastic to start. So I hope this is a set stone to, for all the future and really great work that you're doing in the UAE and everybody in Saudi Arabia to try to improve the cancer care in our world. And with that, I'd like to close this session and thank you everybody and for all the speakers.
Okay. Good afternoon, everybody. Back to our discussions today. So our next speaker, distinguished speaker, is Dr. Aida Al-Awadi. Dr. Al-Awadi graduated from UAE University, College of Medicine and Health Sciences, then completed her internal medicine residency in the United States at St. Vincent Hospital, affiliated with the University of Massachusetts. Then completed hematology and medical oncology board in MD Anderson. She holds the American Board of Internal Medicine, Hematology and Medical Oncology. Dr. Al-Awadi further specialized in breast cancer and has published many articles in breast cancer and books and book chapters. She had chaired many breast cancer and oncology symposium nationally and internationally. Please welcome with me Dr. Al-Awadi on board.
Thank you so much. I much appreciate being invited to this fabulous conference. I thank the organizing committee. I would like to thank your effort for putting together this amazing conference and inviting me to be part of it. So I'll be covering the topic, the exciting new topic of HER2-low breast cancer, which is a new entity that has changed the landscape on how we approach the patient in the metastatic setting. So here's the objectives of my presentation: to understand the foundational concept of HER2-low and breast cancer, to address some of the challenges in defining HER2-low breast cancer, clinical implication of HER2-low in metastatic breast cancer, and what are some of the new treatment options for metastatic HER2-low breast cancer. So as most of us know, HER2 is physiologically expressed on most of the cells in the body, including that in the breast, skin, lungs, and etc. So nearly all breast cancer exhibit some degree of HER2 expression, even if they were not HER2 amplified or overexpressed on the cell membrane. The detectability depends on the type of tissue analyzed, which is paraffin embedded versus frozen section, and the sensitivity of the assay utilized. So back in the 1980s, Salmon and colleagues first reported the negative impact of HER2 overexpression in breast cancer. And you can see clearly in the graph on the right side, those patients with HER2 amplified tumor had dismal prognosis when compared to those with non-amplified tumor in terms of overall survival and even disease-free survival. Luckily, We have now the first antibody, HER2 antibody medication, which is the trastuzumab, which has changed the landscape and how we approach these patients. So HER2, as most of us know, is a tyrosine kinase receptor that upon homodimerization or heterodimerization with other partners of the EGFR family, it promotes the proliferation, survival, and invasiveness of cancer cell. And by blocking this receptor with trastuzumab and other antibodies, it inhibits its oncogenic pathway, leading to its clinical benefit in HER2 positive breast cancer. So this has changed the landscape and how we treat this patient and made it one of the most aggressive type to the one of the most treatable type of breast cancer. And most of us really, when a breast cancer patient comes to our clinic, we get excited when they are HER2 positive, because now we can give them many options and can improve their survival and increase the risk of cure. And now we don't only have trastuzumab, but we have many different targeted agents to the HER2 protein. And some of these were approved in the early setting, and most of these agents were approved in the metastatic setting. And that includes trastuzumab, pertuzumab, lapatinib, trastuzumab, emtansine, or what we call as TDM1, tucatinib, neratinib, trastuzumab deruxtecan, or TDXT, which is going to be the focus of our presentation, and the margetuximab. So again, the prognosis of HER2 positive metastatic breast cancer has improved tremendously with the addition of these anti-HER2 medications. So we now have an overall survival that is not reached based on the last analysis conducted in 2016. And we have been seeing tremendous improvement since 2008 up until now. And I think we will reach at one point where we can actually cure some of our metastatic HER2 positive breast cancer. So here's the traditional HER2 pie chart. You know, in the past, we would consider about 15 to 20% of all breast cancer cases to be HER2 amplified, which we defined as IHC of 3+ or IHC of 2+ and FISH negative, and the majority we would label them as HER2 negative. However, we know that despite of lack of amplification of some tumors, they do have some degree of expression of receptors in the cells. So for example, patients with IHC of 1+, if you looked at the definition, they could have stain of more than 10% of tumor cell, but incomplete membrane staining. And those with IHC 2+ and FISH negative, they could have also more than 10% of tumor being HER2 expressed, but weak to moderate complete membrane staining. So these patients still have some degree of HER2 expression, but they are considered as non-amplified tumor. So it makes sense to think whether these agent would work for these patients. So unfortunately, up until 2021, we did not have any approved agent for this entity. So the real question is, could they benefit from HER2 blockade? And the first study that looked into this is the NSABP 31, which actually was a phase 3 trial looking into the effect of adjuvant trastuzumab in 2008. But they did a retrospective analysis where they looked into the whole spectrum of patients. And as a matter of fact, they discovered that 10% of the patients were actually HER2 non-amplified. So they were labeled as HER2 negative. They were 1+, 0+, or even 2+ and IHC negative. So they went back and looked into this patient. So unfortunately, they were included. So the question is that, did these patients, now that we identified them as HER2 negative, but they received trastuzumab, did they benefit? And actually, if you looked into the chart, as a matter of fact, they did as good as patients with HER2 positive disease. So that shed the light to maybe these patients would benefit from anti-HER2 therapy. So this, another trial that tried to address this question directly, it's a NSABP 47. It's a phase 3 trial that conducted to understand if adjuvant trastuzumab was beneficial for HER2 low patients. So they included patients with node positive or high risk node negative breast cancer, and the IHC was 1+, 2+ for HER2 and FISH negative. So they randomized the patient to either receive chemotherapy versus chemotherapy plus trastuzumab for 1 year. And this was published in JCO in 2020. And unfortunately, you see no benefit with the addition of trastuzumab in the adjuvant setting for these patients. You can see there is a clear overlap between these two lines. So that was a bummer. So that we should not stop there. We have to think of other strategies. So as a matter of fact, trastuzumab even did not have any benefit regardless of the IHC score, positive nodes, the hormone receptor status, and intended chemotherapy used in this trial. So they looked into pertuzumab. Now, how about pertuzumab? Maybe it would do something for these patients. So as a matter of fact, they did a population study where they looked into the addition of pertuzumab in HER2-low metastatic breast cancer patients. And unfortunately, again, the objective response rate was only 2.5% and a median time to progression of 1.5 months only. So no, again, no clinical benefit of blocking the HER2 pathway in HER2-low breast cancer. Another setback, but they did not stop in there. So how about these antibody drug conjugates now? So we have the old generations and the new generation antibody drug conjugates. So simply, what are these antibody drug conjugates? Basically, it's an antibody, trastuzumab in this case, linked to a chemotherapy, which is a payload, and usually it's a potent chemotherapy, and the linker make this drug stable so that it does not degrade in the circulation, but it delivers the medication to the target cell where it releases cytotoxic medication and lead to apoptosis of the cells by different mechanism. So we have the older generation of antibody drug conjugates, which is the TDM1 and HER2-low. Again, they did a retrospective evaluation of TDM1 in 21 cases of HER2 non-amplified tumor. Again, very little activity of TDM1 and HER2-negative metastatic breast cancer. Only one response out of the 21 patients. Objective response rate was only 4.8% and the median progression-free survival of 2.6%. You can see the orange line, they actually did worse when compared to the other two types of breast cancer or the HER2 amplified breast cancer. So now we have the novel conjugate for HER2-low breast cancer, which is the trastuzumab deruxtecan. It has a high antibody drug ratio, 8:1, meaning more chemotherapy on the antibody. It has a cleavable linker, which allows payload to diffuse outside the antibody, and novel payloads that act in different way that can also be lipophilic, and so can pass the tumor membrane and reach different cells, including the brain, and achieve the so-called bystander effect. So here is the structure of TDXT. We're not going to go into the details of it, but you can see these orange circles, more chemotherapy on the antibody and the cleavable linker. So as a matter of fact, TDXT, was investigated in this setting, in the phase 1 setting, and the phase 1 setting has led to many expansion cohort, and among those was the HER2-low breast cancer, which is defined again as IHC 1+ or IHC 2+ and FISH negative. So you can see that among all of the cohort, gastric cancer, breast cancer, different entities of breast cancer, different location, different countries, but they looked into the 2C arm. So this was first reported in 2018 by Dr. Shanu Modi and was first presented at ASCO, and the result of the phase 1B study of the trastuzumab deruxtecan, which suggests activity in HER2-low breast cancer. You can see a beautiful waterfall chart. You can see the impressive responses in there. We don't see this much in phase 1 trials. The objective response rate is 37% and activity both in IHC 1+ and 2+, and the median progression-free survival of 11 months, which is very impressive again to see in a phase 1 context. And the activity was there regardless of whether the patient was treated with CDK4/6 inhibitors, if they were hormone receptor positive in the past, or even anti-HER2 treatments. And now we have two novel conjugates for HER2-low breast cancer, and these are trastuzumab deocarnazine and the disitamab vedotin. Both of them have been heavily investigated in HER2-low metastatic breast cancer. And you can see in early setting trials, the objective response rate with these agents are anywhere between 32% to 40%, and the median progression-free survival of 4 to 6 months. Again, very impressive. You can see, I mean, these waterfall plots speak for itself. So now these agents are expanding to be investigated in a larger phase trial, and I think we're going to see a positive result, and they're going to be there for the patients, hopefully in the future. So this led to the proposal of a new pie chart of HER2 positive breast cancer that was proposed by a Dana-Farber group and a very well-known figure in this field, Dr. Paolo Tarantino. So now you can see that HER2 positive breast cancer in 15% of the patient. In the past, the rest of the patient were labeled as HER2 negative, but now we can see in this pie chart, the blue part, more than half of the patients are HER2 low. And these patients now we have more treatment options for, and we need to identify them as a distinct entity. Very interesting observation that was conducted by the Dana-Farber group. It basically showed that HER2 low expression is positively associated with the estrogen receptor expression. So as you can see here, the higher the estrogen is expressed in the tumor, or the stronger the estrogen is expressed in the tumor, the higher the likely chance that we have HER2 low in that type of tumor. So for example, in triple negative, they identified only 40% of the patients are HER2 low. But when they looked into the ER low patient, 1 to 9%, expression, now we have 46% are HER2 low. And the higher it is, the higher the chance we get a HER2 low expression. You can see in the estrogen receptor high tumor, more than 95%. Now more than half of the patients are HER2 low. So a very interesting observation. It may have implication in the future, and there are many theories behind it, but we don't know yet whether it's gonna change the way we treat this patient as of yet. So again, also they looked into, is HER2 low a distinct, does it have a distinct prognostic value? So they looked into all of the study that investigated HER2 low and its association with the survival of the patient. As you can see, most of the studies showed no overall survival difference. So they found no OS difference in HER2 low versus HER2 zero tumor, regardless of the hormonal receptor expression as well. But I think this will change just because now we have approved indications for medications in the HER2 low setting. So definitely in the updated data, we're going to see more of the positive overall survival data. So the question is that, is it a distinct entity based on what I said in the prior slide? Yes, now we can all be convinced that this is a distinct entity of breast cancer. But the question is that why blocking the receptor did not yield any benefit of this patient, but the cytotoxic drug delivery did. So the money is really on this, like why this and not that? So it seems that the main mechanism by which these cells respond to the treatments is by the targeted delivery of a highly potent payload. So the money is on this mechanism, and that's exactly why the antibody drug conjugate worked, as opposed to just blocking the pathway of HER2 receptors. So, but any new concept in breast cancer would not come without some challenges. So there are many challenges in how we define the HER2 low expression. So the first challenge is that we know that the HER2 low expression is unstable. So for example, a patient with HER2 low tumor in the early setting, when they relapse, you biopsy them, some of them will be HER2 zero. So should we consider them as HER2 negative, HER2 low? We don't know. We don't have that answer yet. But the reason for this change, the dynamic changes that happens with the HER2 low expression is unclear, but it could be due to peri-analytical factor, HER2 expression heterogeneity, or the biologic evolution of the disease. On the other hand, how about those with ultra low expression? So the other challenge is that low concordance among pathologists to define those with 0+ or 1+. So in a recent study, among 18 experienced pathologists, there was only 26% concordance between the diagnosis of HER2 zero and HER2 1+. because the current assay that we utilize is not sensitive enough to detect the differences between the IHC 0 and 1+. Because in the past, we did not care if they are 0, 1+, they are HER2 negative. We don't have any medication in HER2 low tumor. But now it makes a difference, because if it's 1+, we have a new medication for these patients that can prolong their survival. And we're going to talk more about it in the next few slides. Again, you see the IHC 0 does not mean there is no staining. Always, no. Some of the cases, in the second definition, there could be some membrane staining that is less than or equal to 10%, whereas IHC 1+ is more than 10%. So there is a very fine line between these two entities. And usually in my practice, when I have a patient in metastatic setting and they are HER2 0+, I call back the pathologist. I tell them, can we review it again? Can we have an eye of a different pathologist? Maybe now it's going to be 1+, and that will open up a new treatment option for the patient. So very interesting. I think there is a heavy work in terms of like trying to develop assays that can pick the differences between these two entities. The third challenge, which is sort of similar to the challenge that we have in the first slide, it's the dynamic definition of the disease. How many of us treat these patients? And when we biopsy them on the metastatic setting, they can be 1+, and then on progression 0+, and then again 1+, and then 2 times 0+. You know, we like to biopsy these patients to know the evolution of the disease. Maybe that will open up treatment options for the patient. So we don't know. Should we consider this patient 1+ based on the previous IHC score, or is it 0+ now, and we should not give these patients any anti-HER2 medications? So that's definitely a challenge. There is nobody has investigated these medications with the dynamic changes, and definitely a challenge that we face in the clinic. But the Dana-Farber group proposed this definition, the HER2 non-amplifying tumor that showed HER2 low expression on any prior specimen in the course of the disease. So this is exactly what we do in our clinic. If the patient is 1+ and became 0, we still consider the 1+ that the patient had, because that still, I mean, there is tumor heterogeneity. Maybe we picked up the clone that was HER2 negative, and there was a whole debate about it. And I'm sure if we have like a pathologist in here with other breast experts, you know, there's going to be a big debate about it. But I'm convinced that this definition is the right way to go. And as a matter of fact, in patient in Destiny 04 trial, the patient enrolled based on any positive HER2 expression, 1+, 2+, and FISH negative, regardless when it was through the course of the disease, whether in the early setting or in the metastatic setting. So they were considered as HER2 low tumors. So challenge number 4, the ultra low HER2 expression. We talked that with the IHC 0+. And actually, this is a good challenge because it may open up now more treatment option for patients who we recognize as HER2 negative, but they still have some degree of expression. So how about those 0+? Some of them do have some degree of HER2 expression. So that will be answered with the Destiny 06 trial, which is a phase 3 trial that included those patients. And they randomized these patients to get either TDXT or physician choice of a chemotherapy, and they looked into progression-free survival. So the key difference between this trial and Destiny 04 is that they included the IHC 0+, which is very important because that may now include the patient to those who we can treat with DDXT. It's larger, so the number of patients enrolled in this trial is 850, and they restricted this trial to hormone receptor positive disease only. And very interestingly, they included patients who did not receive chemotherapy, unlike Destiny 04. So very excited about this trial, and I think we're gonna get the result of this trial in the next few years. So again, this is the past, the present, and the future paradigm on how we look into the HER2 low tumor. So now we have a large subset of HER2 low tumor that can be targeted, and how we see it in the future based on Destiny 06 is that the HER2 low group expand to include also HER2 negative or ultra low tumor. And finally, we may reach a moment where we have a continuous expression of HER2 tumor that can help us select patients for the right therapy. So of course, we cannot finish the presentation without talking about Destiny 04, which received a huge standing ovation in the recent ASCO 2022. So basically, they investigated TDXT in patients with HER2-low metastatic breast cancer. So the patients included were HER2-low per the same definition. All of the patients actually received at least 1 or 2 lines of chemotherapy in the metastatic setting, and the hormone receptor patient were deemed to be endocrine refractory. So when they exhausted all of the endocrine agents, then they put them in the TDXT if they are HER2-low. So they randomized the patient into 2-to-1 fashion, TDXT versus physician choice of chemotherapy, you name it, Xeloda, eribulin, gemcitabine, or Abraxane. And the primary endpoint is PFS by BICR and the hormone receptor positive disease. And the key secondary endpoints include the PFS for all patients and then overall survival for hormone receptor positive and all patients. And they stratified the patient according to the HER2 status, 1 versus 2 prior lines of chemotherapy, and the hormone receptor positive status, whether they received prior CDK4/6 inhibitors or not. So here are the 2 cohorts, the hormone receptor positive cohort and all patient cohort. And as you can see, the baseline characteristics were very well balanced between both arms, and majority of the patient had visceral metastasis in the form of liver and lung metastasis, and rarely there are some patients who had brain metastasis. So most of the patient had hormone receptor positive disease, and all, patient arm, more than 80% of the patients were hormone receptor positive disease. And most of the patients received at least 1 line of chemotherapy, and a majority of patients in the hormone receptor positive cohort received CDK4/6 inhibitors, about 70% of them. So PFS and hormone receptor positive in all patients, it met its primary and secondary endpoint. Now, as you can see here on the left side and the right side actually of the audience, you can see in the hormone receptor positive disease, there is a significant improvement in PFS, with the median PFS in the TDX arm of 10 months versus 5.4 months. So a doubling of the number we can clearly observe in this graph, with a hazard ratio of 0.51 and a significant p-value. And for all patients, again, the graph is replicated with improvement, significant improvement in the PFS in all patients when it comes to TDXT. How about overall survival in HER2 positive and all patients? Again, we see a significant improvement in overall survival in this entity. And how often do we see an overall survival benefit in the metastatic setting? From the first time the data is presented, like most of these data will be approved, most of the drug will be approved based on PFS. But now with this medication, we have overall survival difference. And you can see here in the hormone receptor positive disease, the median overall survival is close to 2 years versus 17 months in the physician choice of chemotherapy. And again, the same thing for all the patient, and the differences are statistically significant. And again, the PFS and OS and hormone receptor negative disease, again, the same thing. So this drug works whether the patient has hormone receptor positive or negative disease. And you can see the marked separation of the curve and improvement in the PFS and OS in patients with hormone receptor negative disease. And the improvement, all subcategories favor TDXT, whether the patient had prior CDK4/6 inhibitors, if they are hormone receptor positive, status, regardless of the IHC expression, whether it's 1+, 2+ FISH negative, regardless, of whether the patient has visceral mets or not. But, these medications, unfortunately, does not come without a price, and that is the side effects and adverse effect. So I'm sure that most of us started using these medications in the clinic for either HER2 amplified or even HER2-low metastatic breast cancer. But the most common side effect that we witness in the clinic is nausea and fatigue. So these are the main thing that we see with our patient, which may require dose reduction or even aggressive supportive medications. Neutropenia is there, anemia, decreased appetite, but to a lesser extent. And luckily, majority of the patient has grade 1 and lower grade of toxicity with this medication. And rarely they would get grade 3 and above
toxicity. Now, very important, and I counsel the patient that alopecia is very important because you would expect the patient to come to your clinic and you tell them about these new drugs, and then you tell them 40%, you have 40% chance that you may lose your hair. And they will be, are you giving me the conventional chemotherapy, So that's very important when we counsel our patient because they have to understand that hair loss may be there. So, but all in all, it's definitely better tolerated than the conventional chemotherapy. So you can see that the median treatment duration for TDXT was 8.2 versus 3.5 for the other arm. And the most common adverse event associated with treatment discontinuation, as expected, is ILD pneumonitis with the TDXT. 8.2% of the patient had to discontinue treatment because of pneumonitis, and then only 2.3% in the chemotherapy, arm, specifically because of peripheral sensory neuropathy. So adverse events of special interest, we know ILD is a big thing in these patients. So we have to monitor these patients very closely. We have to select this patient carefully. We have to check whether the patient has any underlying chronic lung disease, whether the patient has asthma, they have prior, interstitial pneumonitis and such. So these are very important before we start the patients on these medications. So as you can see here, 12% of the patient experienced ILD or pneumonitis, but luckily the majority of them had grade 1 or 2, toxicity. However, we still have to be very careful in monitoring the patient. So the way I do it in the clinic, when the patient comes, I ask them, do you have a new respiratory syndrome, symptoms, cough, shortness of breath, or any of this regards, So that's very important when it comes to patients follow up on this medication. Because remember, even though majority of the patient happen to have low grade toxicity, 3 of the patient actually died because of grade 5 pneumonitis. So we have to really be careful when monitoring these patients. And when it comes to the left ventricular dysfunction, it was not a major issue. So it happened in 4.3% of the patient. And again, it was of a lower grade. So based on this, TDXT was approved to be used in patients with HER2 low metastatic breast cancer, and the approval happened in May of 2022. And with that, I would like to conclude my presentation. Thank you so much for your attention. I'll be happy to get any questions.
Thank you very much, Dr. Aida. I'm really impressed today with our speakers, distinguished, all of them, especially from UAE. And thank you for this well-chosen, practice-changing topic. We'll leave the questions till the end of the session. Thank you very much, dear. Next is Dr. Iman Tawheed. She's a consultant gynecologist at Kuwait Cancer Center since 2013, the General Secretary of Kuwait Oncology Association. Now she's the president, actually. She has obtained an MD obstetric and gynecologist in 1995, extensive experience working in multiple hospitals such as Ireland, UK, Saudi Arabia, Kuwait. She is a Kuwait representative of Society of Laparoscopic and Robotic Surgery, European Surgical Academy. Please welcome with me Dr. Iman.
Rahim, Assalamu alaikum wa rahmatullahi wa barakatuh. Shukran, Dr. Aisha, for the introduction and the invitation. I really appreciate. Now, after very condensed lecture about breast chemotherapy, now I'm going to take to the other side of the gynae, which is the cervix. And I'm going to speak to you rather, give you a general view about the cancer cervix and what's happening in Kuwait. And how to bridge the gap between the cancer cervix and the palliative care. Now, this is where I work. It is Kuwait Cancer Center. There is only one cancer center in Kuwait. It has 100 beds, and the palliative. This is the palliative center. It's completely separated from the cancer center, around 600 meters. And it contains only 23 beds for the whole oncology. Now, I know that by the end of the conference, all of you are familiar that the NCDs is a big challenge in the public health, and the cancer is coming second. It has a huge public burden, and from the gynecological point of view, the cervical, the cancer cervix, is considered the most common cancer in the female genital tract worldwide. I know there is much geographical variations. Now in the state, for example, or the Australia, the incidents are getting, of course, low, coming down because of the vaccination and the screening program. Now, since 2018, the WHO is asking for action against cervical cancer. So what is the cervix for the non-gynecologist? It is the lower part of the uterus. It opens into the birth canal. This is how does it look like. Now, this is an advanced, of course, state of cancer cervix. It is a huge tumor, and this is very not uncommon, as I see, because we don't have a national comprehensive program in Kuwait. Now, most of the cancer cervix cases occur because of the sorry, going back. Oh, yes, okay, associated with HPV virus. This is a sexually transmitted disease. It occurs via skin-to-skin contact. It is sexually transmitted disease. And most of the women, they will harbor this virus, 80% of them, they will harbor this virus after the initiation of sexual intercourse around for 2 years, but with the immunity of the body, they will get rid of it. Now, some patients, of course, they won't, it will persist and they will have abnormal Pap smear. So how can we prevent cervical cancer, this is very unique to the female genital tract cancer, because we cannot prevent the uterine cancer or the ovarian, but we have the opportunity for cervical cancer to prevent it or to reduce it. By doing the cervical screening, it is the Pap test. You take some cells from the cervix, or you can do the vaccination. In Kuwait, we don't have integrated comprehensive national screening program, but we have batchy. Whenever the patient get opportunity to see her gynecologist, they might have their cervical smear. So it is not integrated. And the vaccine as well, this is vaccine you give to prevent the HPV virus, and you should usually, according to the international guidelines, you give it after from age of 21 or roughly 3 years after initiation of sexual intercourse. Now, so what I did in Kuwait, trying to screen for cervical cancer. So we recruited around 4,000 women. But what is the result is, unfortunately, I have only 20% uptake. So not a lot of women, they come to have their cervical smears. So here we go with the advanced stage of cervical cancer. So all the patients, they mostly 99%, they present to us with advanced stage of cancer cervix, stage 3, or sometimes even 4. And hence the importance of the palliative care. Now, we all know the history of palliative care goes to the 18th century, and now, according to the American Palliative Care Association, founded by 2000, it is now a well-recognized subspecialty with a recognized team. Now, by definition, WHO described the palliative care is an approach which improves the quality of life for the patient and their families in any chronic diseases, not necessarily the cancer. So who provide this? We do, the doctors and the pharmacists, the spirituals, and obviously the volunteers. Now, what's the goal is basically to improve the quality of life for the patient, and they should not suffer until they die. And who receives it? Of course, as I said, any patient with chronic disease, but in this, especially where I work, we provide it for the cancer cases. Now, we know that the main complaint of the patient usually during the cancer is the pain. You know, in gynecology, we have here 60%. 60% of most patients, they complain of pain. So it is very important to give attention to this particular symptoms, and 30% around the newly diagnosed cancer, and it increased to up 80% in advanced cases. Now, how would we assess the pain? Now, obviously, after taking the history, you have to concentrate on the physical examination, and you rate the pain, because many physicians, they don't scale it. You know, they just ask whether the patient has got pain or not. She has pain, so and so, and they just prescribe sedatives or analgesia. So you have to rate the pain, the intensity. You either rate it by pain, mild, moderate, or severe, or by scaling from 0 to 10. Now, according to the Joint Commission on Accreditation of Health Organization, they consider the pain is the 5th vital sign. So it's very important to ask the patient about the pain in particular. Now, what we do for this pain, obviously, we prescribe the analgesia or opioids. This is the WHO guidelines for cancer pain, three-step ladder, step 1, 2, 3. And it's according to where do you work. Sometimes, obviously, all this medication not available in all centers, but usually we start with non-opioid, then the weak, then the potent. And now, what's the barrier for this pain control? Why patients, they continue to having pain and they suffer from the pain? There are 3 factors: the health professionals, the patient themselves, and the health system. Now, as we are a health professional, we don't have adequate knowledge for the pain, not too much studies done, and it's a relatively new subspecialty coming up. So, and that's why we are poorly assessing the pain. And there are some concerns from physician point of view regarding the side effect, and patients might get addicted, and some regulations as well. Now, how much full-time the physician, now how much of us we see patient or dedicated to as palliative care provider for the patient. Now, if you see here in the only country here, I quoted this, Saudi Arabia, it is 20 of, they have only 20 for a full-time physician for palliative care provider. That's the ratio is 1 to 1,400,000. So it's very, very short of staff. Now, the patient themselves as well, sometimes they are reluctant to report the pain because, you know, they fear, they always feel that their disease is getting spread further, and they fear from addiction, plus they fear from side effects as well. Now, the health system is the last obstacle for this providing proper management of pain. Obviously, we don't have integrated system, because like my hospital separated from the palliative care until we get patient to move to another hospital, a lot of logistics, and sometimes become very difficult. Now, what happened in cervical malignancy, the palliative care, the problem is the same pain, the patient, but the difference in cervical cancer from other cancer, it is sexuality and the body image. The patient feel that she has lost her family role, and she has so much affect her marital status and marital relationship. I've seen so many patients, their husband, they leave them because they have cervical cancer. Some of them, they think it is infectious. Some of them, they think because of the bleeding. So this affects the intimate relation. Now, what message I want you to go home with, which is very important, trying to highlight that cervical cancer, it takes a long time to develop into a frank cancer. It starts with pre-malignant stage, and it takes 10 to 30 years in order to become overt. So this is opportunity for you to detect and screen the patient, detect it early, so you can treat it early and save patient lives. Because, you know, with the advanced cases, of course, the mortality is very high, up to 90%. So, and you set your goal to be the threshold, you should keep your your cancer cases less than 4 per 100,000 women per year in order to eliminate cancer cervix problem as a public health problem. And this is how would we bridge the gap? Of course, there is the physical, you alleviate the patient's symptoms, the social, don't forget, very much important, the social and the sexual function. And the psychological, of course, you will involve the psychologist and psychiatrist and the spiritual, the religious, what the Imam Masjid, the church, whatever, in order to help patient to pass this difficult time. So a few things doctor can do more than the relieving just the pain. Please look at the patient and try to, it's very important for cervical screening to be comprehensive, integrated, because it's easy to detect pre-malignant and it's easy to be treated. Thank you very much.
So I'll just say it again. Just thank you very much, Dr. Iman, for your excellent, up to the point topic. And as you mentioned, I have just came back from a short visit to Kuwait, where we had a workshop on updating the gynecological cancer guidelines, and we have many things in common with Kuwait. So thank you very much. Next is Dr. Ahlam Duhol, our colleague from King Fahd Specialist Hospital. Dr. Ahlam completed a residency program in radiation oncology at Ottawa University, Canada, obtained a board in radiation oncology, and became a fellow of the Royal College of Physicians of Canada. Subspecialty of image-guided brachytherapy in the Royal Marsden Hospital, London, with a fellowship from the Royal College of Physicians, an executive master degree in health administration from University of Alabama, Birmingham, the chairwoman of radiation oncology department in King Fahd Specialist Hospital, Dammam, since 2014. A consultant specialized in treatment of women cancers with focus on breast cancer patient. Member of Radiation Machine Purchasing Committee, Saudi Health Council, National Cancer Center, a 2030 Leader Program graduate and certified value-based health trainer, with a special interest in applying concept of VBHC and improving the patient journey. Welcome with me, please, Dr. Ahlam on board.
Thank you, Dr. Aisha, and thank you for organizing. I'm honored to be here to talk in the first oncology conference in Bahrain, and happy to share the knowledge with our colleague from other countries. It's a great opportunity. Thank you so much for the invitation. I'll try to be light. I know it's the end of the day, and my topic is heavy, kind of, because it's radiation, and radiation is not a common topic, but I'll try to be, I'll try to explain it as much as I can in short, small words. So I'll be talking about radiation treatment and updates in breast cancer and why we want to go for this. So my content today is some facts and statistics, and then why radiation, and then the current standard of care. And I will elaborate more on the fast forward trial, which is the new trend. And finally, I will go through our experience at King Fahd Specialist Hospital in Dammam. So as we all see in our practice, this is a 42-year-old lady who neglected her annual mammogram, and we can see that majority of her breast is replaced with a tumor now. I think this is common thing we see in our practice. This is another patient. She's 36 years, lactating mother. And for the past year and a half, she had been feeling a mass, and she was reassured that it's only a milk duct. And I think, again, this is a common scenario we see in our patients. And then they present with very advanced, as you see here, reaching up to the skin, the tumor already invading the skin, so T4. This is a lucky woman. So this is the opposite of the previous one. She's, again, 36-year-old lady, educated mother with a positive family history. She was imaged once she felt a lump, and we can see that her tumor in opposite to the previous one was discovered very early. She was T1 and she ended up with very short treatment. She didn't have to have chemotherapy. Oncotype DX was done for her and she completed her treatment within a couple of months and went back to life. So I think we share the common concern in our countries, which is two concerns. The first of all, that it's not in our area, we see our patient in advanced stage, as Dr. Saleh Al-Athman mentioned, that majority of our patients, 85%, they come in advanced, which is controversy to the rest of the world. And I think because of the education and the screening programs. The other thing is the age at diagnosis. This is, those are the cancer registry figures for breast cancer. This is the one for UK at the same age, at the same year of 2018. This is the one from Saudi Arabia. You can see for the UK, the age gradually go up, and for us, and I think this is not specific to Saudi, it's all common Arabic areas. The peak does not have that gradual rise up, because 45% is at age stage less than 40 years old, which is not common to be seen somewhere else. So as a radiation oncologist, it's really important for me to talk about breast cancer because it's one of the most cancers seen and treated by radiation oncologists. And the aim of radiation treatment locally is because the most common site of recurrence is local site, and preventing the recurrence will also improve the quality of care and overall survival. Briefly, let me tell you what is radiation treatment. Radiation therapy is the art of using ionizing radiation, which is basically just high energy X-ray. Patient is not radiating or anything, directed at tumor to destroy the malignant cell while being able to minimize the damage to the surrounding tissue. One of the very important concepts in radiation is the dose split out, what we call fractions. We have to fractionize the dose over time, so we give time for the normal cell to recover, so we can decrease the side effects while we kill the tumor cells and it become less efficient. So my role as a radiation oncologist to adjust the amount given by considering the type of cancer and the location of cancer, because you just think what is the surrounding tissue around that, and accordingly you think of the side effects that a patient will have. So it's, as I mentioned, there is this dilemma of we want to increase the dose to control the disease more, but at the same time, we have to maintain the dose within certain limits so we don't have a normal tissue toxicity. So we have to balance this, and all of studies are going through this main concept. So previously, the standard of care was mastectomy. Then the studies started earlier in the 70s, were to compare the mastectomies versus breast conservative surgery and radiation treatment. Nowadays, 70 to 80% of the patients with stage 1 or 2 disease are candidates for breast conservative surgery. There are 6 important randomized controlled trials to compare mastectomy versus breast conservative surgery and radiation treatment, and it found out that there is no difference in the disease-free survival or overall survival. So we safely can say that mastectomy is no longer the standard of care. Those are the trial, or this is one of the biggest meta-analysis. It included 20,000 patients. 50% of them were not positive patients, and the radiation decreased the local recurrence rate by 2/3. So as I told you, mastectomy is no longer the standard of care in breast cancer surgery. Whole breast radiotherapy is compulsory whenever we give breast conservative surgery, and the result of breast conservative surgery and radiation treatment versus mastectomy are equivalent. But there is the side effect side, and the most important side effects are lymphedema and breast edema. And the other one is, which is we see with acutely with the patient receiving radiation, is skin and breast complication and a sunburn type skin irritation. Excuse me for the next picture, but this is a patient pre-radiation treatment. This is the kind of side effects we see, and sometimes it's more than that. So we learned the lesson over the years that if breast conservative surgery, then all the patients should receive treatment, radiation treatment, except for a small subset, which is 70 years, not positive, stage 1 disease. So now we agreed on this concept that mastectomy is no longer standard of care, and breast conservative surgery, breast radiation is the standard of care, but we want to do better. So can we do shorter radiation treatment? So what is the current standard of care? For many decades, they thought that 2 gray per fraction should be the maximum to minimize the side effects. So patients were given 50 gray over 25 fractions, which equal to 5 weeks, a long treatment. Then the trial came in thinking, can we do less than that instead of the patient coming for 5 weeks? Can we do better than that? There is 4 randomized controlled trial. 1 is a Canadian trial, 2 is a UK trial, and then another UK trial. So the first is the Ontario Clinical Oncology Group compared the 50 gray, which is the standard of care, versus 42.5 gray, which is 16 fraction, means 3 weeks. So 5 weeks versus 3 weeks. And the outcome, and we always look into the local recurrence rate and the cosmetic outcome. So the local recurrence rate, as you can see here, is comparable in both. And then the cosmetic outcome also is comparable in both. So this is the first trial. Then a second and third trial was done in UK. Again, compared the 25 fractions versus number 15 fraction. And it confirmed the same result, that the local control in both arms were comparable, and also the cosmetic outcome. So 3 weeks of treatment instead of 5 weeks became the new standard of care, and we have available mature data confirm the safety and non-inferiority of that. Then they were thinking, can we do less than 3 weeks? So because they were careful with giving high dose per fraction, they wanted to, whenever they wanted to increase the dose per fraction, which was here, they compared the standard of care, which is 25 fractions, to 5 fractions, okay, over 5 weeks, meaning that they were given only once per week and give a full week for the normal tissue to recover. And the late and moderate normal tissue effect were comparable in the 28 fractions in 5 weeks to the standard of care. So now we know that we can increase the dose per fraction with minimal side effects. We don't see a difference. Finally, following this result, the researcher team investigated the radiation therapy with 5 fractions delivered over 1 week, 5 consecutive days. Instead of giving the patient once per week, can we give it in a 5 consecutive days? So that will be very important for the patient traveling somewhere, or patient will be just committed for 1 week instead of 5 weeks. And this is where the fast forward trial came out. And because there was no reason to assume that 15 fraction represent the lower limit for this hypofractionation. So the question was, can we do better? So this is what I just mentioned, that it's 1 week schedule. So it's a multi-center trial, non-blinded, phase 3, randomized, non-inferiority trial, done at a 97 hospital in the UK, testing the safety and the efficacy of 5 daily fraction schedule of radiation treatment compared to the 3 weeks standard of care. They included all the patient, age 18 plus, all invasive carcinoma. Though, if you can see here, that there was no nodal radiation was allowed in the main study. One of the good things they did, they excluded the lowest risk patient, which is older than 65, T1, grade 1 ER positive. Those subset were excluded, and the aim was to increase overall primary event rate. So we're not getting any false positive result because of those good number of patients. So the randomization were equal. They randomized from 2011 to 2014, 4,110 patients were enrolled. and the compliance was 99%, and the 5 years visit forms were completed in 96% of the patients. The demographic and clinical characteristic at baseline were well balanced between groups, though the age 40 plus were minority of patients. They were less than 2% in each arm. So the assessment was through three main things: clinician assessment, patient-reported outcome, and photographic. Sorry. So with the clinician assessment, they were looking for the local relapse and late normal tissue effect at annual follow-up visits. They were looking exactly for the late tissue effect because increasing the dose per fraction will increase the late side effects, not the acute. They also did the patient-reported outcome, and they did it at baseline, 3, 6, 12, and 24, 60 month. And also they took a picture at the baseline 2 and 5 years, just to confirm that, again, we're looking at the same end result: local recurrence and cosmetic outcome. So the endpoint were either distant metastasis, disease-free survival, or overall survival. So for all outcomes, there was no statistically significant difference between all groups. Another paper looked at the acute skin toxicity associated with 1 week, and the acute skin toxicity were very low at the patient who had 1 week radiation treatment, because the duration of radiation treatment is linked to the acute side effects. So the duration was only 1 week, so we didn't see they didn't see any side effects with the 1 week. So these side effects we didn't see. They didn't have to see. Yes, with 1 week, you don't have to see these side effects. Patient will finish the radiation without having side effects. And then the breast shrinkage was the most prevalent, moderate to marked effect at 5 years. Comparing the 2-5 fractions, because they did two fractions. There was 26 gray and then 27 gray. So the 26 gray had a significantly lower risk of moderate to marked normal tissue effect at 5 years after radiation. So the study limitation, one of the study limitation is the dose to organ at risk. One of the most very important thing is the heart. It's undoubtedly sensitive to the total dose, but the number of cardiac event prevented any meaningful analysis. Though we're using the deep inspiration breathing technique, which exclude the heart markedly from the radiation field, so we don't have to really worry about the heart as much. So in conclusion, 5 years ipsilateral breast tumor relapse incidence after 1 week course of radiation treatment is non-inferior to the standard treatment of 3 week schedule, meaning 1 week equal to 3 weeks. So with the consistency of this fast-forward result with the earlier hyperfractionation trial, it supports the adaptation of 26 gray in 5 daily fractions as a new standard of care for women with operable breast cancer requiring adjuvant radiation treatment to the breast. So is this article, is a practice changing? Yes, it is. And luckily, the result of this study came out February 2020, which was the year of the pandemic. So if, as a radiation oncologist, I'll be honest, if this result came out in a different time, we would not be that excited to apply it, but we were forced to apply it because it's better to give the patient 1 week of continuous radiation rather than, because during the pandemic, patients were discontinued if they have to have 3 weeks of radiation. It's either very difficult for them to come, it's very difficult for them to continue sometimes because they would be corona positive, and then they will be COVID positive, and then they will be away. And it's just like, it was a lot of challenges in radiation. So this study just came at the right time, and it forced us to apply it because it came during the pandemic. But you know what? Because we applied during that time, we we were just applying it to whenever applicable to any of the patient, and we had good result. Otherwise, we'd be very cautious and would be not applying it that frequently. So what are the limitations in KSA or in our areas? First of all, that majority of our patients will have advanced node-positive disease who require local regional radiation treatment. And as I mentioned, nodal irradiation were not allowed in the primary study. Now, there is another study working on the nodal irradiation, and we're waiting for it. But so far, we can just apply it to the patient who's going to receive radiation to the breast or chest wall alone with no nodal irradiation, which in our category of patient, not majority. Another thing is the lack of DIBH technique, deep inspiration breathing technique in some radiation therapy department. That will make it more challenge for the hard dose. And then the second thing is a patient age. We have 45% of our patients less than 40 years old. They only represent 2% of the population in this study, but it's still safe. I think we can still safely apply it. So this is our experience at King Fahd Specialist Hospital from October 2020 up until now. We treated 710 patients, and majority of them had advanced disease. So 527 had advanced disease, but among the patients who had early disease just to the breast, who received radiation just to the breast, 182 patients had radiation only to the breast, and out of those, about 35% were treated with the fast-forward trial. Some were excluded for a reason or another. And with those patients, I'm telling you, so far, we did not see side effects at all, not acute. Patient will just finish in 1 week, just go back to their normal lives. And we didn't see any marked side effects. We see them more frequently. We see them every 2 months almost, just to check on them, and they're doing great so far. So I think it's a new standard of care to give five fraction of radiation treatment. I was talking to Dr. Jamal Khadr yesterday, and this is what they're applying also in Jordan. So I think it's going to be just no new standard of care, just to give 5 days of radiation treatment. And hopefully the result of the new study will come with another radiation, allowing us to do also 5 fractions. And then the patient will finish in 5 weeks instead, 1 week instead of 5 weeks, which was just like 4 years ago. Thank you so much.
Thank you very much, dear Dr. Ahlam. I'm really delighted to see such high quality speeches from our local regional people. Thank you very much. Next is Dr. Sébastien Touré. So Dr. Sébastien is Associate Professor in the Department of Molecular Medicine, College of Medicine and Medical Sciences, Arabian Gulf University in Bahrain. He received his PhD in Biomedical Science from University of Montreal, Quebec. How do you pronounce it? Quebec, Canada, in 2003. He published more than 60 papers and 40 abstracts. His current research interests include the characterization of cell signaling associated with gynecological breast prostate cancer, the use of tyrosine kinase inhibitors to prevent cancer development, the development of organoids as models of organ function and disease, the study of microbiome for diagnosis. Please welcome with me Dr. Sébastien Touré.
Thank you very much. Thank you very much for the kind invitation. So we'll shift to completely different topic. It's more like to be entirely basic science, no clinical data on this aspect. So we'll focus on the breast cancer modelization in the laboratory. So now for the past 2 days, we talk about breast cancer. So breast cancer is now the most cancer worldwide across both genders. It has more disability adjusted life years than any other cancer. And majority of breast cancer will occur now in low to middle income countries. So it is estimated by 2040, like 60% of the projected 3 million new breast cancer cases and 70% of the 1 million new deaths will occur in low to middle income countries. So the breast cancer survival probability is 90% in high-income countries, but go to 66% in India and 40% in South Africa. And in sub-Saharan African countries, as well as GCC countries, basically, half of the breast cancer will occur under the age of 50. So this is a case for Bahrain. Basically, it is estimated like in 2020, according to GloboCan, there is 244 cases. And by 2040, this number of cases will more than double. So this study was performed in 2008 and looked at autopsy record of patients from the Boston area and tried to, before the establishment of chemotherapy from 1914 to 1943, and established that breast cancer basically is one of the highest metastatic cancer with 5.2 events per primary tumors. And as well, it is one of the non-selective cancer that can metastasize pretty much in every single organ of the body. So this breast cancer mortality started to decrease after the establishment of adjuvant chemotherapy, adjuvant hormonal therapy, and screening. So this led to drastic decrease of breast cancer cases. But when we consider like metastatic breast cancer, we can see that for the past 30 years and further, there is no real improvement of survival of these patients. So we can say that breast cancer remains a challenge. The cellular heterogeneity of breast cancer still represents a major therapeutic challenge. The mammary glands are highly dynamic organs that undergo multiple phases of remodeling during the lifetime of the woman. And these changes are choreographed by a hierarchical array of mammary stem cells and progenitors. So the diversity of breast cancers has been linked to the cell of origin, while the cellular heterogeneity of the tumor originates in the nature of this mutation. So cancer stem cells have been isolated from breast tumors and implicated in the development of metastasis and recurrence of breast cancer. So this is like, there is two hypotheses for the cellular origin of breast cancer. And these two hypotheses involve either a stochastic model where there is accumulation of mutation from differentiated cells to gives to these cells a pluripotency and the ability to divide rapidly and differentiate as well. The second hypothesis involves a succession of mutation into either stem cells or progenitors. So the mosaic of genetic alteration contribute to the singularity of breast cancer stem cells and ultimately the response of breast cancer patients to treatment. So this is a schematic representation of the hypothetic links between breast cancer subtype and the mammary luminal epithelial cell hierarchy. So we can identify that in this breast cancer subtype, the most aggressive breast cancer, Claudin low, seems to emerge from mammary stem cells, while basal-like subtype will emerge from luminal progenitors, and HER2 and luminal B will emerge into progenitor cells within this hierarchy, while luminal A is thought to deviate from differentiating ductal cells. So the conventional approach for cancer therapy, one size fits all, face major hurdle for the treatment of this breast cancer patient. So the heterogeneity of tumor cells and microenvironment and variability in metabolizing enzyme and receptors promote the differential response. The gene-drug association treatment strategy lack comprehensive understanding of the response to the drugs. So this is why we need better model of breast cancer, at least in the laboratories. So historically, this pre-clinical model rely essentially on cancer cells. And we can see that based on the literature, this cell line established for breast cancer mostly originate from human, but as well were used extensively from mice. It is as well important to identify the source of this cell line. So most of these cell lines in the literature were reported to be, not specified, but when specified, these cell lines were reported to be from ductal carcinoma, as well as lobular carcinoma, in situ ductal carcinoma, and from rare isotype. And it is important to consider, especially for GCC country, where the occurrence of breast cancer happened early. So the age of the patient associated with the development of this cell line are important to consider as well. Another factor to consider for cell line is the cell of line origin and ethnicity of this cell line. So most of these breast cancer cell lines were isolated from primary tumors, few of them from pleural effusion, and after from metastatic site, very few of them. It is as well important to consider that the ethnicity of origin of these breast cancer cell lines. So most of these cell lines were originating from European descent as well as East Asian. And there is no ethnicity related to sub-Saharan countries or GCC countries. So this cell line harbors the majority of functional important mutation observed in the tumors. The DNA methylation profile shows both similarities and difference to tumors. The cell line do not represent all the molecular subtype of tumor. Majority of this cell line rely on two cellular model, which is like represented here. So most of this cell line will rely on MCF7, which is a cell line categorized as luminol A, while an MDA MB231, which is categorized as triple negative breast cancer cell line. So the pattern of intratumor heterogeneity are found in some of these cell lines, but not all of them. And the preclinical model of resistance to drug may not directly replicate those found clinically. So this is why it was important at this time to develop preclinical animal models. So most of the models rely essentially on the mouse. So this has nearly 75% of the research. Rapid reproductive rate and short lifespan allows the rapid development of this cancer, and the genome is 98% similar to human. So they started to develop what is called like patient-derived xenograft, and this patient-derived xenograft consists of the implantation of human tissue into immunocompromised mice. So the platform it is a good platform for cancer research and drug development. It is as well a good platform for drug discovery, biomarker discovery, and preclinical drug testing. It allows the identification of interaction of tumor cells with stromal cells, and somehow is able to study basically the resistance mechanism. But this approach is limited by the engraftment, which is very low in some type of tumor. So you have to start with very aggressive type of cancer. As well, like you have to get this tumor to develop within the animal, and this will take at least 3 generations and at least 4 to 6 months. There is no interaction with the immune system because this model relies essentially on the implantation into immunocompromised animals, and it is mostly generated from invasive and metastatic tumors. So further genomic alteration and rearrangement can happen in this animal as well. So this will deviate from the original tumors. So they started to develop a 3D culture system which rely on the conservation of the cell-cell interaction, but as well the conservation of the interaction with the extracellular matrix and possible implementation with stromal and immune cells. So this is an example of breast organoid. So on the left side, you have the normal breast tissue. On the right side, you have like a cancer type of breast cancer. So an organoid is like a 3-dimensional multicellular in vitro tissue that mimics the corresponding in vivo organ. So it can be used to replicate some aspect of this organ in vitro. So most of these organoids are originating from adult stem cells or induced pluripotent stem cells. They can represent multiple and organ-specific cell type with similar spatial architecture. They can recapitulate some key function of the organ, as well as they can be used extensively into cancer and disease modelization in vitro for clinical studies, and they will reflect the primary tumor heterogeneity and fully capture the breast cancer spectrum. So these organoids were used extensively for biobanking, genome editing, modeling editing, and they were applied as well to high throughput drug screening, personalized medicine, and clinical trial. So the nature of these organoids rely essentially on the dissociation of the tumor or native tissue, the placement of this tissue into a niche that contain basically essential factor for the stem cells to replicate and develop into, differentiate into the normal cells from the organ. And as well, we can have like a system where we can induce, using induced pluripotent stem cell, we can induce this type of organoid. So this is few example of organoid generated from primary tissue. This is like, on the left, you have from breast tissue. You can have like colon with microbiome. You can have stomach, liver, retina, brain, and lung. And now in the literature, you can see that more and more of this tissue, like pretty much all tissue, can be developed as organoid. They can represent as well tumor tissue. This is a few examples of these different cancers. And they can be used as well for biobanking. So this is an example of the different type of cancer, and as well service proposed for different company to study and relying on organoid models. So like I said before, these organoids were used extensively into clinical trial in different parts of the world, China, Netherlands, to study different type of cancer as well. And this is like what we started to establish in the laboratory. So the first patient was invasive grade 1 ductal carcinoma, and we conducted the development of this organoid. The second patient that we had up to now, it is invasive lobular carcinoma, and you can see that we developed the condition for this organoid to mature. As well, based on this approach, we were able to identify like specific cell protein expression within this cell line, and to look at the expression pattern of the marker associated with stemness, as well as marker associated with high proliferation. So this is what we wanted to do in the future as well. It's like the ability of this, using this system to manipulate basically the genetic information, either through transfection, electroporation, or lentiviral transduction. So in conclusion, we want to show that studies have demonstrated that the multipurpose nature of mammary organoid, especially in analyzing mammary gland development and tumorigenesis. So when compared to genetic testing, the functional testing on organoid identify different drug and combination response despite similar driver mutation. So organoid can be also tailored therapeutic strategy for older women or younger women, where knowledge is on the disease is limited. So there is still a lack of model representing the deadliest breast cancer, including metastatic tumors, endocrine-resistant estrogen receptor positive, and HER2 positive tumors. So further research should be performed to incorporate multiple cell type in breast organoid as well. Thank you.
Thank you very much, Dr. Sebastian, for this excellent presentation. Next, please welcome with me Dr. Mohammed Imam Subeh, Medical Oncology Consultant at National Cancer Institute, Cairo University, Egypt. Medical Oncology Consultant at Military Wadi Nil Hospital and Dar es Salaam Hospital, specialized in thoracic malignancies, Zurich University, Switzerland. Specialized in lymphoma management, ULM University, Germany. Lecturer of Medical Oncology at Armed Forces College of Medicine, ESMO and ESCO committee team member, ESO ambassador as national representative to European School of Oncology, peer reviewer and Frontier and GCOPA, principal investigator at few clinical trials, founder, CEO of Egypt Support Oncology Foundation, member in many international societies as well. Please welcome with me, Dr. Mohammed. The floor is yours. Thank you.
Good afternoon. First of all, I would like to thank the organizing committee and all the chairpersons, also for audience keeping insight aside. I am Dr. Mohammed Imam. My talk today about lung cancer and recent update. This month is November, the Lung Cancer Awareness Month. So I am lucky to give this talk. First, one of the most important things in management of the lung cancer is multidisciplinary approach. We have a data that multidisciplinary approach improve overall survival. So we should do in this multidisciplinary team to improve the survival and to increase and improve the outcome of the patient. One of the most important things, starting with the biopsy. We should select the markers that to be used for diagnosis and preserve the other markers for more genetic profiling of those patients. And according to the ESMO guidelines, this is the genetic alterations recommended to be done for those patients with non-small cell lung cancer, including EGFR, ALK, MET, TRIT, and BRAF, and etc. And this is the new era for target therapy. To evaluate these mutations, we have different methods. First of all, PCR and immunohistochemistry in sub-alterations. But the most important is the next generation sequencing to do a very comprehensive profile for all those patients. We have two machines to detect either next generation machine for comprehensive approach, and we have a focused approach in using a cartridge to assess a genetic mutations for this, like called indela. This is the lung cancer outcome according to the 8th definitions. As we see, stage 1A reaching at 5 years about 92%, but in stage 4 reaching about 10 to 0%. So we should do more effort to improve the survival and the outcome of those patients. This is diagram shows the difference between the 7th and the 8th edition. Mainly the change was in T2, T1, and T3. Regarding the outcome, I will discuss every stage and I will highlight the most recent update in every stage. Stage 1, 2, 3, this is the early stage. As we saw, the standard of care is surgery, either sleeve lobectomy, or pneumonectomy, or using video assisted thoracic surgery. But what is the new? The new, we have a trial from Japanese trial evaluating less invasive procedures like segmentectomy versus lobectomy in the patient with stage T1A less than 2 centimeters. And fortunately, the outcome was in favor of segmentectomy versus lobectomy in progression and overall survival. And also the outcome in respiratory function was in favor of segmentectomy. And this is now a new approach for those patients. What about what after surgery? We all of us know adjuvant chemotherapy improved in the survival in most of these trials, like ALPI, ANITA trials, with absolute benefit at 5 years reaching 5%. But in this meta-analysis showed benefit in all stages, but in stage 1B is still debatable. Some patients have a benefit and some didn't have a benefit. So we have a CALGB trial that evaluated patients for adjuvant chemotherapy, depending on the size of the tumors, more or less than 4 centimeters, and showed benefit in patients with 4 centimeters more or equal. 5% overall survival, it is still not large. So we need to do more research to improve the outcome of this patient. The first trial is IMpower 10 trial using immunotherapy after adjuvant chemotherapy for early stage non-small cell lung cancers. And this trial showed improvement in overall survival in all groups. even in PD-L1 more or less than 1 or 50%. Another trial that is PEARLS trial or Keynote 091 trial using pembrolizumab as adjuvant therapy, but in this trial, not mandatory to give adjuvant chemotherapy like in atezolizumab trial. And this trial, unfortunately, didn't meet the primary endpoint in the patient with TPS more than 50%. But in overall population, we have agreed benefit in overall survival and agreed benefit in disease-free survival. And overall survival is still mature, and we are waiting for the final result. What about adjuvant target therapy after chemotherapy? We have striking trial called ADORA trial that randomized patient according to EGFR mutations into osimertinib versus best supportive care. We have a significant disease-free survival either in the primary endpoint stage 2 and stage 3 or in the secondary endpoint including stage 1B disease. Which of which to give neoadjuvant chemotherapy or to give adjuvant treatment? We have all these trials that show it the same improvement in overall survival, about 5% at 5 years, like adjuvant treatment, so it is the theme. But we have new trial to compare adding immunotherapy plus chemotherapy as a new adjuvant, and the primary endpoint was PCR rate and event-free survival and met its primary endpoint. Second thing, it is locally advanced disease, stage 3A, B, C. We all of us know the standard of care is concurrent chemoradiotherapy and have a more overall survival benefit compared to sequential approach, even at 5 years and reaching about 4.5% at 5 years overall survival. The new data from Pacific trial after ending concurrent chemoradiotherapy and randomized the patients according to PD-L1 status to durvalumab and placebo, and this trial showed improvement in progression-free survival at 5 years at we see median progression-free survival 16.9 versus 5.6 months, and also showed improvement in overall survival at 5 years reaching about 47.5 versus 29.1 months. What about the advanced stage? This is a dismal disease, and this is no new improvement, but now we have a lot of developmental drugs to improve the outcome of them. Also, all of us know the platinum-based chemotherapy is the standard of the care, and there is no standard platinum-based doublet for metastatic outcome. But how to categorize those patients? Patients either have a driver mutation or don't have a driver mutation. Patients without driver mutations, like we can categorize them according to the percentage of PD-L1 more than 50% or less than 50%. Single agent immune checkpoint inhibitors is very enough for those patients with PD-L1 more than 50%. And we have another alternative like combination with other chemotherapy or combination with other immunotherapy. And in PD-L1 less than 50, it is debatable about the role of the single agent immune checkpoint inhibitors, but we have a lot of alternative. This is the trials that showed improvement in the overall survival in patients with PD-L1 more than 50% regarding atezolizumab and pembrolizumab and similumab, especially in smokers. Now, there is no need for adding chemotherapy in patients with more than 50% PD-L1. Another trial, CheckMate 227 trial, we have a 4 years follow-up and showed a role of immunotherapy, either combined immune or single agent versus in the chemotherapy, and showed improvement in overall survival regardless of PD-L1 status. Another trial just to opiate and ablaze the resistant mechanism to immunotherapy, especially in the first 6 months, by adding a short course chemotherapy for 2 cycles and then continue immunotherapy combination, Nivo, EB, and showed improvement in overall survival. What about second line? All of us need the standard of care is docetaxel versus best supportive care, but we have 2 more trials using antivascular endothelial growth factor receptors, either TKI or monoclonal antibody like nintedanib and ramucirumab, and both showed improvement in overall survival, especially in ramucirumab monoclonal antibody. And this is the trials that showed the role of immunotherapy as a second line regarding atezolizumab, nivolumab, and pembrolizumab. What about the driver mutation? This is the pattern of TKI of genetic alterations. The inner circle is for European countries, and the outer circle was for Asian countries. And as we see, we have 46.3% of EGFR mutations in Asian, more than the Western countries. According to the ESMO guidelines, this is the target therapy used, either ALK rearrangement. We have first and second and third generation could be used. Also in the BRAF and the BRAF mutation, we have the dabrafenib and the trametinib. Also in ROS1, we have acrizotinib. In EGFR, we have a first and second and third generation, plus or minus adding bevacizumab. But what about after progression on EGFR? Depends on the site of progression. Is it is oligoprogression or systematic progression? If there is any mechanism of resistance to the TKIs or not, and this is the algorithm. This is very important trial recently published that showed presence of T7 EGFR mutations in patients with non-small cell lung cancer and also in the normal lung tissue. And this is elicit a very important question for early detection and preventions for lung cancers. And we are doing more research on this data that published the last year. Another phase from EGFR mutation, exon 20 mutations, there is no effective first and second generation TKIs, but we have mobocertinib and amivantamab could be active in those drugs, and still chemotherapy is very important. What about resistant mechanism to the osimertinib that is become the standard of the care in the first line? We have different mechanisms, either transformation to small cell lung cancer and the chemotherapy is the standard of care, or we have off-target, on-target, and bypass, and I will highlight the most important trial for this. The first trial is IMpower 150 trial. In those patients who progressed on TKIs in the first line, we have a new drugs combination of chemotherapy plus bevacizumab plus atezolizumab, and this is the first trial that showed the role of immunotherapy in patients with driver mutation. And this trial showed improvement in progression-free survival, but no improvement in overall survival. Another off-target mechanism, this abstract showed the use of santilimab plus this in the combined drugs plus chemotherapy in patients who have progression on EGFR TKIs, and this trial showed improvement in progression-free survival and response rate as a primary endpoint. On-target resistant mechanism, we have two trials. First trial, amivantamab plus lazertinib in patients with EGFR mutant non-small cell lung cancer. Those patients ended TKI and then received the chemotherapy, and this is what we see in our clinical routine practice. And this trial, Chrysalis trial, that showed a response rate about 33% and made the primary endpoint, and we need more validation for the result regarding the overall survival. One of the most important target mechanism, presence of this mechanism of resistance, C797S mechanisms, but not only presence of this mutation, it means it is a resistant mechanism. It depends on which allele it occurs in, and it depends on depends on the sensitivity. If it occurs in a different allele, it is still sensitive to the first and the third TKIs. But if in the cis position, it will resist to, and we need to research for more target therapy. What about the bypass mechanism? By developing a new bypass pathway, this is trial called INSIGHT-2 trial The patient who developed the MIT amplifications were randomized to tepotinib plus osimertinib, and the primary endpoint was overall response rate. And we have about 54% response rate either in the both group in MIT amplifications and either detected by NGS or immunohistochemistry. Another trial called the TATON trials that evaluated the role of osimertinib plus savolitinib and MIT primary endpoint regarding the response rate. All these trials, I don't comment on this, like are ongoing trials to evaluate more overcoming the resistant mechanism of this. Coming back to exon 20 mutations, in green line, this is the standard mechanism of mutations occurred in exon 19, but a little bit exon 20 insertions could be present. And this review showed a new TKI generations and a new monoclonal antibody to overcome this resistance. What about the rare mutations? We have a KRAS mutations. It is undruggable mutation, but now it becomes druggable mutations, and we have a lot of trials going on this. KRAS mutations occurring in 30% of mutations. The most common is G12C, and most commonly occur in older patient and adenocarcinoma, but HER2 amplification or HER2 activation have a different mechanism like amplification, mutation, and overexpression. Coming to KRAS mutations, this is trial could break 200 trial, phase 3 trial comparing sorafenib versus docetaxel and showed improvement in progression-free survival, but no improvement in overall survival. This is another drug, adagrasib, more selective for this mutation, G12C mutation, response rate reaching about 43% with progression-free survival reaching 6.5 and overall survival near 1 year. And this is all trials ongoing regarding the KRAS, the mutation. Regarding HER2 mutation, we have different mechanism of activation, either protein overexpression, gene amplification, or mutation. And we have a different target therapy like TKIs, like antibiotic and antibody drug conjugate. And the most important one is trastuzumab deruxtecan, either in amplification or in the mutation. And this is the trials that had a breakthrough FDA approval, trastuzumab deruxtecan, with a marvelous response rate regarding lung 01 and lung 02, also comparing the two doses of trastuzumab deruxtecan and which is the most effective. Now we have also apazotinib. It is under review and will be announced in this month, 2022. And we have two trials that evaluating role of trastuzumab deruxtecan either in combination with immunotherapy or not in the first line therapy. So HER2 exon 12 mutation is a targetable and druggable mutation. Trastuzumab deruxtecan approved and apazotinib under review, combination being tested. What about the MIT deregulated non-small cell lung cancer? Like we have different also mechanism of alteration, either exon 14 mutation is the most common and the most targetable, and also MIT amplification or MIT overexpression. It is more common in elderly patients more than 75 years old, in non-smoker about 50%, and more common in non-squamous, especially in the sarcomatoid histology. This is all the drugs that active in MIT amplification. First, non-selective like crizotinib, but we have a more selective and more CNS penetrations like capmatinib, topitinib, and savolitinib, and glometinib, with median progression-free survival reaching 1 year and overall survival reaching about 2 years. This is a monoclonal antibody, amivantamab, that could be used in case of resistant mechanism, as mentioned before, in patient in EGFR TKIs. And this is a new trial that is still ongoing trial evaluating the role of Teliso-V in MYC overexpression trials. The last one is ARET fusion non-small cell lung cancers. Also the same, it occurs more commonly in adenocarcinoma patients and never smokers with 62 years old median age of those population. And the most common alterations and have a worse prognosis is NIF 5B rate mutation. This is the trials that could be used as a second line with good overall response rate. And also this trials was evaluated in clinical phase 3 trials in the first line, Liberto trial and Achille trial rate, evaluating pralsetinib and salpercatinib and met a primary endpoint. My take-home message: multidisciplinary approach is very crucial in management of non-small cell lung cancer and showed improvement in overall survival. Early stage non-small cell lung cancer, especially stage 1A, segmentectomy is superior to lobectomy with a better post-operative respiratory function. Adjuvant atezolizumab improved disease-free survival and overall survival compared to placebo. Adjuvant durvalumab, I think we missed the slide. Durvalumab as a consolidation after concurrent chemoradiotherapy in stage 3 non-small cell lung cancer showed better overall survival at 5 years. Immunotherapy showed a better survival benefit in metastatic non-small cell lung cancer without a driver mutation. New TKIs with more CNS activity were developed and enrolled in guidelines in non-small cell lung cancer with driver mutation. And thank you for your attention.
Thank you very much, Dr. Mohammed, for your fantastic presentation. And actually, I have a special interest in lung cancer, so it was very enjoyable for me. Now, ladies and gentlemen, we have, unfortunately, we have come to the end. And so we will conclude our 2-day conference. And I'm grateful for everybody who took the effort and participated in our conference, and looking forward to welcoming you again in Bahrain and more events. Thank you very much.
Thank you. Thank you.